Everyone, I declare open this hearing of the Senate Community Affairs References Committee's inquiry into the Supported Home Program. I begin by acknowledging the traditional custodians of the land on which we meet and pay my respects to their elders past and present. I extend that respect to Aboriginal and Torres Strait Islander peoples here today. The committee will be conducting today's hearing via video conference and in person. I'm Senator Penny Orman-Payne, Chair of the committee, and I have with me Senator Askew and online Senators Ananda Raja, Antic Whittaker and Ruston via video conference. These are public proceedings being video streamed live via the Parliament's website, and a Hansard transcript is being made. I remind all witnesses that in giving evidence to the committee, they are protected by parliamentary privilege. It is unlawful for anyone to threaten or disadvantage a witness on account of evidence given to a committee, and such action may be treated by the Senate as a contempt. It is also a contempt to give false or misleading evidence. Witnesses also have a right to request to be heard in camera. If a witness objects to answering a question, they should state the ground upon which the objection is made, and the committee will determine whether it will insist on an answer, having regard to the ground which is claimed. If the committee determines to insist on an answer, a witness may request that the answer be given in camera. I remind senators of their obligations under the Behaviour Code for Australian parliamentarians to treat witnesses with dignity, courtesy, fairness and respect. And I remind committee members and witnesses who are appearing via video conference and who are not speaking to please mute your microphones. I now welcome Professor Gannon. Thank you very much for appearing before the committee today. I understand that information on parliamentary privilege and the protection and obligations of witnesses giving evidence to Senate committees has been provided to you. For the Hansard record, could you please state your full name and the capacity in which you're appearing today?
Thank you. My name is Brenda Gannon. I'm a professor at the University of Queensland.
Thank you. I'm now going to invite you, Professor Gannon, to make a short opening statement, and then we'll go to Senators' questions.
Okay. Good morning, committee. Thank you very much for this invitation today. It's a real pleasure and honour to be here to share with you some of my research and findings that I have put forward in the submission that you have read so far. So just to recap on that, and first of all also to let the committee and participants know about my experience in this field. I'm a professor in health economics, focusing on health and social care, and particularly ageing care, and with another focus on dementia care as well. Here in Australia for the last 10 years, and have written many papers on using data from Australia and previously across the world in Ireland and the UK. I'm also a member of the Global Observatory in Long-Term Care, and within that we are a cross-country collaborative, and we analyse data and issues in long-term care, and particularly with the current trend towards integration of health and social care together. Our involvement and our work also involves many consumers, and generally the questions that we answer are created by consumers, they're raised by consumers, and we work with them in analysing the data. We present findings to them, receive feedback and ensure they are incorporated all along the way. And this is really important that they have a voice, and it's great to see so many consumers involved in this inquiry as well. So in relation to my response, I focused initially on access to services and thin markets. So there is a little bit of evidence in Australia about inequity in access of services to GP services, aged care services across the board. But there had been little work done on the aged care sector. So in the last few years we have concentrated on that, and we published a paper that really highlighted inequalities and inequity of access to care for older people. And this was particularly evident across different income distributions. So lower income people were more likely to avail of primary care services and also hospital services, so missing out on intermediary care. However, people on a higher income, older people on higher income, were more likely to use specialist services, private care services as well. So this is an inequity across the board, and when we went further into this, we found that this really is exacerbated in rural regions. It is also a bigger inequity for people with lower levels of education, particularly maybe secondary education, high school education and below. And these are all factors in isolation also for men as well. And that is actually due to the fact that the inequity is really across in rural areas compared to more urban and regional areas. In the response also, I focus on the need for better training and the need for placements for students who are trained in aged care. And since in the last year, there is really a renewed focus on providing more education services for students in training for the care of older people. However, this is new, and it's particularly important that these opportunities are not just focused on one sector, but also equitable across for aged care sector as well. I also, in my statement, focus on regional versus rural areas, and particularly that there may be more large-scale providers in the more urban areas compared to rural areas. That doesn't mean people don't get services. There are service outlets that are spread across the areas that then the headquarters might be in a regional area. But it still does create a distance divide, and people have to rely more on their family, and there are travel costs involved. And if they do not have those people nearby, then they are less likely to receive care. So there's an inequity there in terms of from a supplier side approach as well from the firm, from the provider provision and where they are actually located. In terms of tin markets also, pricing is really an issue, particularly if we bring in standard economics from health economics into aged care sector. Often across the board we would look at market economics and say demand and supply equal, we have prices. But that does not occur in health and ageing care because there's a lot of uncertainty involved. And due to the breakdowns of the markets there's government intervention, which is exactly the home care support and other interventions. However, there's always an issue there of uncertainty going forward, and is supply driving demand or is demand driving supply? And it's an ongoing ball rolling of ensuring that there's enough care there for people. So we cannot apply standard market mechanisms to get the price, so there is a bit of trade-off involved in terms of where are the best prices and what are the actual costs involved. And a lot of economics focuses on cost effectiveness of services. And an example I'll give that I alluded to in my statement was that we looked at cost effectiveness of an occupational therapy service for people who had dementia or who had mild cognitive impairment. And in that, we found that it was cost effective, but not for everybody. It was cost effective for particular ages. But what I really want to highlight there is that the price that we looked at was not actually the price. It was the cost involved of providing the service. And that cost was around $100 per hour. But when we look at a survey that was issued by the Department of Health and Aged Care last February, the average price that was found from the survey to those providers was between $140 to $220. So that immediately means that a person cannot avail of the service that was deemed to be cost effective, but then when they go to look for the service, the price is actually higher. So I would say that in a cost effectiveness analysis, the cost benefit, we have to not only look at the healthcare sector and the health provision, but also the societal side. And that is something that we are more cognizant of now when we look at cost effectiveness analysis. We also look at including the societal side, the burden on the carer, the burden on the family and the person themselves. And I just want to conclude. I have many things to say and I look forward to your questions, but I just want to conclude about the transition to the support at home care at the moment is quite troublesome for many. And this is not new. Any change in policy will lead to distress, and we would hope that in another year or two that adjustments are made and that people are more comfortable with new policies. In the meantime, there is a distress, and that's what we found before when we looked at the changes to consumer direct care. But we have to think also about how we value people, and this is where consumers comes in. And I'm a consumer. Everybody here is a consumer, either now or in the future. And we have to think about how do we value people. It's not about putting a monetary cost on. It's about their perceived quality of care. So when we look at cost per quality, it's not actually just that quality of provision, it's about how people perceive they are valued and how they are looked after into older age and respected into their older age. And look and embed there the culture of respecting elders as well. So the focus may be better, take some money that may have been saved into prevention, reablement where necessary, that is investment of people into the future, and at all times involve consumer into our economic analysis. Thank you.
Thanks very much, Professor Gannon.
I'll start. I know Senator Ruston's having difficulties getting onto the computer, which is she's actually just come on. But I'll just ask a couple of questions and then I'll go to her for one. But first of all, you're just talking about there the cost variation. So when you're talking about the difference between the $100 for each of those items and when you go to market, it's $140. Is that, how does that impact in regard to the consumer being asked to provide the extra difference? Is that sort of what you were alluding to?
Yes, I think if they if the price is actually $200, for example, but the real cost of provision, then the centrepiece is either a profit or it's additional money that may be needed maybe for travel that might not be incorporated sometimes into cost effectiveness. It may be some administrative costs. So what I'm saying here is that if they have a budget that in theory says they can get this 2 hours of occupational therapy per week. In fact, they may only be able to get 1 hour of occupational therapy a week. And that actually then, in another analysis I did, that would spend their whole budget. That means they cannot do anything else. If they were to get 2 hours of occupational therapy a week at that price, if they were on a particular level of home care package, for example, the lower level, maybe 1 or 2. If they're on higher levels, yes, then they'd have more money to spend. But the gap is either affordable and is paid for out of pocket, or is unaffordable and people forego that extra hour. And that means then that services like the ones that we have evaluated are not possible. So they cannot get the full benefit of the service they want to, and so it cannot be guaranteed that they're going to get the full outcome in terms of their independence. And we know that support at home is about supporting independence as opposed to treating health conditions.
And the biggest issue then, if they've expended their budget too early, they're going to go months without that actually receiving the treatment. I've just got one other quick question because I'm conscious that Senator Ruston will have questions for you as well. But in your submission, you were talking about introducing intervention caps or subsidies to reduce the out-of-pocket costs. I just wondered if you could elaborate a little bit further on that.
Okay, in thin markets where services are not actually readily available, there are some supported home grants for thin markets, and so that they can be given to the providers to help them to boost up the services if they are in that space already. Subsidies and caps, I think, the subsidy should be to the person themselves, I think, rather than to the providers, in order to try to boost up their ability to pay for a service. I think there should be price caps on various services, because otherwise these prices, they will vary across different providers, they will vary across regions, they will vary across localities. So if there was a certain price cap that after that it's not feasible for anyone to pay, whether it's government or person, perhaps that could be a way of dealing with the market.
So if you put a price cap, though, the tendency would be for everybody who could afford to deliver it cheaper would be to take it to that level. Sure. But then what happens then with the ones that are, where there is genuine need, and there is the exception in the, those thin markets and the more remote and regional areas, how would you deal with that? What would you suggest?
That is a fair point, and that is the argument at the moment against price caps more generally. But maybe if they're incorporated into the local thin markets support at home, the subsidies, the extra grants, there's an extra grant available. It will require more administration by providers and people. They will have to apply for this. It's from the provider level. That may be a way of differentiating across markets. It's not the same in a rural area, a regional area, and a city where things are a bit more accessible, perhaps, where people may have transport and buses or less distance to travel at least. So there are inequities across the board, so perhaps maybe there should be variation in prices as well.
I'm sure the questions will continue. I'll accept. Okay. Mind you, I think she's dropped again.
We had Senator Ruston, but I think she's gone. So did you have any additional questions?
I was just writing notes before. Well, I've lost where I was scribbling now. You go.
Yeah,
actually,
okay.
there it is.
I'm interested, Professor Gannon, in your comments around the fact that you're hearing a lot from people who are using aged care services, and there's a level of distress out there. I'm just wondering if you could speak to the sorts of things that people are talking about are the source of that distress.
Okay, I'll just reflect back briefly on the study that we did, which was looking at, we had to measure psychological distress outcome as the variable, and we measured the impact of changes in policy on that. And that measure is about it just being the ability to cope daily, the ability to be involved in daily activities, just general distress levels of a mental health state. I read a lot about this. I listen to a lot of various aged care groups, and yes, there is a lot of distress. I've also read some of the submissions to this inquiry and read individual levels, particular personal accounts of distress. So I'm not actually going out surveying people as such. My work is more quantitative than qualitative, but I do incorporate that thinking into the interpretation of my results. And for sure, people are distressed because it's confusing, changes of rules. It's distressful to think if, and stress can also, it can be, it can have a knock-on effect if one family is finding something distressful, and then the next person is thinking, well, when I need that, what am I going to do? So and there's a lot of discussion around the country at the moment about this. So it's quite out in the open that these changes, and it's great. It's great that there's such discussion. So that is the level of information I can give you on that.
Mm-hmm. As someone who's been looking at the economics of care for quite some time, I'm interested in your evaluation of, are there other models around the world? Like, designing supported home in the way that it's been designed is one way of doing aged care in the home. Are there other models around the world that are doing a better job, and are you able to explain what it is that makes them different to what we currently have?
Okay, that's a really interesting question. The move around the world, and here as well, informally, is towards health and social care integration. So that's the bigger picture, and that's what really interests me. And there has been minor moves to this in other countries, and some are at different stages to Australia. For example, Ireland, where I'm from, they don't actually have a statutory right to home care, whereas Australia does. And I actually think that that's the right move in Australia, putting a legal framework around it. Particularly in the age of, there's now the UN Charter of Rights for Older People, and that's coming on stream. So going back to around the world, various places have tried to integrate health and social care to make it more flexible, to have a one-stop shop where people get assessed and whereby their needs are formulated. The outcomes are a little bit trickier to evaluate. I think they're in early stages. However, what I do think is that there's a perceived quality benefit to people. People see it as a better thing for them, and that in itself is a good result. Then if we focus on more the Nordic countries like Denmark, Sweden, they have great systems, particularly Denmark, where they have integrated health and social care. The care is quite often from the public sector rather than just the private, and it's a mixed bag of both. And it's also funded through taxes, large taxes that many people are not happy to pay. So always, from an economics point of view, we're in a resource allocation, one pot of money problem. So I believe that the system here is going in the right direction. And I think the idea of what's happening at the moment, integration of health and social care, a one-stop shop, but the implementation of it needs more work yet. For example, the assessment, the IAT, this needs a lot more thought through. We cannot assess anybody's needs, particularly older people as well, on the basis of just an algorithm of criteria. It definitely needs human oversight. And that's something that's happening around the world. There's a human oversight into the assessment of needs. The funding is more so a mix of tax, a mix of some out-of-pocket payments, but generally not. And in the Netherlands in themselves, they spend up to 4% of their GDP on aged care. Denmark is lower, Ireland is around 1%, and Australia is even lower again. So if we think to the future, perhaps maybe a higher spend, maybe not. There's quite a lot being spent already. So maybe a more efficient use of the resources and a rethink of how the resources are being used and focus more on prevention of care and the idea of home care is to try to keep people out of residential care longer, as long as possible, if ever, to try to keep them at home, to keep them independent. And that's the focus of home care around the world, is on independence as opposed to a last stop, a last resort of care. So we need to rethink and focus that home care is not the last resort here. It's nearly an investment into the future, a reablement, preventative strategy for somebody who may have not huge needs, minor needs, but if they get the care they want, they are functional and can live at home and be independent, they may never reach the stage of residential care where there's huge costs involved. So that is the pathway, and that is the wish of many countries, but how they're getting there, they're all on different journeys. And so the race is to ensure that we get this in place before the populations get older and older. And I do not think that it's an aging, we can never say it's the aging population, it's the problem, it's the systems that are in place to help the aging people.
Yep, and we certainly saw that in Singapore where they've, really planned for it. Active ageing centres, people turning up over 60 for free, keeping them active and enabled. And yeah, I think that's the goal.
That went with the social care and healthcare that you talked about earlier. That's exactly what we witnessed when we were in Singapore and Japan.
And from a funding point of view, it's very hard to integrate health and social care. Because of the different systems involved. But we can only try to do our best and go with what is there. It's there, the differential between health and social care, but try to bring them closer together and try to not have duplication of assessments if possible as well. And that all comes down to workforce. It won't happen without people. People are being assessed for home care support, more so in the last year, but there's nothing there to fill that gap of what they need because of workforce issues, and particularly in more rural areas as well. So there's an important need to focus on workforce and also regulation as well. And make that regulation not so cumbersome that small providers are put out of the market and becomes quite stressful for the provider as well.
Do you have any more questions? Because I'm conscious I'll need to go down.
Sure, Anne's on.
Is Anne on?
Anne's on there, yeah.
Oh, sorry, that's the big one in the middle. We've probably got 5 minutes, Senator Ruston, and then I'll need to go to Senator Whittaker.
Okie dokie, thank you. Look, thank you very much. I'm sorry I missed part of it because I was having technical problems, but I was just really interested, Professor, in your comments around prevention, and just wondering, do you think the current system as it is designed is geared towards incentivising prevention as a core part of the delivery of care? And, if not, what do you think needs to be done from a systemic point of view in order for the rhetoric to actually be matched by the delivery mechanism?
Oh, thanks for the question. The move towards prevention is beginning. It's not that it hasn't happened yet. It's starting, but maybe it's not equitable to everybody. Depending on what we think is prevention. Prevention is everything really. When we look at, say, prevention of dementia or delay of prevention. Prevention is everything from nutrition to exercise to home supports, maybe assistive technologies. And so to do that more widespread, all of these various interventions that are ongoing at the moment in different pockets of the country need to be more scalable solutions, and they need to be at a higher level. So maybe that some savings that may be made in moving from provider to consumer-directed care, or even not there, or saving somewhere else, could be directed into prevention more broadly, and try to boost up that for all ages, particularly as they get older. Ageing begins really early in life. It's not just at 65. So prevention starts much earlier, and to not rely on just clinical assessments, but to rely on just invest in that prevention, invest in good health behaviours. And I think we're seeing more of that these days as well. But it does require a little bit of funding, and that's what I see as prevention. And with the community home support package, I think that's great, because that will help people, hopefully, to remain independent. They may have some needs, and if they can remain independent and have some preventative strategies in there from some services, allied health services that can come into the home, then that might even delay them going on home support in the first place. But home support is a cheaper. It's cheaper than residential care, to put it crudely, and it's something that people want anyway. Everybody wants to age in place and age at home. And so prevention is key to the future of health, and also it's key to ensuring that the services are in place and that there's not overuse of services before they're actually needed.
Yeah, look, thank you. I think my question was more around, what do you think in terms of structural or systemic change needs to occur in order for this to become a prioritised part of the ageing process? I mean, I think we all know what the problem is, but I'm just sort of keen if you've given any thought to how you would go about changing the way, and obviously government's the big player in this marketplace in terms of that's where the money comes from, so that's where the incentive is driven from. What would you change as opposed to what's happening now in order to deliver this person-centred care, this sort of prevention prioritised care that isn't happening now?
Okay, yeah, it would be a huge change, and more integration of health and social care would help that. More involvement of consumers and their actual needs would help that. So learning from what we see now in terms of what are people using home care support for, learning from that, and then rethinking back what is it that would be needed. I'm not a clinician, but I'm thinking back of what would be needed to try to prevent this. And I'll give one example of a preventative strategy. I was involved in a study in the EU about falls prevention, and this study was actually targeted at 45 age plus. It was called Prevent It, and the idea was to educate people how to do simple things like get out of their seat properly, without falling over, reach for something in the cupboard that may be too high without getting up on a high stool. Simple things in the home. They're preventative strategies as well. It's not about going out and do hardcore exercise or having it will be about having good nutrition, but just simple things, and that can lead to more prevention in the home of falls, of issues in the home, and it can also be cost effective.
So from a financial perspective, because I mean the levers we all know are all pulled by where the money flows, and that's where the incentive. Are we incentivising this sort of primary approach to the ageing process by the way our settings are set at the moment?
I believe that there's some work to be done there in the marketing maybe of the home care support, in that it's not a last resort, that it's something that even we might even want to avoid as well. And so by trying to put the emphasis on more responsibility on the consumers, to become, not responsibility, but have a consumer-led approach to everything. So try to involve people to see what they actually need.
Yeah, I suppose my concern is that with rationing of care, which is going on at the moment, and older Australians are being assessed as needing quite often very low levels of care when they're first assessed, but then they don't get access to that care for many months and sometimes over a year, by which time, obviously, the fact that they're living without the necessary supports means that their care is diminishing. I suppose I'm interested to know whether you think that moving towards a demand-driven system of access to care, so instead of rationing care and handing out packages from a budgetary perspective, what would you see as the value of moving to a system where, when you're assessed as needing some assistance in your life, that you got it immediately before you had your situation deteriorate?
That is a difficult question, and that's what we're watching around the world. So if we look at the Netherlands or if we look at the UK, they are not really at the stage where they can say which is better. We cannot say, is it the provider-led approach or the demand-led approach, unfortunately. What we can say from the person perspective and the demand-led approach is that people may have more, feel that they're more involved in decisions, so there might be a perceived benefit, perceived quality of care benefit. So which is better? I actually cannot answer that right now.
So you're for real saying that you don't know whether people getting access to care as soon as they need it is better than forcing them to wait for that care?
Oh, no, I'm not saying that. I'm talking about the two different systems.
No, I'm talking about the current system in Australia where aged care packages are rationed. If you get assessed as needing a aged care package, you can wait for months to get assessed, and then you can wait for over a year before you actually receive the care that you have been assessed as needing. I'm interested to understand from your economics perspective in terms of the outcomes, and you talked about prevention, and that often meant that it would avoid the more expensive costs of more acute care later down the track. Whether you have a view as to what the cost of rationing care, which is happening in Australia, is on the Australian economy and obviously the people that are being impacted by it. Sorry.
Yeah, sure. Sorry, I may have
question.
misinterpreted the question initially. Definitely, once a person is assessed, there should not be a waiting time list. There needs to be a system there so that they can get those services straight away. Otherwise, it's pointless. So I agree on that. How to actually get to that point may be a re-engineering of resources. Have a look at the efficiency, inputs and outputs, what is being put in, what workforce, what budgets are being spent, and what is actually coming out in the other end. That's a crude measure of what we call technical efficiency. In economics, allocative efficiency is when we might look at prices as well. So preferably we would have more efficiency, more price efficiency. And then secondly, we would want to ensure that everybody who's actually on a waiting list is getting that care immediately, rather than waiting until next week or a year's time as well. So that if I was to say what should be changed, I would say have a look at the efficiency of the system and see, is there any room for improvement in any one of the factors involved in the inputs, and then hopefully that will firstly improve the outputs in terms of number of home care packages available, number of services available, and then the next step is to include quality measures into that as well. So quality measures for aged care also need to be assessed.
Yep.
Thank you.
Thanks, Chair. I'm assuming you're going to wrap me up. I'm happy to keep going if you're not.
No, I'm going to go to Senator Whittaker. Over to you, Senator Whittaker.
Thank you, Chair, and thank you, Professor Gannon, for your time with us today. Your submission talks to the fact that older people and their families are much more involved in the decisions about their care than they've been before. Could you talk to what the evidence says about the difference that this makes in their experiences of the care that they receive?
Yes, sure, thank you. One of the studies we looked at was the evaluation of the change into consumer direct care, and as I maybe said earlier, was that in the initial stages this is quite stressful and leads to a lot of distress in the system. Longer term perspectives on that, we're still working on that to see if that, but any policy change will be distressful in the first year or two, and then people adapt. And obviously inquiries and changes are made so everything becomes a bit more acceptable to consumers. The actual distress to consumers themselves, the evidence I have on that is from what I read. It's not my own evidence. And so I've been reading submissions to this inquiry, and there's a lot of distress. I read various other policy reports, and just general blogs from people on what they believe are the problems in the system in terms of consumer direct care and the move towards that. It does give people more control, and there is a perceived element of control that they're happy with, that they can be more involved. But it does also require a level of knowledge from the consumers and their families to be able to interpret all of that and to be able to navigate it alongside some navigators in the system.
Thank you. I want to talk about aged care workers for a moment. So you talk in your submission that better pay for aged care workers helps alleviate some of the challenges in the industry, but that there's some work to be done when it comes to training. In your view, what would a good kind of career structure look like for a certificate level aged care worker?
Thanks. Yes, we have just started to think about the changes to the structure of aged care, and this is ongoing, and it's already happening in university courses and in TAFE, of more inclusion about aged care and more information about the process of geriatric care. And improved, a lot of them, even though the wages have improved, it's still a lower level career structure unless they can see a progression forward. So just like there would be maybe in nursing industry, maybe there's a way of being able to progress a little bit up the chain in different management structures that would help people envisage a life that they could have in that industry, and also support what they want to do.
I'll just ask one final question just noting we're a bit over time. I guess on that kind of training question, you point to research showing that the time spent on ageing in university health courses varies quite substantially between programs. What do you think it would take to make ageing a core part of the curriculum?
Yes, thank you for that question. In fact, actually, some universities have become age-friendly universities, and in that they make a commitment to ensure that ageing is part of their curriculum. Whether it's happening or not is another question. So that it's a new process, so that needs to be monitored over the next few years. I lecture health economics and always ensure that students are exposed to at least one lecture on aged care economics. In other countries, they have programs certificate level on social gerontology, which means everything in terms of ageing, provision of care, and that also includes economics as well. And that is important because if people are going to be looking after providing home care support or looking after people, there will be a lot of questions to them about finances and economics. So I think it's very important to incorporate that into the learning as well. And we have experience in that. We have experience in working with many different disciplines, ensuring that it's at a level that is acceptable to everybody.
Thank you. That's it from me, Chair.
Thanks very much, Senator Whittaker. That concludes this panel. So thank you very much, Professor Gannon, for providing us with your evidence today. The committee will report to the Senate on the 24th of November 2026. We've agreed that responses to questions on notice should be provided by close of business on Friday the 14th of August, but I don't believe that any questions were taken on notice in this panel. So thank you very much again. And I'm now going to welcome representatives from NIDA Care Holistic Health Services and Healthy Ageing Partnerships, who I believe are appearing via video conference.
Good morning.
Good morning, everyone. Thank you very much for appearing before the committee today. I understand that information on parliamentary privilege and the protection and obligations of witnesses giving evidence to Senate committees has been provided to you. For the Hansard record, I'm going to ask you to each state your full names and the capacity in which you appear today, and I'll start with those people who are joining us online. So if you could state your full name and your capacity.
Good morning, it's Cheryl Harris and I'm President of Healthy Ageing Partnerships.
And in the room?
Chukwemeka Edwin Nweze. or Emeka is my preferred name.
Yes, and your capacity that you're appearing today?
I'm the CEO of Netacare. I will be answering to the questions based on my submission.
Great, thank you. I'm now going to invite each of you to make a short opening statement before we go to Senators' questions, and noting that time is short, so if you could keep those statements reasonably brief. I'm going to go to Healthy Ageing first online.
Thank you, Senator. Healthy Ageing Partnership is a group of health services, councils, aged care providers and community organisations working together to help older Australians stay healthy and independent at home. We support the goals of the Support at Home program, but we're worried some parts of it could do more harm than good. We believe you need to get help early. Things like help with cleaning, transport, or just checking in socially is what stops small problems becoming big ones. But strict budgets and rigid categories could make it harder to get that early help, especially for people who are frail, having memory problems, or don't have family nearby to help them navigate the system. In regard to digital access, the system leans heavily on digital tools like the My Aged Care website. That shuts out a lot of older people who aren't comfortable online, don't speak English well, or have memory difficulties. We want proper phone and in-person options, not as a backup, but as a normal way to access care. And we want funded people whose job is simply to help older Australians find their way through the system. When people have to pay more for everyday services like cleaning or meals, many on fixed incomes just go without. That doesn't save money. It just means they end up in hospital or aged care sooner, which costs a lot more. In regard to pricing and value, letting the market set prices makes it hard for older people to know if they're getting good value, and some providers may chase the most profitable services rather than the ones that actually help most people. We're also hearing early signs, including reports circulating in the community, that some people moving off the old home care packages system are losing services or paying more. We would like guarantees this won't continue and that the rural and remote areas where there aren't as many providers to choose from get proper support so people there aren't left behind. This program should help older Australians stay well and independent, not push costs and risks onto them or onto hospitals down the track. Thank you.
Over to me now?
Yes.
Good morning. Good morning, Senators and committee. I do apologise. I had to take off my jacket, getting a bit hot. My name is Emeka. I'm the CEO of Netacare. We're an organisation that provides a wide range of healthcare support as a holistic health service provider. Our methodology is to deliver all of the care under the one roof, almost similar to the hospital. In that way, the person receives the best kind of care like they will if they go to the hospital and everything is there. We had our recent exposure to the aged care system through the CHSP model, and that's been quite the journey. It started with us being funded initially for a year. It took us the better part of 3 months to try and understand how to actually make the services work. Why? Because effectively they chose to fund us for areas that were not in our regions of support. So when we did the original application, we told them where we domiciled, which is right here in Brisbane. However, we were funded in remote regions of Australia. So you're talking Northern Territory, Western Australia, South Australia, and some parts of Tasmania. Now, when we initially started assessing the case, we came up against some of the, I suppose, the same issues that every other provider will, which is in these regions, you can't find any occupational therapy or physiotherapy that lives out there. And so, well, how do you provide the only other option was maybe we could do telehealth. And there's a question of how do you provide physiotherapy to a 90-year-old via telehealth? Well, it's not workable. They don't know where their C6 is and certainly can't get to it. So we decided to try something like formulate a fly-in, fly-out service. Now, you need to understand the way the funding model works, and this is directly connected to how supported home has been structured, so do bear with me. The funding model that we provided funded us at $138, at the time $134, it will increase about 12 months later, $134 an hour to provide services in remote regions. Now, so you understand, as a metro provider, we already charged, and we are not the most expensive, at $200 an hour. What others charge is closer to the $300 mark. When we first took the contract, I personally had a lot of conversations with the Department of Health in trying to understand how to work this task that seemingly looked impossible. Because how do you provide services at $138 an hour to this population? Well, the only methodology that could work is telehealth for that kind of money. Now, they said to us, there is a Sorry, Sunita?
I'm just mindful of the fact that we do want to have time for questions, and this is
Sure.
sounding like this is probably quite a long story, and
Yes.
we do have your submission, so I'm
Yes.
just wondering if you could maybe come to the point and then,
Of
and
course.
then we'll go to questions.
Of course. So if I can kind of pull through the timeline and work out, like right at the end, where we have effectively now been disarmed from being able to provide the services because it simply wasn't workable. And after many conversations with the department, it just didn't happen. Now, if providers like us, it's effectively not possible to provide the services because of the cost, under the supported at home model, now the provider can set their price. The difficulty is really two things. If I set my prices, I will probably be charging the real value, which is around $500 an hour. And if I do that, that person is not going to get the kind of care they need. Now, if you look at the new packages, it's somewhere between $11,000 and $80,000. Now, I can guarantee you, if you need me to provide support to somebody who has the same assessment in a regional area, I will be providing approximately half the number of services. Well, that's issue number one, but the other issue is that really the compression of the funding over the time that the person will have it will simply mean that there are just not enough providers that are willing to engage because there is no centralized referral system for supported at home, which is what it needs to be. Otherwise, we're just not going to have a feasible service because the provider needs to market in this region to find people, and then they all need to come to them, which is not possible unless you translate what is CHSP, that original funding model, move that cohort over to the supported at home program in a centralized referral system to the provider. Those two things are the only real way to make this work.
Thank you very much. I'm now going to go to questions. Do we have Senator Ruston online, or have we lost her again? All right, I might go to you, Senator Askew.
Okay, I might start with Mrs. Harris. I've just got moving around my packages here. I'll start with your commentary or your recommendation in your submission, and you're talking about recalibrating the supported home assessment algorithm. Can you elaborate a little bit further on that and what you would ideally like to see that look like?
I think the algorithm, unfortunately, has caused huge sort of stress factors for a lot of older folk in the community, and we really need to be dealing with a human. I think an algorithm cannot make any decisions around that person's emotional or mental health state. And I think even if it comes to assessing somebody, you actually need to be visiting them in their home so that you're able to actually not only find what their physical problems are, but also by actually assessing their home, you're able to tell whether that person is really requiring more assistance than what they say. Most people are very proud and they like to feel that they can still cope, but more often than not, they can't. So I think that we've got to get back to humans and not dealing with algorithms.
Thank you. And do your services that you're involved with, do you do nationally, or is it rural and regional as well and remote?
We're actually doing Sunshine Coast, and we are also now doing a satellite through when we do our forums. And the forums that we hold we've done 2 now on My Aged Care. So the last one we had 40 people at Gympie and we had 20 people at Yeppoon. Our next one we're doing in September, we're actually extending to even more areas. So we are finding that in the rural areas, you are not getting the same support as what you are able to get on the Sunshine Coast. And it makes it very difficult for people.
I thought that might be the answer that you were going to give me, that it was, I think this is the issue, and I think the situation that we're finding through Netacare is I think a classic example. So with Netacare, where do you actually cover now? If you're not actually, you said that you didn't continue with that contract. What areas do you cover now?
Well, we will only be covering our metro regions for Brisbane because we are simply not able to continue that service. In fact, they pulled the entire funding because we were trying to have a conversation to explain that for us to provide the services you're asking us to do, it has to be by 3 times the unit multiplier that you are applying, which means $138 multiplied by 3 to actually provide an hour of services in those regions to provide actual clinical level of care. And that's simply not a conversation they're willing to engage in, and so they stopped paying us.
So what would be the ideal solution? You've actually been through the process of exploring that, providing services into those remote areas. What would you see as the ideal solution?
The ideal solution moving forward, even in supported at home, I believe, does still need to look very similar to what CHSP currently does, but with different measurement methodologies. At the moment, CHSP measures purely numbers, and the incentive there for providers is actually to fake the numbers. The only way you do what they're asking you to do is to say you've done something you haven't done. And we've measured it, and we've spoken to lawyers and all sorts of other people in this area environment, and that's really the only way you can do it. So the measurement needs to be outcome-based, not output-based. Outcome means we turned up, we delivered the care, we provided you an actual report that says what the person needs and what they need next to make them better, and we see that measured improvement over time through the clinical services. The current methodology does not measure that at all, just doesn't allow for it. They just want to know that you've done some hours. And so really, if supported at home, that package from 11,000 to 80,000, that doesn't really do much in terms of addressing thin markets, because like I mentioned before, a provider needs to find usually at least 20 odd people in sort of the same region that require the same service about the same time to make it viable. But if CHSP, you cross that block funding model over to supported at home, you appointed a number of providers for each specific region, you provided them with that funding in a bulk form, you pay them monthly, and you give them the referrals. You control that from a central point, which basically says, well, there is already a system in place for the aged person to go into the hospital, get the referral into what will now be supported at home, and then there is already a team that puts through the referral and assigns it to the provider. We can actually measure that and know, okay, this provider has the last 20 referrals, therefore we need to give it to the next one. You will probably still be able to have market competition, which is what I guess the current system is trying to solve, market competition. You still will have that because you can have more than one. You can have 3, 5 if you need. But you certainly need to change it into that model and have a centralised referral and a centralised funding model and not individualised the way it is.
Okay. Thank you. I'm conscious of time, so I'll hand back to you.
Ms Harris, I'm interested, you talked about the fact that you've been running forums around aged care. Can you just outline, are they educative forums? So is the idea that people come and then you explain how the system works for them?
Yes, absolutely. What we've been doing is we make sure that we get a couple of speakers who would talk through the different levels and the changes that have come into effect. We then make sure we have a panel that is made up of different service providers, somebody who's got lived experience, and of those who attend can then ask questions of the panel, which we would then ensure that are answered. If for any reason, which touch wood up to now we haven't had, but if we cannot answer that question, obviously we would ensure we go back to that person with the correct information. I think one of the most important things is that people are getting the right information for them to be able to make informed decisions around their health and well-being. So whilst we've done that, some of our forums have also been around, driving safely and around the age of when they need to really look at stopping driving, or their doctors have advised them not to drive. We've also done things around brain health and well-being. And I think as a consumer myself, one of the most important things is for us to be able to get the right information. And I know it's a very difficult thing. A lot of our service providers at the moment are really trying to get through their daily load of work that they've got to do. And I think when we talk about stress, there's stress on both sides. There's stress from our consumers, but there's also stress that's going on with our service providers. So I think we have to be conscious of both.
You talk about in your submission about the need for place-based funded navigation roles. Can you speak to, and I note that the ABC is reporting today on the story of a family that's just found the whole system so complex that they had to engage a broker to navigate it. What are you hearing from people in terms of the way they're interfacing with the system and the ease or difficulty of that?
The majority of people are finding it exceptionally difficult to access either the services or the information that they require. And I think our idea, which I know I've submitted to the Senate, around trying to have a hub of some sort, and also a mobile unit that goes out to outlying areas, I think that would be of a great benefit to them. I think when it comes to placements, they're not enough around for our community at the moment, and I think that we've seen that by the long waits that people are having. You've got people who are dying before their placement comes through, which is something we shouldn't have. We're a first world country, and that should not be happening today. We have to find easier ways of being able to deal with what our community are requiring. I feel quite strongly about that as a personal issue, because I think we're dealing with people, we're dealing with emotions, and we've got a lot of our community who have no families to be able to help them when it comes to finding a placement or going through all the paperwork. And if I could just mention at the same time, we have, as you know, where people can apply for aged care financial hardship assistance. I don't know if any of the senators are aware that's a 16-page document. That is absolutely ludicrous to expect somebody to try and navigate when, as I said, they may not have family, they may not have anyone who could advocate for them. So we have to find better ways of doing things.
And excuse my ignorance, but is Healthy Ageing Partnership, is it a not-for-profit? Does it get government funding? How does your organisation operate?
At the moment, yes, we are a not-for-profit. We receive no funding at all. It is something that we really would love to find, that we can get funding. And all of us who are on our board are volunteers, and because we work collaboratively, because to me that is the future of how we should be working, is we have that collaborative approach. I think what I always say to our service providers is don't see each other only as competition, because what one service does doesn't necessarily mean the other service is doing exactly the same. And sometimes, we all know there's enough work in the industry to be shared. So if you're a service provider and you're not able to help that person, you could perhaps contact one of the collaborative that you're involved in and pass on that information. And I think that's how we have to go forward.
Thank you. I'm conscious of time, so I'm going to go to Senator Whittaker. Oh, doesn't she? Sorry, I'm busy asking questions and not looking at my...
Sorry, yes, no questions from me, Chair.
Okay. I might just ask another question of Emeka. My apologies. What, from your point of view, you've talked about alternative ways of doing things. I guess I'm interested to know what you learnt whilst you were delivering services in rural and remote communities, in terms of some of the changes that made for people who hadn't previously been able to access services. Like what were the gains that you saw people make when you were able to deliver those?
Sure. I'll start with saying that when we first started trying to engage this population in these regions, we had significant pushbacks because they were simply not keen to engage. It took us quite a considerable amount of time to have them engage, and the reason, the most common feedback we got was that they thought we were going to just do it on the phone, and they were not interested. And so after a lot of encouragement, they finally listened to us enough to learn that we were coming out there. We had to do it, we had to come out consistently for weeks before they could trust us enough to open up and let us support them. The changes and the improvements that we needed to see for a lot of these population, they're not that crazy. Clinically speaking, we could achieve most of the outcomes within 3 months, discharge them and move to the next person. Their biggest issue had just been that they just never had it. And of course, they wouldn't, because we're not allowed to fly out there to them, which we will later on learn. We saw that we were, in the time, we probably had approximately 400 odd people, and when we stopped services, there was only about 220. But that is to say how many people we were able to provide the care to, because we predominantly do allied health, provide the care to, see a result, get them the AT or whatever they required, the home modification, and then moved on until the next time that we might get them back in our system. So I think our greatest learning was that if these individuals were able to get the kind of care in the proper form, and the barriers don't exist for the providers, the fruits will be yielded quite quickly. We'll see them remain at home for longer, less congestions in the hospital, and certainly a much happier population that isn't blowing up the senators' phones. I think that was our greatest learning.
Thank you. I'm conscious of time, so unless we have any other questions... No, Senator Whittaker doesn't have any. Can I say thank you very much to Nita? I'm just getting some feedback. I'm worrying that I'm interrupting someone. Thanks very much to Nita Care and Healthy Ageing Partnerships, both for your comprehensive submissions. Both of you have taken a lot of time to give us very comprehensive evidence, and that is very much appreciated. And thank you very much for your time in front of the committee today. The committee will report to the Senate on the 24th of November 2026, so we have a bit of time to run yet. We've agreed that responses to questions on notice should be provided by close of business on Friday the 14th of August, but I don't believe that we took any questions on notice from this panel, so thank you very much for your evidence today.
Thank you.
We'll just suspend for 5 minutes, if that's okay. welcome representatives from FlexiCare Queensland and Catholic Health Australia. Thank you very much for appearing before the committee today. I understand that information on parliamentary privilege and the protection and obligation of witnesses giving evidence to Senate committees has been provided to you. For the Hansard record, if you could each state your name and the capacity in which you're appearing today, and I'm just going to start on this side and work to our right.
Hi, I'm Lincoln Hopper. I'm the Chair of Catholic Health Australia's Aged Care Committee and also the CEO of St Vincent's Care Services.
I'm Alex Lynch. I'm Catholic Health Australia's Director of Age and Community Care.
Adrian Morgan, General Manager, FlexiCare.
All right, I'm going to invite each of your organisations to make a short opening statement and then we'll go to questions. And again, I'll start on my left.
Thank you, Senator. Again, I'm Lincoln Hopper, the Chair of Catholic Health Australia's Aged Care Committee and the CEO of St Vincent's Care Services. Catholic providers deliver around 20% of community aged care nationally, serving more than 50,000 older Australians at home, with an above-average presence in regional areas and among people of low means. Catholic providers are part of the largest non-government grouping of health, community and aged care services in Australia. The care of needs of older Australians, particularly those who are most vulnerable, are central to everything we do. That's why Catholic providers support this reform, and we want support at home to succeed. Our submission and our appearance today reflects that commitment. 9 months into implementation, though, the program is under serious pressure on two fronts. The first is access. 5 years ago, fewer than 200,000 Australians had access to a home care package. Today, nearly 365,000 have access to support at home. That growth is significant and it reflects a bipartisan commitment to home-based care that Catholic providers support. But the system has to deliver that care and keep growing is under serious pressure. More than 100,000 older Australians are on the wait list. The average wait is a year. People assessed as eligible are not yet receiving all the care required to meet their assessed needs. The second area is viability. Data indicates provider margins have been reducing significantly in the lead up to the commencement of support at home, and industry feedback indicates this challenge is becoming more acute in the program's first year. The care management cap was halved from 20 to 10%, despite Stuart Brown's December 2024 survey showing actual care management utilisation ran at 18.7% of revenue across the sector. And the administrative burden of the new claiming, reporting and compliance requirements is extraordinary and largely unfunded. If providers cannot sustain operations, the access problem gets worse, not better. Our submission makes recommendations across access, viability, end-of-life care and the lessons of implementation. I draw the committee's attention to three in particular though: restoring the care management cap to a workable level, urgently examining the deterioration in provider margins before it translates into service withdrawals, and ensuring the assessment tools decisions are transparent, clinically informed and open to professional override. I thank the committee and welcome any questions.
Thank you very much.
Thank you, and thank you for the opportunity to give evidence today. So we at FlexiCare consider support at home represents a significant backward step for the older people it's designed to assist. But this isn't simply FlexiCare's view. I led the home care breakout session at Ageing Australia's recent Queensland conference, a session at which was attended by about 150 aged care professionals and managers. At the start of the session, we conducted an anonymous online survey to test how attendees evaluated the impact of support at home on their participants. 94% rated it as producing worse outcomes for older people, with 57% saying it left them much worse off. Only 4% reported it was beneficial overall. I'm aware this wasn't a scientific study, but in my discussions with people later in the conference, it was clear their responses to the survey represented their honest appraisal of what they saw happening since support at home began. So we at FlexiCare have seen support at home has led to people no longer being able to access services they need, important services being routinely declined by participants, additional anxiety and confusion among older people in combination with increased carer and family stress, people being unable to obtain even simple aids and assistive technology, either at all or within a reasonable time frame and cost, substantially increased costs for older people as well as for the whole aged care system, and a blowout in waiting times for assessments and for the delivery of meaningful support. For older people, it's led to unnecessary and unwelcome admissions to hospital and residential aged care. For providers, it's meant an increasing proportion of their time and resources are being absorbed by cumbersome administrative procedures which have no apparent link to productive outcomes for older people. So, support at home has deep structural problems which we believe will be hard to fix, but we do have specific suggestions which should help reduce many of the negative impacts, starting with a reimagining of the role of support at home. And I look forward to your questions.
Thanks very much. I'm going to go to Senator Ruston first.
Thank you very much, Chair, and thank you very much both for your contribution. And I'm just interested just to unpack a comment that you made in your opening remarks, Mr. Morgan, where you said that support at home is a step backwards, and that in your survey that you found there was a significant number of people said they were much worse off. I'm keen to understand, of the people that you were talking to, my understanding was it was very clear that anybody who was on the old home care packages would be grandfathered as they transferred across into the support at home system. Did you identify in your survey as to which members or participants of the survey were grandfathered people and which people were new onto the scheme?
Yes, so the survey was actually of providers attending the aged care conference, reflecting on their participants. So it's whatever they saw happening to their participants. So it was the providers saying that they believe that the participants that they supported believed they were much worse off. Yes.
So what were the kinds of things that they identified as the contributing factors to them believing they were worse off?
There's a very large number of issues, really, pretty similar to the ones I mentioned that we at FlexiCare had noted. Certainly the loss of access to services, some things which were previously available are no longer available, or because of the costs they cannot afford them anymore.
Okay, so just onto that point, which is my point about the grandfathering. Were your providers telling you that the cost of services have gone up? Because my understanding was that everybody's packages were, if you were on a home care package and you went across to a supported home package, you had your arrangements grandfathered through. So are your providers saying that the loss of access and affordability is driven by the fact that the price of things has gone up? What was the reason why they believed that there was a loss of access or capacity to purchase?
So it's dual. So the price went higher, and I mean the grandfathering only covered people's personal contributions from their own pocket. It didn't actually cover the cost of delivery of services, which other witnesses have referred to as the overall cost of running support at home is much higher than home care packages were because of the administrative burden that's involved in it. But secondly, some services are simply now precluded. So to give you an example would be cottage respite is no longer available through support at home. So it's a combination.
Yep, okay, sure. So basically the money might have been grandfathered as a quantum, but its ability to actually purchase the same amount has diminished, and there are things that are no longer available for them to purchase.
Precisely.
Yep, okay. So to CHA, I'm just interested in your comments around the care management cap. And so in with the change where it's gone down to 10%, what have you done if you believe that obviously there's a set cost that is associated with it? And you said, I think, did you say it was 15 or 18% you believe was about the right amount? Is that correct?
Stuart Brown had assessed prior, Senator, to the change.
Yep.
It was 18.7 across the industry, yeah.
18.7 across the industry. Okay. So in effect, across the industry, we've got an 8.7% shortfall in terms of the cost of administration. How much of that administration cost has increased since the implementation of support at home in terms of the cost of the extra administrative burden?
We know there's added pressure and some of that margin drop that we spoke about earlier, not necessarily just the care management fee, is related to the administration of the new program. So we know that's contributing to it. But I probably would say that you can't halve the funding for the function that keeps people safely at home and expect the same outcomes. And care management isn't administration, it's a mechanism that prevents hospital admissions, as an example. So it's critically important to get that number right.
Yep. So has Stuart Brown done any work to your knowledge or to your knowledge, Mr Morgan, to actually understand the quantum of the additional administrative burden on supported homes so we can get some sort of idea? Because, I mean, obviously, well, I suppose the question then is, of the additional administrative burden, is there anything new in that administrative process that actually would deliver a better outcome for older Australians?
I can't find it. A lot of it relates to just simply new processes that you've got to go hoops to jump through to get to the same place. I don't know about Stuart Brown's data. I think they're due to put out some new data pretty soon in the next few days. Maybe there'll be some information about that. I know from our own organisation we've had to employ several additional people to just handle the administration that came with support at home. Those additional positions make no contribution to outcomes for older people. We're a relatively small organisation, so I think we've put on effectively 3 full-time equivalent people to carry that additional workload.
Gosh, yeah, okay. Well, that might be an interesting question for Stuart Brown. So I think it was you, Mr Hopper, made that. I think it was you that made the comments about the provider margins more generally. In terms of your own organisation, obviously you're a not-for-profit. Do you, I mean, without giving away too much commercial in confidence information, or where are providers, not-for-profit providers like yours, in terms of how close to the edge in terms of profitability on the delivery of support at home?
Yes, thank you, Senator. The most pressing challenge actually for providers is that deterioration in operating margin. A lot of providers who sat broadly in line with industry average before November 1 are now reporting deficits, and that's what's showing up in Stuart Brown. Again, similarly, their data up to December, so we are waiting for the latest showed a drop in margin of 4.4 to 1.7%, so a 60% drop in margin rate there, which just tells you that's actually an industry-wide, not a provider-specific challenge. And so it's significant. It's the most pressing challenge there is in support at home to enable providers to continue to operate.
So you obviously operate a vast range of different sizes of operations, whether they be in rural, regional, remote, as well as city sort of operations. Are you seeing a difference in the profitability and the margins depending on, you know, what the location is?
That would be true because but by virtue of the access to people, resources to be able to deliver support at home, it does vary across regions, of course, but across the sector, And the Stuart Brown took that into account, it's showing that it's a universal challenge. But it's particularly challenging in rural and regional areas, more so and more pressing,
Yeah. So I suppose the question is to an organisation like you, I mean, how much do you rely on the cross-subsidisation from location to location in order for you to continue to be able to provide the services to the people you support?
Some providers, it's the only way they continue to operate. Others might have larger scale and be able to, because of the economy of that. But it would be true that many providers would be cross-subsidising in order to be able to support the operations of support at home.
Yeah, okay. And you made comment in your opening remarks about the professional override with the assessment tool. And just wondering from your own experience, how often do you see people, or since November, see people who actually have received their packages having packages that you believe are completely inadequate or incorrect for the needs, or is it too soon for you to be answering that question?
It is a little too soon, and I wonder if, Alex, you've got cross-CHA perspective.
Yeah, Senator, we're seeing some early examples of that, but it's fair to call that anecdotal at this stage. I think the move to put a human in the loop, so to speak, announced earlier this month is a step in the right direction. We're sort of still taking stock of exactly what the detail of that is and taking our lead somewhat from the consumer peaks that have cautiously welcomed that. I think in a system the size of support at home, it's not unreasonable to have an algorithm in the mix to bring an element of standardisation and efficiency. But it should be simple and easy for a clinician to access a human review if they feel there's any indication that a higher package than was put out by the algorithm is warranted.
Yeah. Have you got any knowledge around how the actual algorithm works, or is that sort of like too far away from your coalface?
We're probably a little removed from that. We can sort of make observations from how we're seeing it function in our services, but I think you'd have to put that question to the department.
Yeah, sure. Okay. And Mr. Morgan, have you experienced any sort of trends, behaviours, etc., in relation to the automated assessment tool in terms of the challenges of the access to care that's being offered?
We've been monitoring this very closely from the beginning, Senator Ruston. At the moment, 42% of the people who've been assessed since the 1st of November, who we would have previously thought would have been upgraded, have not been. That number, 42%, that number bounces around a little bit week to week, but it's been between 37% and 43%, depending where we're up to. And in terms of being close to the algorithm, it is a complete mystery at one level, but we also we're looking at situations where we have participants with very similar circumstances, and you look at the assessment outcomes for them, and they're so different. And we really can't make sense of it. We welcome the notion of some human override as long as it's clinical. I think it's crucial that there are clinicians involved if they're going to introduce this, not an administrative override. But it is complex and slow, holding things up yet again for people. It really should be in the hands of the assessment organisation. These are people who are highly skilled, highly qualified assessors. We think there should have been more investment in if they're worried about inconsistency between outcomes, and that's a lot of the argument that was put forward by the department, really the traditional approach to that would be investigate why there are the differences and then provide training, guidance to the assessors. There's been a very sledgehammer to a nut kind of approach, I think.
I think on that education point for the... sorry, Senator. I think on the education point for the assessors, in health, we're increasingly seeing clinicians be mindful of system cost. So system cost and fairness across a broader cohort is also a concern. We can train the assessors to be cognizant of that while still making appropriate decisions for the people in front of them.
Yeah, yeah. And can I just ask you quickly on the financial hardship assistance? I'm just wondering, have you got any data that you've been able to collect in terms of the increased number of people who are seeking hardship? Have you seen an increase in the number of the people that you're seeing who
For me?
in need? To both of you.
Okay.
Would you like to go first?
Yeah, very few are applying. Going back to the evidence earlier today, it's a 16-page document. It's very daunting, particularly for the people who most need it. And even though we offer assistance to people, I don't think we've had anybody who's been successful.
Oh.
We've had applicants, but from what I understand, there's nobody who's been successful at this point.
Right. Have you got any quantum on the numbers that you're talking about?
Very low numbers have applied. It's less than a handful.
Yeah. Okay. What about CHA? Have you had a similar experience?
I don't know that the volume has increased. Perhaps it's felt like that for some providers as the process has slowed up in the early months of the reform. Echoing the comments about the particularly voluminous form to complete, I don't know that our experience has been quite the same in that people are getting approved, and not all of them. For us, there's then the broader concern for specific cohorts, particularly pensioners that rent, and whether or not they should be paying any co-contribution at all when they're at sort of that end of the socioeconomic spectrum, which comes back to why that hardship process needs to be as efficient and strong in its function as a safety net as possible.
If I could add a comment to that, I mean, to me, that should be the threshold. If you're a pensioner who rents in the private market, that should be the end of the story.
It should be
automatic.
It should be a one-page form at that point.
Yeah, absolutely. Okay, and just finally, in relation to your experience around getting quick and easy access, particularly in relation to things like household supports, etc., are you seeing many of the people that you're dealing with ending up in hospital or having to go into nursing homes, in your opinion, prematurely because they're not being able to get access to the necessary supports that enable them to stay at home?
From our point of view, we have had examples, both in terms of people who couldn't get assistive technology and needed it, but also people who couldn't get services they required.
Yep.
But we're not talking very large numbers, but we are talking an increasing number. Referring to something you talked about earlier, a lot of people are still in the grandparenting arrangement, and they will be less impacted than people who are not in the grandparenting arrangements.
Yep. And are you seeing, even though I gather there's only going to be a reasonably low number of people who are coming into the system that aren't grandfathered in relation to their home care package conditions, are you seeing different behaviour from them in terms of how they are interacting with the services that are on offer because of the changes?
If you're talking about the service mix,
yes,
there's a small move towards the services, the clinical services people don't have to pay for. Mm-hmm. It's probably not as significant as we had expected. A lot of people have just reacted across the board to hearing that there are payments involved. Part of this is the complexity. It's a very, very complex system, and a lot of people find themselves, even with a lot of explanation and time spent with them to explain, just kind of a bit freaked out by it and just go, I don't know if I want that. Concerned about what might be hidden or around the corner.
So to that end, is it your experience that people are reacting to the pricing in a way that, I mean, are you seeing people not take up a service because they've got to make a contribution towards it?
Definitely. and a lot of people not going into supported home at all because of the cost structure, particularly people who currently have Commonwealth Home Support Program services at the moment. But within, even once people are within supported home, there's still a group of them who are refusing services that they otherwise need and could afford if they didn't have to make a personal contribution.
Okay, so in terms of you seeing anybody who is currently on the Commonwealth Home Support Program who may have been deemed eligible for a supported home package choosing not to take the supported home package and stay on CHSP?
Large numbers.
Large numbers.
Yes.
Okay, is that the same experience that you've seen, Mr. Lynch or Mr. Hopper?
I can't answer that specifically other than to say there is reticence by participants, particularly about the uncertainty of co-contributions. It isn't necessarily because of it, but I think there's a lack of certainty or understanding of if I were to begin to participate, would it increase or not? So there's a confusion, if you like, and therefore a reticence to take that up. If I might step back to your question about supported home's role in preventing hospital admissions, it absolutely does. This is an important pillar of avoidance of downstream higher costs, particularly in emergency departments. So we know that getting access early and well and fully funded certainly supports people to remain well longer and avoid consequential challenges in their life, including early admission to aged care.
Yeah. Okay. Thanks, Chair.
Thanks, Senator Ruston. I'd like to take a very big picture view of things. We had a Royal Commission. It said that there were huge problems around the care that was being given to older people. Coming out of that Royal Commission, we have a new Aged Care Act, which essentially did two things, two quite separate things. One was to say we need a rights-based system where older people are at the centre of everything that we do. And then we had a massive rewrite of the financial architecture of home-based care, which is effectively all supported home is, right? It's a redrawing of the financial architecture. Now, it seems to me, from what I'm hearing consistently from the evidence, is that actually the rewriting of the financial architecture has not led to more people getting access to timely care at the time that they need it. I'm hearing from you that your margins are being squeezed, and yet we're hearing from older people that they can't afford the care because prices have gone through the roof. So I guess my first question is, have we actually gained anything from rewriting the financial architecture? Could we have just said we're going to change it to a rights-based system and still operate it as we were, and potentially then rethinking what that looks like going forward? I'm keen to understand what have we actually gained from the financial architecture of support at home, because it seems to me that providers aren't happy and neither are the people who are getting the care. And I know that's a very big question, but it kind of goes to the heart of what we're here trying to work out.
I think, Senator, if we think about those two things combined, without needing to rewrite history, because we can't, the sense that actually the funding architecture needed to match rights-based is probably the point. And to have a system that was in collaboration with the rights-based approach would not have worked. So I think where we find ourselves is...
Can I dig into that a little bit more? Not an aged care provider. Why wouldn't the architecture that we had have worked? Because I think that's an important thing to understand, because, you know, why have we done it the way we've done it? Why couldn't we have just said people actually are entitled to have rights and we need to make sure that they're enforced and adhered to? What did the old system prevented that?
Well, the new system of a demand-driven, where funding follows the assessed need, would be the ultimate answer to the rights-based approach, which is, I think, the problem we're sitting with today, which is where we need to ultimately get support at home too. it's transitioning that way. We would be advocating that demand-driven system that follows the assessed need is the answer. And a
But
staged
how is it
transition
moving
to
that
get
way when we're hearing from you is that wait times are getting longer, less people can afford the care that they need, people aren't wanting to transition from CHSP to support at home because they can't afford the co-payments, the hardship system is too difficult. I don't understand how we could possibly be closer to rights-based care, given the Inspector General's point that care denied is you don't have a right to care if you can't get it. So I'm really struggling to understand how any of this is moving us closer to that.
I understand why you're struggling with that, because I am too. I think the main impact of the new financial structure has been to save the Commonwealth money. And I think, Treasurer Chalmers talks about savings in aged care of many, many billions of dollars, and quite a lot of that is coming from the home care side of the equation. I feel that's a false economy because it's the cheaper end of the cost structure, and if you can keep people out of both hospital and residential care, you won't just save the Commonwealth money, you'll save the community money, and also people will have a better life. So I think it's actually, although if we take a narrow view and look only at home care and say, yes, money's been saved in home care, but I suspect it's being pushed through to other parts of the system. And the other thing, which for me is fundamental, is that the rights-based system leaves out the most important right, which is the right to aged care.
Yes.
Yeah, that's the big one. And in a sense, there are a lot of other rights talked about. You don't get any of them until you enter the system. So, yeah, I think it might have been an exercise in distraction, possibly.
And I guess what I'm trying to get at is you're sitting in front of us telling us that your margins are getting squeezed, and yet people receiving the care, and I refuse to call them participants and consumers because they're not, they're older people who need care. They can't afford it. So how can these two things be true? Like, I really want help to understand how is it that you're telling us, providers are telling us we can't afford to deliver care, our margins are getting squeezed, but people are paying more than ever for their care. How is that mismatch coming about? What is the cause of that?
you go.
Look, I think I'll step back and try to answer your bigger picture question, which I confess I came here with a list of minutiae. How do we deal with our current transition phase? I think rights are bigger than just the changing of the financial setup, and so there have been improvements as part of the package of reforms that fell out of the Royal Commission that are broader than that. The sector's governance on the whole has improved. Its minimum standards have improved. Some bad actors have exited either because they were told they have to or because they couldn't meet those new standards. So I think when you think about it from the older person's perspective, once they're into care, the expectation that they'll receive better care than they would have 5 to 10 years ago is now there.
Yeah.
To pick up on what Mr. Morgan was saying about the right to access to care, one of the challenges under the home care package model was utilisation. So the government would, under its budgeting rules, be required to allot, say, $50,000 to a client, but if they weren't using it all, then it would accumulate, and that money could not easily be reallocated to another person. So the sense was that to achieve the scale that we now need to achieve to keep people at home and to give them that, older Australians, that care at home, the finances had to change. How easy it is to...
Surely there's a difference between saying after 4 years, if you've got a big chunk of money still sitting in your account, there's a reallocation function, as opposed to we're changing the whole thing and everyone pays co-payments. Like, I understand that's an issue, but again, this seems like a big sledgehammer for a very small problem used to justify a massive cost saving.
But I think to your more specific question then of like what's causing that, there is a range. I mean, it's new for us too, but we think that the contributions are challenges getting people into short-term packages. Some of the other viability concerns are stemming from abundance of interim packages where there's no clear guidelines about what care we're not meant to provide
Yes.
when someone's been assessed as needing 100%
So you're talking
of
about
X.
the 60%
Yeah, and we're
packages where
giving
they're
them
not
60% of
giving them a
X,
full
which 60%. And
Yeah.
in fact, I think most high-quality providers are just shooting past 60%, and that's squeezing their margins. The administrative burden has been spoke about effectively by the people sitting next to me and by other witnesses. Associated providers is a challenge.
Can you give me an example of the additional administration that is causing your costs to increase but that are not transferring through to better care? I mean, you've talked about governance, and obviously that was really important, right? There were people who were really getting poor treatment in aged care. But what sorts of administrative things has Supported Home put on you that make no meaningful difference to people's care at all? Can you give us some examples?
I can give you some examples with assistive technology and home modifications. That used to be in the home care package days a very simple process. If the person had funds available, their home care partner could simply talk to them about it, arrange it, and it would happen.
Yep.
Under the new arrangements, it's a very convoluted process, and even just trying to simplify it before you begin. So if you want something that requires a prescription, and many of things do, it means if you've not got any money in your separate bucket to pay for that, then you have to put in an application to get some money, to put some money to pay the prescriber. That's an application process. You then have to wait for an answer. You have to check, have I heard yet? Have we got it? Have we got the funding? Have we got the funding? Okay, it might come through. It may not be enough to pay the prescriber. You have to negotiate then with the prescriber about will they do the work for the lower amount of money, or will we have to go back and ask yet again to get the prescriber's money? When we can pay the prescriber, then we can get the prescriber to say what is required. They provide the prescription. Then you reapply yet again to the system and say, now can we get the money to pay for that prescription? You wait, you find out you may or may not get the amount required. They might need a bed, $6,000 for an electric bed. They might say you can have $3,000. Then you've got to go back and say, well, that's not going to be enough. What are we going to do? Then you're trying to get more money put into the pool. If you can't, you've then got to negotiate with the older person to see, is there a workaround here? This used to be so simple. I've just described to you a whole series of processes.
Sounds like the definition of insanity to me.
Well, it must be pretty close. And you then multiply that for all the people who require that assistance. That's where you get whole extra jobs of work created out of things that do nothing for an older person.
So would I be correct in assuming then that nothing's ever easy, but one path that could definitely be taken that would help providers in not having such tight margins and bringing down the cost of care for older people is literally going and look at some of those processes now that have been put in for support at home and completely streamlining them? Yeah.
I think there's other examples. I think just top of the list would be associated providers. There is the core of an important idea there, making sure that the regulator is aware of who providers are sending into people's homes. But the current system cannot be the end point. There are staff talking about, and in fact actioning, putting whole staff on just to manage their register of associated providers, which runs into the many, many hundreds for some registered providers. One example would be where a registered provider is providing services as an associated provider. We don't need to go through the process for them, as opposed to them being considered an associated provider to us. Clearly, as a registered provider in their own right, they should just be viewed as capable and competent of providing services. And then another one, we're about to begin applications for thin market grants in areas where Senator Ruston asked about cross-subsidisation. No one's in those areas to make money. The grants will be provided. They'll be provided next year. We'll run them less efficiently than we could because we don't have funding certainty, and boards have fiduciary responsibilities not to make commitments based on absent funds. So looking at making thin market grants. Substantially more permanent, if not permanent outright, is another thing that could be done to reduce the administrative burden.
I'm very conscious of time and that I need to share the call with Senator Whittaker, unless she said she doesn't. Yes, she does have questions. Would I be able to ask for you to take on notice, and I don't want like the whole ins and outs of it, but a list of things, of processes right now where a simple streamlining of those processes could actually deliver benefit for providers, but also significant benefits for older people in this system.
Certainly.
Great, thank you very much. Senator Whittaker.
Thank you, Chair. Notwithstanding the conversations that we've heard about some of the challenges with the implementation of these changes, I think both of your organisations have broadly supported the intent of the reforms and the need for change from the previous system. I wonder if we could spend a bit of time talking about what the new support at home system is doing better than the one that it replaced. I'm interested in your reflections on that.
I mentioned earlier, I think the headline was that we've noticed in 5 years we've doubled the number of people accessing the system. We've also identified that there's a significant number on a wait list and a period of time that's going with it. And the need or the cost of inaction around that isn't zero. There's a cost to those individuals and the system. But certainly more people are accessing that, if we were to put it in those terms. We just need to do a lot more to get more packages released to those who are waiting.
I would add there's new streams of programs that are, we're here with teething issues for how to work through getting them functioning properly, but you can see the benefit they're going to deliver. The end of life pathway in particular is one that we're pleased to see as part of the Support at Home program. We're pleased to see that the potential for someone to use that package has been doubled in the latest budget. We'd like to see it eventually just possible for a human of sufficient seniority at the department to be able to say, you are still alive, you are still requiring palliative care, and so your funding will continue until such time as you pass away. But that is an example of a bright point in support at home. And I think the restorative care packages will get there. We're just having teething issues with how we get people into those. So there's some examples of the positives.
Yeah, thank you. I understand that from the 1st of October, some assistance will become fully funded without any contribution required from older Australians. So that includes help with showering, dressing, and continence management. I wonder if you could talk a bit to that and in the older Australians that you assist in your organisations, what difference that change will make for them.
That's a positive change. A change that probably should have been in place from the outset because it's so intrinsic to people's capacity to live independently. People don't ask for personal care support if they don't really need it, yet it's something that people tend to need multiple times a week, and so the co-contributions would add up very quickly. To roll that into clinical care makes a great deal of sense. I'm glad to see that they've done that. I would like to go back to one of the comments you made right at the outset, Senator Whittaker, about the need for any change whatsoever. I really think the case for the change they've made, of the scale they've made, was not made out, and I think it would have been far preferable with a series of quality improvements to the previous system, such as capping the amount of money people could hang on to in unspent funds. That was completely unsupportable, and people would have really welcomed that, and we wouldn't have had the degree of disruption that there's been if we'd gone through a more incremental process. So I guess I'm mentioning that now, knowing we can't change history, but hoping that in moving forward that we make incremental improvements and change, because they're far easier to design and deliver.
Thank you. Does anyone have anything further to add to that before I move to my next question? No? Okay. One of the things the government has done, I guess, to manage the implementation of this is deferred the introduction of price caps, and we've also announced a number of enhanced consumer protections, including empowering the regulator to order refunds where a provider has been overcharged. Where a provider has overcharged. Why was that the right call? Why were those decisions necessary, do you think?
That was a really important decision. I think the deferral of price caps was simply a necessity in terms of the maturity of the data that we have to set prices. But I think not just settling for that, but putting in place stronger consumer protections was the right approach. I don't think any reasonable provider is going to oppose refunds where they have overcharged someone. I would like to think that where that occurs, that is normally an accident or challenges as they themselves are transitioning to the new Aged Care Act and new systems, but it's entirely reasonable that refunds be provided where there's been an overcharge of a co-contribution. What will be really important, one of those consumer protections the government announced was getting guidance from the department on reasonable prices, and there's going to have to be differentiation in what they look like. Regional looks very, very different to metro. Other forms of thin markets look very, very different to metro. You have regional towns that are mining towns, and the costs are astronomical and very different to another regional town. I've heard some politicians say if you've seen one regional town, you've seen one regional town. So there's going to have to be some work done in that space. But absolutely the decision was critical. And if price caps are ever brought in, it should only be in a context where there's very rigorous data over a number of years. But I think first having a go at more impactful consumer protections that there's evidence for, which is what the government's announced, is absolutely the right way to go.
And I couldn't agree more. I'd just add that variability also has to pick up services after hours, on weekends and on public holidays. So it can't be a single price cap, but I also agree with something which was said in evidence earlier today. I think maybe Senator Askew said that prices tend to go up to whatever the price cap is. So I think the evidence is actually it pushes prices up across the system. And I'd rather see if somebody's charging far too much, we set a reasonable price, and if it's far beyond that, then there is action taken to bring it down rather than try to put in price caps, which are going to have to be very, very complex to cover all those variable circumstances we just talked about.
I agree, and I think the government acted based on possibly the NDIS experience where you saw that price inflate, a price cap essentially being treated as a price guide. And there would have been all sorts of integration issues for those that had higher prices than a cap, but for good reason. We could well have seen service withdrawal in regional and outer metro like we saw in the NDIS example. So very supportive of that decision.
Thank you. Final question from me. We're now 9 months into this transition. I'm interested in what the government has done that's been useful to providers in terms of managing the transition and what you'd like to see going forward.
One key outcome that we've advocated in our submission actually is the continuation or release of packages. So in that submission we talk about 60,000 per annum for the next 6 years. We need certainty and a flow. We understand the cost of doing that is significant, so a stepped approach, allowing people to get access earlier and more people would be significant. We've talked about these things too, examining the deterioration in margin and understanding that urgently, and also looking at the administrative burden of the system. These things have emerged through the transition, so we owe it to ourselves to actually explore that rapidly in order to ensure that Support at Home can deliver on its commitments to people.
Certainly wherever the government's provided detailed information with plenty of lead time, that has been most helpful. We didn't get it across the board, and I would hope in future we could, again, for learning from what's happened, that in future changes there are longer lead times with full information being available. The other thing is whenever we're given information about what's happening in the system through, for example, the Quality and Safety Commission, that's always helpful to have that. and again, as close as possible to the time that it relates to and not too much delay.
Thank you. Thanks for evidence today, and thank you, Chair. That's me done for these witnesses.
Thank you. Can I thank all of you for both your submissions and your time in front of the committee today? It's always very much appreciated. The committee will report to the Senate on the 24th of November 2026, and we've agreed that responses to questions on notice should be provided by close of business on Friday the 14th of August. Thank you very much again for your evidence, and we will now suspend for a short break until 10 minutes past 11. And I'm going to welcome representatives from the Kirinari Community Services via video conference and North and West Remote Health. Thanks very much, everyone, for appearing before the committee today. I understand that information on parliamentary privilege and the protection and obligations of witnesses giving evidence to Senate committees has been provided to you. Now, for the Hansard record, I'm going to ask you each to state your full name and the capacity in which you're appearing, but because you're online, it's a bit tricky to know who should go first, so I might just call each of you, even though it sounds weird that I'm going to say your name and then you're going to say it again. So I'm going to start off with Miss Lynch.
Hello, thanks very much. Diane Lynch, CEO, Kirinari Community Services.
Thank you. Mr. Kane?
Thanks for that. John Ing, CEO of North and West Remote Health.
And Ms. Cotterill?
Morning. Rani Cotterill, Executive Manager of Allied Health and Community Services for North and West Remote Health.
Great. Thanks very much, everyone. I'm now going to invite each of your organisations to make a short opening statement and then we'll go to Senators' questions. So I might start with Kirinari Community Services.
Thank you. So as I said, my name's Diane Lynch and I am the CEO for Kirinari Community Services, which is Australia's largest regionally based provider of human services, including aged care. Kirinari supports more than 15,000 customers across New South Wales, Queensland, South Australia, Tasmania and Victoria. The way communities include and care for their ageing members reflect who they are and what they value. Support at Home was introduced with the promise it would enable older Australians to live independently, safely and with dignity. This is a promise Kirinari strongly supports. Our purpose is to ensure everyone can lead a good life. When I think about what life I want as I age and what support I want when I'm older, I think about living my definition of a good life. A bit of help to clean my kitchen, regular connection to my family and friends, not seeing a doctor unless absolutely necessary, enjoying delicious food, a bit of travel, wandering in a beautiful garden, a daily walk to my favourite coffee shop and chats to the locals. My dad is 86. And the life I have described is broadly the life he lives. My mum died last year, having been diagnosed the year before with dementia. Mum's life was also as I described until the last 12 months. Her last 12 months were characterised by too many doctor's appointments and well-meaning but misguided attempts to maintain life by medical interventions and appointments that, in my opinion, significantly reduced the quality of her life. My siblings and I now reflect upon the decisions we made to have Mum diagnosed with dementia, and we have all agreed that we will not go down that path again if Dad shows signs of cognitive decline, to avoid a circus of medical appointments and interventions, for my mum at least, that resulted in no additional assistance, but only decreased the quality of life. I share this personal reflection because I think one of the core challenges for older Australians is that we fund aged care through a clinical lens, rather than simply asking, what do people need to live a good life as they age? Overall, Kirinari strongly support the intent of reforms that deliver on the recommendations of the Royal Commission into Aged Care. There are, however, challenges. The compliance burden of support at home is 2.5 times greater than Commonwealth Home Support Program in care management costs, with no additional funding to meet it. Complexity directly translates into cost, and cost comes out of frontline services. The Inspector General's National Press Club address this week indicated residential care costs the taxpayer around $123,000 a year, against about $30,000 to support someone at home. More than 200,000 people are stuck at the front door of the system, and prevention should be treated as infrastructure, not expenditure. The $15,000 lifetime cap on home modifications is inadequate and does not correlate to construction costs in regions. Ultimately, Senators, the ongoing challenge sitting under all this is geography. The true cost of regional service delivery isn't recognised. Providers in the regions cannot neatly match an hour of service to an hour of payment. In many cases, that's just the amount of time it takes to travel between customers. Even with a thin market grant, our cost for one remote customer exceeds the published rate by more than $80 for every hour of care. This is why Kirinari has long advocated for pricing to include a regional loading embedded in core pricing rather than delivered through short-term grants. Unless we expect everyone to migrate to urban areas, we need processes and pricing models that appropriately reflect where people live, so all Australians can live a good life, no matter where they live. Thank you.
Thanks very much, Ms Lynch. I'm going to go to North and West Remote Health.
Thank you, Senators. So, John Kane, CEO of North and West Remote Health. North and West Remote Health is a not-for-profit organisation in the primary healthcare sector, and we deliver a wide range of services across a large part of Queensland, extending as far north as Mornington Island, as far south as the Birdsville and Baduria area, west to Mount Isa Longreach, and east to Townsville, Cairns, Mackay, and surrounding areas. So we cover about 52 communities across our footprint, and part of those service delivery activities is well within the Commonwealth Home Support and the home care or supported home programs at the moment. We've just embarked on and transitioned across about 50 supported home clients, mostly in the rural remote communities of Western Queensland. So we're a very, very small provider in the scheme of things in terms of supported home at present. But we have a very, very large Commonwealth Commonwealth Home Support CHSP program that's identified to be transitioning towards the supported home program in time. Our operating model is in that MM6, MMM7 range, particularly, and about 50% of our clients identify as Aboriginal and Torres Strait Islander community members to work with in support of the supported home packages that we provide to them. So a pretty important cohort of clients that are particularly affected by the change and the transition from the home care to supported home, and also in scope for some change and some service delivery options for the transition from CHSP to supported home. So I think our discussion and our input in terms of the Senate is particularly important in terms of the rural remote sector of Queensland, particularly. Very much in terms of the impacts in terms of thin markets and the impact of changes of financial modelling in terms of service delivery in a thin or no market service delivery region, as well as also experiences to date in terms of the transition from home support to supported home at the moment. So very much looking forward to contributing to Senate's inquiries today.
Thanks very much, everyone. I might just go to North and West Remote Health first. In your submission, you talk about, in particular, impacts of the transition of support at home on First Nations communities and First Nations elders. I'm just wondering if you could speak to your top concerns for that cohort of people and recommendations that you would make to address that.
Happy to. And Rani, would you like to lead off on that one in terms of your lens from an operational perspective, what you're witnessing at the moment? I can dovetail into the next steps if you like.
Yeah, of course. Thank you. I think to start off with the journey of assessment. So what we are finding is that actually getting some of these First Nation elders assessed is one of the biggest barriers and challenges that we're seeing. We have assessors that are based within our region, but still the geographical sparsity of where we live requires travel of over 700 kilometres to attend these communities. What we're seeing is the assessors are not attending these communities and relying heavily on a phone call to the participants. And within my submission, I've kind of gone down and alluded to the challenges of a phone call-based assessment service. So getting them on the phone is being quite difficult. And as an organisation, we obviously see firsthand the trials and tribulations that are happening for these individual participants. And so we strive as hard as we possibly can to help and support to get those assessment pieces done. As an example, we had one of our clients come into our wellbeing centre. We sat with them to try and work with them to almost translate what was going to happen over the phone. Keeping in mind, we've already done the MAC referral for them. So we've sat with them before and worked through the MAC referral pathway. And then we've finally got to the piece of the assessor coming on. This participant has, they've asked what their name was. He's answered, "What's your date of birth?" And they said, "What year were you born?" And he said, "I'm 75. And they said, "No, what year were you born?" And he said, "Oh, not sure." And so when they're trying to even just get an understanding of the person that's sitting in front of them, they've asked the MAC ID. He didn't know what the MAC ID was, did ask the date of birth, and then we're trying to help and support because we had it there in front of us as well. We're helping him. And we say, what month is it? And he said, "Well, it's the month of November on the 6th day." And in their system, they had it was the 4th day. And they said, "Are you sure it's not the 4th?" And he said, "No, 6th day." And it was just that translation. And one of our care support workers said, this is how it is the 6th day, but we've got in our system that it might be on the 4th as a birth certificate. And the assessor said, "Do not speak for them. We need this from the person themselves." So that's one example of an assessment piece. And that's, actually when we've got to a point of sitting with the client and working through the assessment piece with them. So I think that, the assessment, and I think that there has been some work with the First Nation assessor, but having that position filled within the region is, it's workforce sustainability that's also an issue. Moving into actually getting them onto these packages, what we're finding is, and I will talk to the transition piece, is the grandfathered clients that are coming over for, the no worse off and no client contributions. And then for us as an organisation, when we've got a release of a new code for support at home, we're sitting with, these clients might be neighbours. They know that the next door neighbour doesn't require to have client co-contributions because they've grandfathered. And then this person, when we're trying to onboard them as a new participant, they're saying, "Well, auntie next door doesn't have to pay. Why do I have to pay?" And it's immediate, that mistrust, the real concern of us trying to articulate the changes of the new program, and then for them to trust us as an organisation and us as people within their communities. We found it really difficult to actually roll the support at home. And what we're actually seeing, and what I've articulated in the paper, is that the mistrust and the requirement to pay. And I think that that's another real piece, is that up until their most vulnerable days of ageing, they have not had to pay for healthcare services within these communities because of other programs like Closing the Gap. And so when they're at the most vulnerable and when they're requiring the most healthcare, this is when we're asking them to put forward client co-contribution. And we're doing our darndest to do the financial hardship and trying to get, the supportive evidence to showcase that, the client co-contributions do not equate to, or, not relevant for these individual people. But it just hasn't been the case for when we've tried to sign people over.
Ms. Cottrell, do you have any evidence around success or lack thereof of people's hardship applications? We heard from an earlier witness that they weren't aware of anyone in their organisation that had actually had hardship approved. Do you have any figures around that for your organisation?
We have sporadic. It's very sporadic, if I could say that. It's that it will be applied to some and then applied to not applied to others, which when you're assessing them on face value, it's like for like, but some were approved and some were not. So I don't have exact percentages or figures, but sporadic is what I have seen.
Senator, can I just add to that? In terms of, we used to have co-contributions attached to the CHSP program a number of years ago. And for a lot of the cohort that we're talking about under the current support at home, they were part of or have been part of the CHSP program in the past. So we did the assessments for a number of years there. and where we were able to achieve client contributions, we were able to achieve and recover. But we ended up actually having to write most of those off in terms of actual physical receipt of the money after a period of time. So we're talking a few $1,000s here, not a lot of money, but the assessment process was undertaken. There was an element of $10 or $20 of a contribution that was accepted as being a reasonable contribution. But the recovery of that from an administration perspective and actually the payment of that never really occurred. So it ended up becoming an administrative task after the fact to a large extent on the basis of a financial hardship that was probably never been able to be achieved anyway.
Yep, thank you. Ms Lynch, I just want to go to your evidence around focusing on what a good life looks like for older people. And I'm wondering if you can speak to the aspects, I guess, of support at home that are actually impeding older people's experience of a good life.
Yeah, thanks. Look, I think it comes down to that. What the CHSP program does super well is that small amounts of support for many people. It's super responsive, and you can respond to changes in a person. If they've had a fall and they're coming out of hospital, you can put services in. The reality for support at home is that it's somewhat more challenging. It takes an individual approach. And certainly there's a great deal more back office administration that's required. So I think when you sort of think about, when you think about, certainly what I think about with that sort of little amounts of support going in that can help a person maintain in their own home and reduce that likelihood of hospitalisation or residential care, we really want that to happen, and we want it to happen fast. So when you've got significant wait lists, when you've got a long time to get through an assessment process, when people feel like the actual process itself, if they are experiencing financial hardship, just adds to kind of the complexity for them, it delays that support. And what we really, I kind of feel like what we really want to do in terms of thinking about a good life, it is that how do we help people stay in their own home with a little bit of service really fast, that's super responsive, so that people sort of go, well, I don't need any additional support. I don't need to, and I'm not declining. I don't necessarily need to end up in a clinical space. The end goal is absolutely, we don't, we want people to be able to stay at home and perhaps not even require showering, certainly not require regular health checks, certainly not, be on a sort of a treadmill to doctors' visits. And I think for most of it, we've sort of, we think through that lens of, as we're getting older, well, we just need a little bit of support. If somebody comes and mows our lawn for us, and that's one less thing that we have to do, then you don't start thinking about, well, actually, that's getting really hard. And then thinking, okay, well, how long can I do this before the next thing happens? So I think, unfortunately, for support at home, some of the challenges come in around, it's become, as that individual service, a more complicated service. It's more complicated for people to get into it. It's more complicated to get a hardship approach up. I was curious on the question before around the hardship. I know for Kirinari, we've seen something like 16 applications, and 3 of those applications have got up. And some of the feedback that we've got is that people have found it incredibly confronting. One regional couple that we're aware of who are sort of, supporting each other, were very frustrated with the application process that asked for things like the value of their appliances, their furniture, even their curtains. And they were declined despite clear financial strain. They've reduced their services, delayed some of their personal care, and leaned sort of more heavily on each other. They chose not to appeal, largely because they felt that it was distressful and fatiguing from the whole process. So I guess part of what our concern is that, many rural customers are asset rich and income poor. Their wealth is held in the very home that the program's designed to keep them in. So I kind of feel like we've got to find a balance here around being able to get services in quickly, and actually not hamstringing providers with a heavy level of compliance and a heavy level of administrative burden that actually translates into additional cost and doesn't let us get in the early intervention that's really, really necessary really fast, which ultimately saves money for the taxpayer because you're avoiding those hospitalisations and you're avoiding residential aged care. And in my opinion, the majority of people that I speak to who live in regional communities absolutely want to stay in their own home. They do not want to go into residential aged care, but they need a little bit of support to do that.
I'm just wondering if I could ask on notice, Ms Lynch, and an open invitation to North and West Remote Health too. I asked a couple of earlier witnesses if on notice they could just send through a list of some of the processes that they think are really overly complex, but that are creating a big burden for you as providers, but really are not translating to any additional improvement in outcomes or care for older people. So if you have like a list of things that you think, you know, the department really needs to look at reforming those processes, very happy to receive them on notice, and we can start to compare across providers what you're picking up. I'm conscious I need to share the call, so I'm going to go to Senator Ruston. Or is she still here?
She's still there.
Yeah. Is Senator Ruston still on the call? Senator Askew, did you want to?
She's on now. She's playing with something.
There we go. Senator Ruston.
Get on there.
My sincere apologies. Oh, now I've got incredible feedback. Gosh. I'm going to drop out and come back on again. I'm hearing everything coming back to me on repeat.
Okay. That being the case then, I might see whether Senator Ananda Raja has any questions.
Yeah, not for this witness. Thank you.
Okay. Senator Whittaker, do you have questions?
Happy for you to go to Senator Ruston since she's back on, and then come to me.
Great. Thank you. Senator Ruston.
Yeah, I can't be trusted with technology. Look, I was just more than anything just keen to just tease out what you've both said about the challenges that are faced in rural and regional and remote markets in relation to the challenges of access to care. And I wondered, I mean, a lot of the conversation has been around the problem, and I think we're all pretty well aware of what the problem is. I was just wondering whether either of you had any suggestions about things that could be done to actually practically remedy how we deal with this, inequity of access issue in rural and regional Australia for people who want to access care at home.
I'll have a crack first, John, if you like. Cool. I would say maintain the CHSP program separate to the supported home program. In fact, expand it. Small amounts of services to many, many people is what we need to respond really fast to things, and maintain the CHSP program in terms of its really light touch and background responsibility in terms of compliance and bureaucracy for providers. It's a really effective program that we see every day. We get calls from different parts of the region who are aware that we're a large CHSP provider and are hoping that we can deliver more. We're delivering the maximum that we can with the funding that we have, and it's very successful. But I would say that it's there's still so much unmet need. There's so many communities that would benefit from more of the CHSP program if it was available. So I'll just leave that as a quick one.
Yeah, no, absolutely. So to that end, what is your view at the moment in relation to the time frame when we need to get some certainty around when CHSP well, what's going to happen to CHSP from the 1st of July 2027, because it was not before, but I mean, not before still leaves a view that something is going to happen, or some advice or action needs to occur to give advice to the sector from the 1st of July. I mean, how soon do you need to have a degree of certainty what the 1st of July 2027 onwards looks like?
Yeah. I could add to that, if I could, that earlier comment about the importance of CHSP and the block funding model. I think as we're moving towards this this change, the less funding available in the sector, the harder it is for rural and remote organisations to employ and to incentivise people from a retention perspective to work in rural and remote communities right from the word go. So I think the block funding element of CHSP is crucial to support that ongoing, and to increase that in a way that that builds or incentivises organisations to employ more to cater for the demand that's in communities at the moment. Would certainly be a benefit to those organisations providing those services across the areas in the MM6 and MM7 world particularly. The earlier the advice in terms of the intention of the Commonwealth in terms of CHSP to support at home, the better, because that is going to be a massive shift, not only for the consumers that are going to be receiving the services, but also for the organisations in determining whether or not they can actually afford to continue to provide those services in the rural and remote sector. Declining or reduced availability of funding and flexibility in that funding to actually cater for service provision in remote communities will be a big problem if that's not available for ongoing service provisions going forward to consumers. So the earlier the better, and there's a lot of nervous organisations out there right now looking to understand what that's going to look like for them in the future. And we're already seeing, we've already had examples in our sector that some current CHSP providers are looking to get out because they've got no line of sight over what it's going to look like. They've probably got the thoughts and the modelling to say it's not financially viable for us to continue to do it, so we need to find someone else to do it for us. Or they'll exit completely, and there'll be no service providers there to do the work. So that is the number one biggest risk in terms of organisations thinking about are they going to be able to provide services in the future under a new model, under support at home. Pricing is going to come into that if it's going to be broken up into individual packages rather than under a block funding, which will become completely inflexible. Where does that intersection look like between the ability to service provide versus opting out, and then the translation of that to what it means to the consumers? So the earlier that is advised, the better it is for everybody to work that through to the end user at the end of the day.
So from your experience in providing support at home, or the old home care packages and CHSP, I mean, is there an efficiency that's derived, particularly when you've got a shallow market, from operating as a block on a block funded funding model? Is that a more efficient way to actually deliver the services with the limited resources you have in terms of human resources?
Yeah, 100%. The only way you really achieve service viability at the end of the day is to be able to apply some scale to existing services, or to add that service delivery onto another service delivery. So how we've got our model at the moment, which is primarily grant funded or block funded, there is a bit of a mix of fee for service, but the fee for service is only really viable because we're able to provide that service in addition to current activities we're having in communities at that point in time. So there's value at the end of the day for the end user under an NDIS package, for example, with scale for existing services for other people in communities that we can add on to in terms of service delivery component. So if you were to look at providing that service as a one-to-one, i.e. the only service or only model you've got in terms of funding availability is a fee for service into remote communities, you probably won't go there because you can't afford to go there, and you'll make a loss right from the word go. Will not be able to sustain those services in the longer term. Versus a blended model, a grant-funded model with an element of fee-for-service to help cover your operating costs and to provide access to services into communities. There's another model there that does work in some way, shape or form, but they don't work in silos or in isolation at all, because people just opt out because there's they lose money on it, basically. They can't provide the service, unfortunately.
Yeah. So to that point, which is a very good one around, particularly in smaller markets, where the care sector could be applying to a healthcare sector, a disability care sector, an aged care sector. I mean, they're all a care sector that in some way, shape or form, people will be relying on services. Do you think there is would be a more effective and efficient way of allowing communities to actually streamline what they're doing by having a sort of like a single point of interface for the client in relation to the service provision, instead of it having to come in by those silo means, of whether it's aged care funding and all the things that go with the regulation of that, or NDIS funding and all the things that go with that. Disability support services that are provided outside of the NDIS, which is obviously what the government's intent is with foundational supports. It could be veterans, it could be just community members who just need a little bit of extra support. I mean, how much does the rigidity of the existing system prevent you from efficiently and effectively being able to deliver services to your community?
Perhaps if I could say, part of the reason that Kirinari is a diverse and broad human services provider is to actually be able to manage that reality. Government does fund in a particular way, and as you say, veteran services, NDIS, aged care, children's services, community housing, community transport, they're all health and allied health services. They're all human services. They're all super important, and they are all funded separately. So Kirinari's decision to scale and to diversify our services, because we were originally a very small NDIS, or before NDIS, accommodation provider, and we made a very clear decision at the start of the NDIS to diversify our services and to broaden our regional reach, largely because we heard a similar story all the time, and that was that people were very frustrated. There's very few humans that I run into in regional areas who don't have multiple challenges. So you might have aging parents, and you might have a child with a disability, and you might have trouble getting transport because you live in a regional community and it's virtually non-existent. And everybody is aware of the housing challenges in regional, metro as well, but certainly in regional. So we started to, you hear these issues and you realise that the only way that you can really help people in regional communities to navigate effectively is if you play in all of those fields, so that people can come in the door once, tell their story, and you can actually, help them to go directly to a person within our own organisation who can manage those services and answer those questions no matter what they are. So we have found that certainly as a regional provider, it's extremely important to be diverse in your service delivery, because it is how you make a difference to regional communities. It is how you solve problems. And you need to have super strong relationships, partnerships and connections within those communities, because in regional, everything goes around on the back of the relationships that you have. So I would say that it's super important. It's also, we have found that it is very helpful to end up with scale, because if you, and scale needs to be, it's a tricky one. There's a really fine line. You need to become highly efficient in your back office process in order to deliver more. And as a not-for-profit, every cent that we can find to go into frontline service delivery is what we try to achieve. And that does mean that you have to become completely efficient in the back office. And that's very challenging because your technology isn't where it needs to be. And your ability to recruit enough staff is very, very challenging in regional communities. And you are incurring additional transport costs because the smaller regional populations don't support their own labour market. There aren't enough people in those communities actually working in the industries. to be able to deliver those services. So you do need to come in with services from a larger regional area, and that costs money. In terms of staff wages for the time, but also the costs of petrol, the costs of maintenance of vehicles. But to succinctly answer your question, I think it's extremely important to have knowledge of all of those different ways that government fund, and I think that we have proven as a regional provider the benefit to regional communities in being a diverse human services business.
Thanks very much. Thanks, Chair.
Senator Whittaker.
Thank you very much, Chair. I'll just get my camera on. Thank you for your time this morning and your evidence so far. One of the things I wanted to ask about is the appointment of a new independent Aboriginal and Torres Strait Islander aged care commissioner. And I'm hoping you might be able to talk to the importance of that role being established in ensuring culturally safe, equitable aged care for Aboriginal and Torres Strait Islander people.
I'll
Very
take that one.
Yeah, Ronnie, you can talk about that one. I think I'll just start off if you like. Yeah, look, I think just new news to me. Sorry, I'm not aware of that piece, but it's quite okay. But I do believe that having an independent person that can inform, support, and oversee the important elements of Aboriginal and Torres Strait Islander health services and direction of health services is going to be a very important piece of the future in terms of the supported home and the CHSP program going forward. Ronnie?
Yeah, thanks. I think, I guess piggybacking off Senator Ruston's final question as well, where I think that regulation is something that's absolutely killing organisations like us. And if we were looking at Ms Lynch's example, NWIH is super similar, but having to navigate the system with unpaid work and helping the clients actually navigate the system, whilst also then becoming accredited against NDIS and aged care, having a new commissioner in place, I think applies a level of understanding of what we're going through and the places that we're service providing. And I think that level of understanding, even though the aged care commissioner, I think every time that I've been in her presence, she's saying that we just want providers, we're very comfortable and we're here to support the providers that are out there that are trying to do their best. But the providers, and I'm sure Ms Lynch, you'd be the same, the work that we have done over the past 2 years just to keep up with aged care reform, to make sure that we're meeting the Aged Care Quality and Safety Commission requirements, meeting the new strengthened standards, creating the pre-audit prep tool. It is so the administrative burden to maintain a level of accreditation, because we haven't been through the renewal just yet. We don't know what we're going to be hit with. So I think it is extremely important for the Commission to have an understanding of rural and remote providers, to have an understanding of the receiver, of the clients at the end of this. And I hope that there would be a level of, advocacy at that highest level of flexibility. And I think that to answer your question, Senator Ruston, I know I'm going back one, but if I can give you some advice on or recommendations on what we do forward, I have put some in the paper that I created, but flexibility and limiting the regulation for these providers out in our communities is inherent. The associated providers, so if we have a meal provider in one of these communities, so, one of the communities that I could talk to is 800 kilometres from Mount Isa, which is our main office. We have one participant on support at home requiring meals. There's no Meals on Wheels down there. There is actually only one pub, and that pub has decided to be an associated provider for us to make the meals for this one participant to allow him to stay at home and on country. And so the regulation requirement to have that pub make that meal and to be an associated provider and have a service agreement with us and meet the regulation requirements to have a national police check and a blue card and a yellow card and, all of the things that we need to have them to just deliver a meal. The administrative burden of that is wild. So I guess that they would be my two recommendations, is to continue looking at the regulation to maintain some consistency across those, NDIS providers aligning with aged care providers, because that's what is required. You've already heard it from both of my colleagues here, is that diversification of funding has allowed us to maintain our viability, but maintaining that regulation and even just the child safety requirements under aged care is different to what is required under our community transport, which is different to what is required for NDIS. And so you're kind of constantly researching and making sure that you're going to meet the regulation for all of the different requirements.
Thank you. I just have one final question, because most of my others have been canvassed already. We've talked a lot about, not just in this session, but in the previous sessions, about the challenges in remote and regional markets. One of the things the government has done, I suppose, in recognition of those challenges is we've run 3 separate rounds of thin market grants to support service provision to older Australians outside of metropolitan areas. And there's a dedicated stream of those grants for services to Aboriginal and Torres Strait Islander communities. I think the most recent round was over $311 million. Could you talk to those grant rounds? I think one of the witnesses, I'm not quite sure, mentioned it before.
And I'll talk
some
to
of the
it.
challenges that prevent. Yeah, please do, Ms. Lynch. Thank you.
Yeah. Look, we recognise that and thank very much the government for putting in place those requirements. I think what we would advocate for is, instead of a grant round, that they are embedded in the pricing and recognition of regional loadings required. There is regional loading for 6 and 7 for further out, but the reality is, for regional service provision, is many of the things that add cost actually happen whether you're close to somewhere like I'm sitting in Albury-Wodonga at the moment, but much of the cost for the smaller towns that access Albury-Wodonga as their major centre, it still exists for us as a regional provider. In order to deliver those services, there are fees that are whether it's training staff when you haven't got a lot of staff, whether it's being able to get petrol, and whether it's driving cars out to and returning from a service, and you aren't able to pay for the return for the staff member because it's exceeded a certain distance, that sort of thing. So I think what would be super useful is, instead of it having a grant round application, that there's just simply an acknowledgement of the true cost of regional service delivery and embed that in a unit cost. And I would also just say that whilst a grant application process is appreciated, it does require more work. So you're again doing another process to recover costs that you've already incurred. So it would be far more useful not to have to do that, because it does add another layer of administrative burden onto providers, and that cost doesn't go away. That cost is going to be there for us forever, regardless of whether you've got a grant funding around for a short period of time. So far more useful would be to put it in the reflect true cost of regional service delivery in a loading for all of the regional areas, not just the ones that are very remote.
Thank
you. If I could add to that, please, Senator, that and they're one-off too, which is they're super valuable. Don't get us wrong. Grants that help support and increase the capacity to do and provide services on top of the current allocation of funding under CHSP or Support Home is invaluable, because the reality is there hasn't really been any growth in grant funding under CHSP and Support Home, because it's actually reducing in real terms or the cost of living. So what that means is you can find yourself in a false economy where it's used as a potential top-up to continue service delivery, then it ends and you've got to find a supplement then thereafter or scale back. So I agree with the last comments in terms of adding it to the current service envelope for continuity, so that organisations can continue with that service delivery and increase the ability to service capacity, because over the last 3 or 4 years, it's been about adjusting the outputs rather than an increment in funding to support the service delivery directly.
Thank you. Thanks, Chair.
Can I say thank you very much to our witnesses from Kirinari Community Services and Northwestern Remote Health for your evidence today. It's very much appreciated. The committee will report to the Senate on the 24th of November 2026, and we've agreed that responses to questions on notice should be provided by close of business on Friday, the 14th of August 2026. Thanks very much, and as someone who has lived remotely and still lives regionally, thank you very much for all the work that you do to provide really important services to people across remote and rural and regional areas of both Queensland and the rest of the country. Thank you.
Thank you.
Pleasure. Thank you.
Yeah. I now welcome representatives from Ethnic Communities Council of Queensland and the Federation of Ethnic Communities Councils of Australia. Thank you very much for appearing before the Senate Committee again today. I understand that information on parliamentary privilege and the protection and obligations of witnesses giving evidence to Senate committees has been provided to you. I'm just trying not to cough while I'm also trying to speak to you. For the Hansard record, could you each state your full name and the capacity in which you're appearing, and I'll go left to right.
I'm Priyanka. I am the Executive Director from the Federation of Ethnic Communities Council of Australia.
Please don't wait on my account.
That's okay. My name's Mrs. Lisa Ward. Unfortunately, I'm not a doctor, but anyway, thank you for the recognition. I'm the CEO of Ethnic Communities Council here in Queensland.
I'm going to ask each of you to make a short opening statement and then we'll go to questions. So, Ms. Ray.
Thank you, members of the committee. Thank you for the opportunity to appear today. My name is Priyanka and I'm appearing on behalf of FECA, which is the national peak body representing Australia's culturally and linguistically diverse communities for the past 50 years. We are also the national peak body for multicultural older people and carers. Over the past year, FECA has engaged directly with multicultural older people, their families and carers, community organisations and aged care service providers across the country to understand how the aged care system is working in practice. Since April 2025, we have undertaken consultations in every state and territory across metropolitan, regional and remote communities, directly engaging with thousands of people from more than 50 countries of origin. It is those community voices that I bring to you here today. In Alice Springs, I met a devoted son caring for his 85-year-old mother. She was living with significant health needs, was wheelchair-bound, and was receiving aged care support. He was her primary carer and was approaching an age where he may soon need support himself. He was not asking for special treatment. He was asking someone to help him understand what supports existed, where to begin, and how to navigate the system so he could continue caring safely for his mother, who was at this point only on a level 2 package. He simply did not know where to turn. That experience was not isolated. We continue to meet older people who have lived in Australia for decades, raised families, worked, paid taxes, and contributed deeply to Australian society, yet do not know they may be entitled to aged care support. That should concern all of us. By now, 1 in 4 older people receiving aged care services is expected to come from a culturally and linguistically diverse background. In other words, 1/4 of the people relying on aged care in Australia. 4 years ago, the Royal Commission into Aged Care Quality and Safety called for an aged care system built on inclusiveness and cultural safety. The Commission recognised that older Australians require personalised care that responds to their cultural circumstances and needs. Yet the evidence we are hearing suggests that for far too many multicultural older Australians, that promise has not yet come to practice. Many people told us they do not feel heard. As one older community member told us, I was assessed for support, but I still did not understand what I was entitled to, what it would cost, or who could help me. I felt lost in the system. That phrase, lost in the system, captures what we heard repeatedly during our consultations across the country. Too often we reduce this discussion to translation alone. But for many multicultural older people, the issue is broader than just language. The system is not always designed in a way that people can understand, navigate, or access. Barriers arise across the entire pathway. People may not know what supports exist. They may struggle to navigate my aged care. They may not receive information in a language or format that they understand. Their cultural and family circumstances may not be fully understood or recognized in the assessment processes. They may not understand service agreements, contributions, or how much support their package will actually purchase. Even after assessments, they may struggle to find a provider or a worker they can communicate with and trust. These are not minor administrative difficulties. They determine whether an entitlement becomes actual care. In Tasmania, we heard about an older person who had been assessed as requiring support but did not fully understand the service agreement, contribution arrangements, or how much their budget would purchase. Concerned about the cost, they reduced the services that they had been assessed as needing. On paper, it looks like a choice. In reality, it was a consequence of confusion and concern about cost. The need did not disappear. The responsibility merely shifted to family members who absorbed additional unpaid caring responsibilities alongside their own work, health, and family commitments. In another case, FECA heard from an older person who had been assessed as eligible for home care, but was told that a provider could not accept them because they required language support. The issue was eventually resolved, but it raises an important question. How many older people are assessed as eligible for support, yet are unable to access it in practice? And how many simply give up before those barriers are ever recorded? We also heard about a Vietnamese couple, both in their 90s. One spouse could not be safely discharged from hospital because appropriate home support was not in place. At the same time, the other spouse was hospitalized following a fall. This demonstrates why aged care and healthcare cannot be viewed in isolation. And when support is not available at the point of need, the consequences extend far beyond the home. They are felt in hospitals, in emergency departments, family households, and ultimately in the broader health and aged care system. These examples reveal the same structural problems. An older person can be eligible for support and still be unable to understand it, afford it, or access it in practice. A service can exist technically while remaining inaccessible in reality. When this occurs, the risk is again transferred to older people, family carers, hospitals, and the wider system. Family care is a source of strength in many multicultural communities, but it should never be mistaken for an unlimited resource. Many carers are themselves old. They may be managing health conditions, participating in paid work, raising children, or providing care that has become physically and emotionally unsustainable. Research consistently shows culturally and linguistically diverse carers experience high levels of stress and unmet need. The system must also recognize that culturally responsive care involves more than translating information. It may require qualified interpreters, culturally informed assessments, additional time to explain complex decisions, family liaison, cultural brokerage, and support to connect older people with workers they understand and trust. For some communities, multicultural and ethno-specific providers are not simply one option among many. They may be the only practical, accessible source of care in a person's language and cultural context. This is why cultural and linguistic thin markets can exist in metropolitan Australia as well as regional and remote communities. In summing this up, FECA asked the committee to focus on 3 principles. First, equity must be designed into access and assessment. Older people need trusted community-based entry points, qualified language assistance, assessments, and that recognize culture, family circumstances, and the actual capacity of family carers. Access should not depend on English proficiency, digital literacy, or confidence in navigating government system. Second, choice must be genuine. A person has not exercised meaningful choice when they reduce services because they did not understand the costs, cannot afford the contribution, or cannot locate a suitable provider. Older people need clear and accessible information, effective hardship protection, and independent advocacy. Third, culturally responsive services and workers must be recognized as essential infrastructure. Multicultural organization, ethno-specific providers, bilingual and bicultural workers, and community navigators hold expertise, trust, and relationships that cannot be easily recreated once lost. Their role must be recognized in funding, workforce planning, pricing, market stewardship, and accountability arrangements. We are not asking for a separate aged care system. We are asking for an aged care system that works equitably for the diverse population it already serves. The true test of support at home is not how many people are approved for support, but how many are actually able to access and use that support safely, effectively, and with dignity. We urge the committee to ensure that equity, cultural responsiveness and accountability are embedded in the design, funding and delivery of support at home from the outset. That means investing in trusted, community-based access pathways, strengthening language and navigation supports, recognizing the roles of multicultural and ethno-specific providers, and ensuring family carers are not left to fill gaps in the system. Our message is simple. If support at home is to deliver on the promise of the new Aged Care Act, equity must be designed in, not tacked on later. The experiences we have heard across Australia show that without deliberate action, too many multicultural older Australians will remain eligible for care on paper but unable to access it in practice.
Thank you. Mrs. Ward.
Thank you. Thank you, Chair and Senators, for the opportunity to appear today. My name is Lisa Ward and I'm the Chief Executive Officer of the Ethnic Communities Council of Queensland. We are the multicultural peak body and are also an aged care provider. Through our home care and residential aged care service, we support older people from many different cultural backgrounds every day. Working across both policy and service delivery gives us a unique perspective. We see not only how the system is designed, but how it is experienced by older people and their families. One observation that has stayed with me since support at home has evolved is that workforce obviously matters, our funding matters, and compliance and technology matter. And they're all essential to the safe and sustainable service. But they are not the reason aged care exists in the first place. Older people experience aged care through relationships, whether they feel safe, respected and understood, and whether the care that they receive enables them to continue to living the life that matters to them. The Royal Commission challenged us to build a rights-based, human-centred aged care system. My concern is that as we have built a more complex system around the person, we may have unintendedly made the system itself the focus. One of our team recently supported a Vietnamese couple. Both went through the same assessment process. The wife openly described the support that she needed and was assessed at a level 3. Her husband, who had greater clinical needs, but throughout his assessment, he repeatedly said he was fine, he did not want to burden anyone, and he did not want to appear weak. Those responses reflected his values, his culture and his life experiences, and he was assessed as a level 1. It wasn't that the assessment had been done badly, it was the same process and it produced 2 very different outcomes. An interpreter was available, so the issue was not language, it was understanding the person behind the words. Our team then spent weeks building trust with the family, explaining the assessment outcome, coordinating interpreters, gathering additional information, and advocating for reassessment. None of that work was incidental, and from that family's perspective, that was the care. It also highlighted something we see more broadly. Support at home is a complex system for many older Australians. For multicultural old Australians, that complexity is often compounded by language, culture, health literacy, previous experiences with government systems, and different expectations about family care. Treating everyone the same does not always produce equitable outcomes. Person-centred care means recognising that different people need different approaches to achieve the same outcome. That has implications for how we fund and measure care. The current care management allocation does not adequately recognise the additional time required for interpretation, cultural brokerage, family engagement, advocacy and navigation. Yet these activities are often what enable older people to safely access and benefit from care. Government has also recognised the concept of multicultural thin markets by providing additional funding to some organisations, and we welcome that recognition. However, Australia's aged care sector is becoming increasingly multicultural. Every provider is now, to some extent, a multicultural provider. If culturally responsive care is expected across the sector, then we need to ensure the system recognises and supports what it actually takes to deliver it. Otherwise, the unintended consequences is that providers default to a one-size-fits-all model, not because of the lack of commitment, but because that is what the funding model makes possible. So I encourage the committee to keep asking the question the Royal Commission asked us to do. What does the older person need to live the life that matters to them? Because culturally responsive care is not something separate from personal care, person-centred care. In a multicultural Australia, it is person-centred care. If we design a system that genuinely works for the older Australians who find it hardest to navigate, we believe we'll build a better aged care system for everyone. Thank you.
Thank you very much. And I'm going to start with Senator Ananda Raja.
Thank you, Chair. And thank you both for the work you do in culturally diverse communities. I think you've nicely outlined some of the challenges that these communities face in terms of health literacy and navigating what can be a difficult system. But look, I mean, I'm just cognizant, though, that our communities are so diverse. How do we develop solutions that are actually scalable and practical, that can be delivered within the resources that we have? We can't be everything to everyone. So have you thought through of, some types of sort of solutions that are broad-based that can be used for such a diverse community without, I think, it's important for us to make concessions for culturally diverse communities, but we can't be everything to everyone. It's just not possible.
From my perspective, human-centred care is exactly what we need. So we've all got diverse experience, so First Nations, multicultural, but also rural, regional, remote, men, women. We all have very different needs and cultures. And if we put a one-size-fits-all model in place, it's going to be incredibly difficult to create a system that really is equitable. So as I mentioned before, I think we actually need to design the system around the people who find the system more complex to navigate rather than the people who understand and are able to navigate the system with some level of, I wouldn't say anybody is finding this system actually simple, but someone who finds it easier than other people and don't have those actual barriers.
So what does that look like practically? Are you talking about training healthcare workers or...
I think it all starts at the individual assessment. It starts at the individual assessment that happens at the very beginning of the program. If we are not really considering the way the questions are being asked of the individuals undertaking the assessment and understanding that they may, due to language and different cultural barriers, and as I say again, men might find it more difficult to talk about, do they need continence care than a woman, for example, let alone somebody who comes from a more conservative background. So I think it's, instead of just having questions and that they are being asked, that the way the system needs to work is there needs to be a level of compassion and a level of understanding that they might not have a clinical background and used to being asked these questions. So how do we strip it back and give dignity to the person from the outset?
And I can add to that. I think we face...
Can I just also caution you? Look, human-centred care is something that we all aspire to. Sorry, I just
was going to let
keep it focused on answering the question around, rather than I'd rather we avoid motherhood statements and really just get to some pragmatic solutions if you do have them.
If I could just let Ms. Ray answer as well, and then we'll...
So we've faced similar issues in reaching out to multicultural communities and other sort of priority issues for government, for instance with COVID, where we knew our health promotional messages was not going down to multicultural communities and uptake of vaccinations weren't happening. And I think the answer to that wasn't just the mandate, that was the system response to an issue, but we also did work with multicultural communities and built the capacity around that health information and that health literacy. So we worked in partnership with community leaders, with community organizations that more than 200 plus communities already trusted, to work with them to bring them closer to that point where they understood the need for the vaccine. And I think that's a lot of that work is happening in community already, where peak bodies like ECCQ are working with communities to make them aware of what aging in Australia looks like and what does rights-based care even mean. I think we've got to recognize that this is, for people who migrated to Australia in the late 1970s, after the end of the White Australia policy, this is the first time they're experiencing aging in this country. They don't have a collective memory of what aging looks like. They don't have a grand aunt or an uncle that they know went into aged care. So they're all actually navigating this for the first time. And their expectation of aging is from their country of origin, where there was a lot of unpaid labor provided by families and living in that almost village kind setting, which just isn't realistic in Australia. So we have to do that. Almost that aging literacy needs to be developed within these communities, and that's not an expensive exercise, it's a capacity development exercise, but once communities take ownership of that, it should be easier.
Do you have any models that you could turn to actually that speak to that engagement with communities, developing new models of care for these communities?
COVID. Yeah, so just COVID. So what happened during COVID? We partnered with.
Yeah, no, I'm familiar. I don't want you to repeat that. I am familiar with COVID.
We're working on the national lung cancer screening campaign. Again, another issue which has a lot of stigma, not a lot of cultural recognition, but a preventable condition. And we're working with communities directly to build those culturally safe spaces where they can have conversations around cervical cancer. Self-collection of the swabs. So encouraging communities to understand this is an issue and make this something that is integrated as part of their journey within Australia. But that capacity development does need investment.
So what kind of solutions, again, just going back to solutions, what can the committee consider in terms of making the aged care system a little bit easier to navigate for people from culturally and linguistically diverse backgrounds?
Well, investing in that capacity development, that the rights-based aged care is a very unique construct of a country which has universal health care. But for someone who's migrated from a country where aged care is always seen as a community responsibility, just like what Lisa pointed out, we see it day in and day out where couples live together. The man doesn't have basic skills of cooking and cleaning, but in an assessment, he'll say, yep, I can do all of that because he's relying on this partner. And when that partner is in hospital or disappears, there's a crisis in the family. So this education, that what does rights-based mean, even that understanding of what are your rights, and as an individual, what should you be able to do in community by yourself. I think there's a lot of development to do in order to get multicultural communities to that point where they can actually advocate for their rights within the system.
So in terms of specific solutions, do you have any thoughts on what specific solutions the committee should contemplate?
Partnering with community-based organizations, providing them with the resources, with the capacity to do that peer education into their communities. This is not something that we think needs to be only the responsibility of government. I think communities are keen and eager to learn how to navigate the systems, and working with carers, so working with that generation below, helping them understand that these are needs. We meet a lot of carers who don't understand that if their parents are in hospital and the supports don't exist in community, they will not be discharged. This is not an understanding that a lot of families have. So doing that education and awareness is vital.
Thanks, Chair.
Thank you. I want to sort of, I guess, come back up to the bigger picture, and it seems to me that we're moving towards a system that is valuing standardisation and efficiency. Like, we hear that around the integrated assessment tool, that the reason we have this tool is because things were, quote unquote, unfair because there were more people getting services in some places than others. We've also got a system that's highly complex. I'm interested, maybe from you, Ms. Ward, in particular, Mrs. Ward, because you are delivering care. Can you highlight aspects of the new system that are actually detracting from rather than improving people's quality of life and care, which are probably exacerbated if you are someone from a culturally and linguistically diverse community, but are no doubt also being felt by others?
I do want to go back to the individual assessment tool.
I'm very happy if you want to start there.
Yeah. I understand that there needs to be a level of consistency, and that is where a tool is very important, but we really need someone who overlays that with that professional judgment rather than to replace it. So I think there needs to be that, but you need an override system for it. Look, we know that the tool, and it's been evidenced by even the government's evaluation, that it doesn't pick up the cultural context, the trauma, the communication barriers, or the complexity of someone's circumstances within it. So I think that's one area that's really important. The amount of work that we are finding our care partners doing to actually come back and work with the participants to ensure that they get the care that they need when they need it. We often hear, because of the timeframes as well for reassessment and how hard it is to get another reassessment. Unfortunately, we are finding that people are passing away or ending out in the hospital system or in residential aged care, but often it's not even in residential aged care, it's the hospitals all passing before they've even had their reassessment done, let alone having the care provided to them. We're finding as well a number of people, particularly those that have been grandfathered and moved over into the system, because of the way, I know it's meant to be a no worse off, but there certainly is a worse off, and it's largely around the lack of transparency and of how administration is built in to the hourly rate. So we are finding that previously they might have had like allied health care as well as some general domestic assistance at home, and we are having care partners sit down with them and work out within the budget that they've got what do they need to now forgo or pay for themselves, and that is one of the areas that we see more often than not. We are often trying to work out other ways in which the service can be provided, and that's I think one of the previous people that spoke had mentioned that's where community home support program could provide those more flexible needs and less clinical needs, and where support at home can step in and support the more clinical or higher need areas. We also find that people are getting domestic assistance, and because of the way that the system's been set up, that's generally dusting and vacuuming and maybe unpacking the dishwasher. However, getting up and cleaning fans, ceiling fans, or getting on their hands and knees and scrubbing or moving furniture isn't realistically part of what's being paid for. And so we're finding that participants are actually moving furniture or getting up on step ladders and then hurting themselves and ending out in the aged care system. So, in the hospital system because of an injury, and that falls often cause a huge backshift in how they're going. So there's some of the things that we're finding is really impacting on the ground.
I'm conscious of time, but I might just invite you if there's anything else that we haven't asked you that you wanted the committee to know before we finish this panel.
I think just the change in complexity. So even getting multicultural seniors to wrap their head around the idea of 4 levels of aged care packages was a lot, and we are finding now with the with the changes and the 8 levels, the clinical, the contribution, that whole constructs become really complex for them to navigate, and they're often just opting out. And I think for a lot of communities, like they're going, like we've heard people say, well, if I go through the support at home, I'm paying $100 an hour for domestic care. I might as well just not bother participating in the system and get that outside. But what they don't recognize is that means they're not in the system.
Yes.
So when that need does arise, so what was supposed to be an easy entry point into get basic support and then escalate that care as you need, even that entry point has become so hard that people are not engaging with the system. And we're not going to see the backwash of that till it's too late. So I think we really need to recognize that we don't even have the data to demonstrate how this complexity is now going to become a risk.
Thank you. Did you have one more thing you wanted to add?
Yeah, I just think I reinstate what I said in my opening statement. I think with the complexity that we're managing at the moment, I think we're really at risk of forgetting the individual who we're providing care for at the centre. So, yeah.
Thank you. Can I thank you both for your time in giving evidence today? It's very much appreciated. The committee is going to be reporting to the Senate on the 24th of November 2026. I don't believe we took any questions on notice in this session, but they are due on Friday, 14th of August. So thank you again. Really appreciate your time in coming and giving us evidence today. We are now going to suspend and we will come back at 1:25 p.m. The committee will now resume. Apologies for being a couple of minutes late. I now welcome a representative from the Shire of Flinders via video conference this afternoon. I understand that thank you for appearing before us today, and I understand that information on parliamentary privilege and the protection and obligations of witnesses giving evidence to Senate committees has been provided to you. For the Hansard record, could you please state your full name and the capacity in which you're appearing this afternoon? I think they're just looking for that. Ms Smith, just noting that you're on mute.
Sorry, I'm just trying to sort out my sound.
We can hear you clearly.
Yeah, sorry, can you hear me okay?
Yes, we can.
Yes, okay, sorry about that.
No, it's totally fine.
Sorry, you happy if I start?
Yes, so if you could just begin by stating your full name and the capacity in which you're appearing today.
Yeah, so my name is Barbara Smith. I'm the Director of Community Services and Wellbeing with Flinders Shire Council.
Thank you. I'm now going to invite you, Ms Smith, to make a short opening statement, and at the conclusion of your remarks, we'll go to questions from senators.
No worries. Thank you for the opportunity to appear before the committee today. As I mentioned, my name is Barbara Smith and I represent Flinders Shire Council in North West Queensland. We are a sole provider of aged care services in our remote community, delivering both CHSP and supported home services. While aged care is traditionally not a local government function, our council continues to deliver these services because there is no alternative provider available. Despite receiving thin market funding and support through the Service Development Assistance Panel, Council still subsidises our aged care service delivery by about $200,000 each year to ensure our residents have access to the care they need at home. At the outset, I'd like to acknowledge that we support the intent behind the supported home reform and the goal of keeping older Australians safely at home and independently in our community. However, from our experience as a small remote provider, there are several challenges that are creating inequitable outcomes for rural and remote communities through this reform. Firstly, the cost of delivering aged care in remote Australia is significantly higher due to workforce shortages, travel distances, and the absence of economies of scale. At the same time, providers are operating with caps on administration and care management funding while managing increasing compliance and reporting requirements. For small providers, it's becoming increasingly difficult to remain financially viable without increasing service costs or seeking alternative sources of funding. This leads to our second concern. Because client contributions are linked to cost of service delivery, older Australians in remote communities can end up paying higher out-of-pocket costs for the same service simply because it costs more to deliver. This creates an unintended inequity for people already facing higher costs of living and reduced access to services. Alternatively, providers such as ours often make a conscious decision to try and keep our service prices as low as possible to reduce the financial burden on our clients, knowing this then keeps the contribution costs down. However, absorbing these additional costs places further pressure on our provider viability and is not sustainable in the long term. While financial hardship assistance is available under the scheme, we get to have a single client approved, despite supporting a number of clients experiencing genuine hardship. Thin markets are also a critical issue. In communities like ours, there's often only one provider. If that provider withdraws from a service category, there may be no alternative provider available to fill the gap, creating service continuity and increasing reliance on local hospitals and primary health services. Finally, we're concerned that some of our most vulnerable residents, including First Nations elders, are accessing support later, often when their circumstances become more complex and urgent. CHSP services continue to play a vital role in building this trust and connection with people to support them before they reach real crisis. To address some of these challenges, we're asking the committee to consider reviewing the pricing and contribution arrangements to ensure that rural and remote older Australians are not disadvantaged by higher service delivery costs. Strengthen the support for thin market providers, including extending the SDAP support, reviewing thin market funding arrangements, and considering proportionate compliance requirements for small providers. Implementing stronger oversight of service availability within thin market communities to identify and address service gaps before older Australians lose access to this essential care, and continue to support entry-level services such as CHSP, which help people to engage early and remain safe at home for longer. Thank you, and I welcome questions.
Thank you very much. I'm going to go to Senator Ruston to kick us off.
Thank you very much for your contribution. Obviously, you have a very specific interest in terms of your location of where you operate. I'm just interested in maybe getting a little bit more information around how you see the Commonwealth Home Support Program working within the structure that exists in your community, and what fears or concerns you might have if that program is no longer continued.
Yeah, look, I guess it's a few different elements to that. I guess Commonwealth Home Support is a really flexible program, and it can be used as a way of supporting people quite easily if they're looking for sort of entry-level services such as lawn mowing or social support. We do obviously now, it's interesting with the new pricing model under Support at Home. It typically used to be that our package clients were the haves and the CHSPs were the have-nots because they were required to pay contribution fees. However, now that's really flipped on its head, and we're seeing that a lot of our clients are actually opting to remain on CHSP purely because of the financial costs associated. It's just for some context, we had a client just recently who was budgeted for a monthly budget contribution under Support at Home at $2,000 per month, whereas that same service, amount of service delivery under CHSP was $300. So it is a considerable change.
Is that their contribution or the cost of the service?
That's their contribution.
$2,000 a month.
Yep.
I know I don't want to give you any more work than you've already got, but is there any way that you could provide us with a couple of cameos? Obviously, completely de-identify them. We wouldn't like you to be identifying your older Australians that you look after, but to actually have a comparator in terms of $2,000 per month for a delivery of a same service that was otherwise charged at $300 in terms of their payment under CHSP. It would also be interesting to understand what the cost of the provision of that same service was, because if you're charging $300, I'm imagining that your payment that you receive from the government in order to provide that service isn't $1,700 a month. So the question would really have to be, how have we got this incredible discrepancy? So if you could provide us with more detail around that, that would be brilliant. And any other examples that you can use where it appears that people are paying a lot more than what they previously paid for exactly the same service, and secondly, where a service is being charged significantly at a significantly higher rate than in Support at Home as opposed to CHSP. That would be amazing. So to that end, you made a comment in your opening contribution about compliance requirements in terms of the incredible burden of compliance requirements. I mean, nobody wants for there to be, a poor cousin reporting requirements, but you obviously believe that some of the reporting requirements and compliance requirements that are required of you are not necessary, because I'm sure you wouldn't be saying not to do them if you thought they were necessary. So do you have a sort of a list of the things that you do that you believe, if you were given an exemption not to have to do, would have absolutely no bearing on the output and support that you gave the people you care for?
Yeah, look, I think, and look, I'm not suggesting that we still wouldn't be held up to a standard of delivering quality and safe services. I guess it's just trying to illustrate, the context with which we're operating in, with a very small administration team trying to keep pace with a lot of the reform changes that are coming. And certainly, I think I'm happy to sort of take that on notice and give a bit more of a breakdown for you. But just in terms of some of the things that I've been doing with my morning, there's some changes in DEX reporting requirements that we're now required to update a lot more data on the back end for our CHSP reporting requirements. Now, it's not just a simple flick of the switch on our system, it's literally going into each of those items to then update the back end of our system that then reports through to DEX. I think sometimes these changes come and they come at a very rapid pace, and it's really unclear to see what's actually going to be done with some of this data in the long term by the department. How is it going to be reported, and whether on this trajectory transitional change that we're undertaking, is this really the necessary focus that we need to have right now in the change? We're obviously already also preparing for our re-registration process, all of our financial auditing processes. I'm not saying we wouldn't need to comply with those sorts of things, but the changes are going at a rapid pace, and it's not necessarily, we're not necessarily feeling like all of the requirements of us as a service are being taken into consideration when the change dates are being put in place.
Yeah, I mean, whilst I have an incredible amount of sympathy for what you're saying, I would contend that if there are reporting requirements that are not actually doing anything apart from duplicating, reporting, etc., I don't care whether you're big, small, or indifferent. Why would we be having providers doing something unnecessarily when they could be investing that time in providing care? You made comments around how you think that funding changes need to be considered to make sure that they reflect the cost of delivery of services in more shallow communities. Have you, just pouring more money in across the board is always a very blunt way to respond to things. Have you given any thought to how you would like to see those funding changes put in place more generally?
Yeah, I think I have been thinking about this, and really potentially with the transition to set funding, there is actually an opportunity to look at actually what that will then mean for clients of rural and remote services. So my thinking is that regardless of whether a person is required to pay a contribution fee, that your rate, that the service rate is still set at a maximum cap. So what that might mean is that the average service cost of DA in a metro area might be $100, and the client's required to pay 50% contribution for that. They're paying $50, whereas in a rural and remote community, it might be $150 for that same service. That service fee would still be, that contribution fee would still be set at $50 for the client, and then that gap would then be covered under their support at home arrangement.
I mean, it does go to the very basis of the means testing arrangements that sit around support at home. It's not really means testing. It's a percentage contribution of a service being delivered. It's not really taking into account capacity to pay. That's all from me, Chair. Thanks.
Thanks.
Thank you very much, Barbara.
Thanks, Senator Ruston. Ms. Smith, it's just occurred to me that you're here representing a council that's providing aged care services, which is increasingly becoming very rare, especially in Queensland. I'm wondering if you could speak to what it would mean if Flinders Council could no longer financially be viable to provide those services. Would I be correct in assuming that you're one of the only providers and possibly the only provider for people around Hughenden and Western Queensland?
Yeah, that's right. We are the only supported home provider here. And while we do have an allied health provider available to deliver CHSP, there's no other CHSP provider either. So this is, the fact how thin our market is very, very concerning for us. Council really wants, we have an ageing population. It's extremely important for us that our people have access to the services that they need. However, yes, it is getting increasingly more challenging. As part of this transition to support at home, our council was previously providing nursing services as part of our registration. We did, however, as part of our review of what our capacity was, is decided to relinquish service delivery under nursing. That's then resulted in an unintended consequence that now we have no service for nursing for our clients. We were of the assumption, I guess, through the transition to support at home that the new program would allow for additional providers to come into the market, specialist providers of nursing care to come into the market, and that really hasn't happened. We've found now that we have clients under support at home that do require nursing consumables, for example, disposable continence aids, very common nursing consumable, now can't be purchased under their support at home program package because we don't deliver nursing services and there's no one else to deliver that. Another thing that we have sort of unpicked as part of this process is that it really does favour services that are able to provide the suite of service delivery over all categories, including care management. So even if we did have a provider come in that wanted to provide just nursing services, our clients would essentially have to choose who they wanted their service provider to be, whether it be the nursing provider or us that can provide the other services. So it's really opened up quite a significant gap for us. We are leaning a lot on the hospital service and our GP practice, which obviously that cost shifting is not what was intended by the reform. So it's council is obviously committed to staying in it as long as we can to ensure that our community receive the services, but we really don't feel that it is, as you mentioned, becoming more and more trickier. I think there's definitely an opportunity where when a provider is exiting a particular category, I'm not sure who's monitoring it, who's letting anyone know that gap now exists and that there is an opportunity. I guess that was over nearly 12 months ago now and nothing has sort of happened. In terms of sort of transition out support, if council ever got to the point where it sort of became too much, we definitely feel like the burden is on our shoulders to try and resolve the issue rather than any kind of the market dictating and seeing the need. That's for sure.
Yeah, and I guess that's typical of what many councils around the country are doing, right? Like not just in aged care, but trying to fill service gaps where state and federal governments are failing communities, and you're trying to fill them with less and less resources. If I can just go back to the cost example that you gave to Senator Ruston around the $300 for the services versus $2,000 a month. Could you just unpack for me a little bit more where that differential comes in? Because as you were saying, that's the difference in the contribution that someone is having to pay. Is that because you're getting then more funding for the CHSP provision of service, or is it because of the scale and block funding that brings the cost per unit down when it's provided under CHSP?
Yeah, so CHSP, the services are co-contribution rates we set at $12 per hour, regardless of means testing. So with this particular client, they receive quite a significant portion of domestic assistance hours under their support at home. Being means tested and being a self-funded retiree, they were on the 80% requirement for domestic assistance, which was coming out then at a $80 contribution compared to a $12 contribution under CHSP. With that particular example, I am happy to de-identify it and give you some more tangible explanation for that, and perhaps there is some other examples we can give. We do find that we are a predominantly agricultural region. We have a lot of our clients that are asset rich, but not necessarily, they don't have the disposable income to be affording the contribution fees, that's for sure.
Mm-hmm. Thank you. I might share the call and I'll go to Senator Ananda Raja.
Thank you, Chair. Ms. Smith, with regards to the thin market that you serve, I understand that there is a grant system, a thin markets grant program. It's around $311 million. I just want to find out whether you've accessed this and how you found the process, and whether these sorts of flexible funding options have been helpful, and what else the government should consider.
Yes, I commend the government. I think the thin market grant is fantastic. We do access it. My one gripe with it is that it is a competitive grant process that we go through. So, when we're talking about limited and finite resourcing, even going through that process is yet another thing that we need to do. It is a simple application process, but I believe that with the data that we're reporting through to the department, I think that information would be easily available on, our number of clients and that sort of thing at point in time. So, I'd like to see that it just becomes a ongoing funding that we can then sort of account for, and there's no sort of ambiguity whether we're going to receive it or not, something that we can definitely budget for. But yes, it has been extremely helpful and supports 50% of our administration costs, which is wonderful.
Just to the point of the process, can you perhaps step us through the process? And, we are interested in cutting red tape. If you're having to duplicate information that the department should already have, that is something the committee should be, I think, should consider looking into.
Yeah. So basing this off round 2, so I was actually just this afternoon, I need to do my round 3 application. So round 2, you're required to go into a grants portal, export an Excel template. They then ask you at point in time, how many clients you have registered under each support at home category. That then equates to a financial dollar figure per client. You then have to sort of upload that to the portal and then wait to get your letter in a few months' time to see whether you're successful or not. So it's not the worst grant application I've ever seen, but I think it's it's just another example of a process that might be unnecessary.
So if I this is correct, you're inputting data of your caseload and case mix, perhaps. Is there anything more than that, like a justification as to why you need the grant, a narrative or a?
I think what you're going to be spending the money on. Yeah.
Right. Yeah. Okay.
Yeah.
It sounds like, I'm not sure. Would the department already have this data? I mean, you're having to input it. Wouldn't they already have the data?
Well, we report monthly through Services Australia for all of our current clients who are receiving services. Services Australia have all of the information about, which clients are registered to our service. So, the My Aged Care provider portal would also have the clients associated with our service. So I think so. I imagine most providers are using the funding just to fund their administration, their software costs, their staffing.
And with these rounds, are they annual, or is it every few months? Or is it?
I think it's every 6 months they come out.
Okay, so you're getting a tranche of funding.
Yeah.
Okay. It's not clear to me why you're having to reapply. I mean, if you're successful once, then you're clearly in a thin market and you have a group of population that you're serving. So why do you have to keep applying is my question. What are your thoughts?
No, it baffles me too. I think potentially, like the changes in the number of clients we might have can vary. I mean, for us, it might be 1 or 2 people that then changes the total amount. It is also where specialist service providers, like those that are providing to culturally and linguistically diverse or some of those more specialised supports, do also apply. But same thing, I think that data is readily available sort of point in time to the department, I would have thought. So.
Okay. You mentioned earlier continence aids. Are you familiar with the CAPS program, the continence aids payment scheme? And do your clients use this? My understanding is that it provides a payment to eligible people with permanent and severe incontinence to assist with a portion of the cost of their continence products.
And is it eligible? Sorry, I'm not 100% sure of that. I know in Queensland
it might be something.
program.
It might be something worth looking into, which may benefit some of your clients.
Yeah, because we do find some of the sort of so Queensland Health do have a program called the MASS program, but people that are support at home clients aren't eligible to access that program. But yeah, I'll definitely have a look into CAPS. So thank you.
Okay, thank you, Chair.
Thank you. Did you have any questions, Senator Askew?
No, fine, thanks.
Okay.
And that's mine.
Ms. Smith, I really would just like, I guess, to give you the opportunity before we finish this panel of whether there are any aspects that we haven't asked you questions about but you would like to get on the record that are particularly relevant to the service that you offer and the challenges that you face?
Yes, I guess probably just reiterating the sort of critical nature, I guess, that thin markets are experiencing. I really think that there needs to be a lot more sort of governance and oversight, in terms of the sustainability of those services and supporting to fill any gaps that might exist, just so there is that service continuity and that people aren't at risk of losing services altogether. The risk I see is essentially we're now being given an opportunity as a provider to decide whether we want to re-register or not.
Yeah.
Obviously, there's no other provider. Our council will continue to do so, but I see there being a huge risk that a service provider could just say no, and then what happens? And I just think from my experience that I've seen with us relinquishing nursing services, no one was really monitoring that or making sure that gap was filled. So I think that's a piece of work I would really strongly encourage to happen. And the other thing I wanted to touch on, and I guess I am really grateful for being a recipient of the support through the SDAP panel. I think that's a really great support to rural and remote providers, and we've been benefited from it twice over the last 5 years. I really think that support, if we could have it extended to for even another 12 months to help us navigate this reform change. Our service is probably one of the more lucky ones. We've had sort of stable leadership and a stable staffing within admin for a little while now, but we're still struggling to keep up with the rate and the pace of the change. So what SDAP has provided us is some consultancy support to really embed these changes and make sure that our service is sort of set up for success. But that funding for us, or that support for us, is coming to an end shortly. And I feel like there's still a lot of rapid change that we're going to go through moving forward. So I think they're sort of the main things I wanted to touch on, and I'm really grateful for the opportunity to have a talk with you today. So thank you.
Thank you. And look, can I say thank you very much for taking time too, because as I said, it's becoming a real rarity now, especially in Queensland, for any councils to be offering aged care services. So it's really important to hear evidence from your perspective and what it means for you and your community and the people that it serves. So thank you very much. Really appreciate your time today. So the committee will report to the Senate on the 24th of November 2026. We've agreed that responses to questions on notice should be provided by close of business on Friday the 14th of August, and I do note that there was some de-identified case studies that you said that you'd be happy to provide us, and we really appreciate that because that's the sort of evidence too that is really compelling. So thank you again for your time today, and wish you all the best for the rest of the afternoon. Thank you.
Thank you very much.
And I'm just going to suggest that we actually suspend briefly, given that all our phones are going to go off in about 3 minutes.
Yeah, that's a good point.
Okay, so we'll resume. Thank you. I now welcome representatives from the Australian Podiatry Association, both in person and via video conference. Thanks very much for appearing before the committee today. I understand that information on parliamentary privilege and the protection and obligations of witnesses giving evidence to Senate committees has been provided to you. For the Hansard record, I'm going to ask you to state your name, your full name and the capacity in which you appear today, and we might start online first.
Hello, I am Dr. Robert Mullins. I am a podiatrist and I'm the chair of the Podiatry Aged Care Committee for the Australian Podiatry Association.
Thank you very much. And do we have anyone else online? No? Okay. I'll go with people in the room and I'll start on my left.
Judy Powell. So I'm the Policy Advocacy and Research Manager with the Australian Podiatry Association.
And Hilary Shelton. I'm the Chief Executive Officer of the Australian Podiatry Association.
Great, thank you. I'm now going to invite you to make some short opening remarks and then we'll go to questions.
Great, thank you very much. Well, good afternoon and thank you to the Chair and Committee members for the opportunity to appear today as part of the Senate Committee's inquiry into the Support at Home program. The Australian Podiatry Association, or as we refer to ourselves as the APOD-A, appreciate the opportunity to contribute to this important discussion on the future of aged care and the measures needed to ensure older Australians can access the healthcare services necessary to remain safely and live independently in their homes. APOD-A is the peak professional body representing more than 6,300 podiatrists across Australia, and podiatrists play a critical role in preventing falls, managing chronic disease complications, reducing hospitalisations and delaying entry into residential aged care. Firstly, we would like to acknowledge the traditional custodians of the land on which we meet today, the Yagera and Turrbal people, and pay our respects to elders past and present. And we acknowledge the ongoing contribution of Aboriginal and Torres Strait Islander peoples to health and wellbeing and extend our respect to First Nations peoples here today. So again, just to briefly introduce ourselves, my name's Hilary Shelton. I'm the Chief Executive Officer of the Australian Podiatry Association, and I'm joined today by Judy Powell, our Manager of Policy, Advocacy and Research, and Dr. Robert Mullins online, who is a podiatrist and the chair of our APOD-A Podiatry and Aged Care Special Interest Group. APOD-A supports the objectives of the Support at Home program and its focus on enabling Australians to live with dignity, remain independent, healthy and connected to their communities for longer. However, our members are reporting significant barriers that are limiting the effectiveness of the program, which is effectively reducing access to essential preventative healthcare services through podiatry. APOD-A's 2026 survey of podiatrists providing services through the program found that demand for podiatry care is increasing, while onboarding, credentialing and contracting requirements are creating substantial administrative burden and reducing clinical capacity. So members also reported that delayed access to podiatry services is contributing to worsening mobility, increased falls risk and delays in wound management. Workforce pressures are particularly evident in rural, regional and remote communities where workforce shortages exist and lengthy wait times already affect access to care. APOD-A's membership data shows that wait times exceeding 3 months are occurring across metropolitan and rural areas, while services are simply unavailable in some remote communities. Without intervention, these pressures risk reducing access to preventative care and therefore could increase demand on hospitals, general practice and residential aged care services. So our appearance today is not to criticise the program, but to identify practical reforms that will improve outcomes for older Australians. APOD-A has proposed 6 recommendations focused on reducing unnecessary administrative burden, protecting continuity of care and consumer choice, improving pricing transparency, supporting rural and thin market service delivery, undertaking profession-specific allied health costing, and expanding access to clinically prescribed lower limb orthosis and medical grade footwear through the assistive technology and home modifications list. Importantly, these recommendations are designed to strengthen the program's ability to achieve its core objective, helping older Australians to remain safely and independently at home for longer. Improving access to timely podiatry services will support independence and dignity, reduce avoidable hospitalisations and falls, and help to ensure the long-term sustainability of the aged care system. So again, we appreciate the opportunity to appear before the committee today and very much look forward to assisting in the inquiry and answering any questions that you may have. And most of the questions, if they're regarding clinical application, we'll refer to Dr. Mullins, and also have Judy here with me. Between the three of us, we can dig into detail for you.
Great, thank you very much. I'm going to go to Senator Ruston first.
Thank you very much for that quite extensive introduction. I'm just interested. One of the complaints around from residential nursing homes has been the inability to be able to count allied health care towards care minutes. I know it's not a matter as it relates to support at home, but I was just wondering, given we've got you in front of us, whether you may like to make a comment around how you see access to your particular allied health services would benefit people in residential care.
Sure. Did you want to speak more to that?
Probably Dr. Mullins, as chair of our committee, would be best placed, I think, to respond to that. I've got some views as well, but maybe he'd like to speak first.
Yeah, absolutely. I actually work pretty extensively in residential care. So since the ANAC reforms took over and care minutes became a metric for the residential aged care system and part of the star rating, we're finding that a lot of nurses are more under the pump because the minutes provided by RNs, ENs, and care workers are counted in that metric. So the facilities themselves and those providers are focusing on that. There is allied health still being provided in all of those homes, and there's really no good reason why that's not counted as care. A podiatrist is performing care, a physiotherapist is performing care, a dietitian is performing care. Those should all be included in the care minutes, and it would provide more nursing resources back into those homes to do nursing and to do the other things that they're meant to be doing already, because we're already there. So I feel like that's just a data point that could be easily corrected. We're doing the work already, so why not have it count?
So if you're doing the work already, what's the mechanism by which you're funded to do that work? Is it through sort of private health sector delivered healthcare plans, or does the person pay out of pocket? How does it work?
A lot of the residential funding comes directly through ANAC, so there's not a specific allied health component to that, but there are portions of the Aged Care Act that call out reablement and access to allied health. So the homes are providing it. Individual people are choosing more private services and paying themselves or through private health insurance that they have. There are a few Medicare programs that still work with people who are in residential aged care as well, specifically for podiatry. So there's multiple reasons or multiple funding sort of areas, but it's not a specific allied health funding. It's just part of the ANAC fee that the home is receiving.
Yeah. So do you think that we would see more support for older Australians in the allied health area? I mean, obviously you can only speak to your own area, but do you think that there would be greater uptake of podiatry services if they were considered part of care minutes?
100%. In was that October 2022 when ANAC took over from the ACFI system, there was a significant drop off in all allied health because it was no longer a specific requirement of what they needed to get funding.
Yeah, okay. Thanks. Sorry, I probably digressed somewhat from the terms of reference.
No, that's okay.
This hearing, but I just thought it was really very important because it's about making sure that we're incentivising the targeting of the care that the individual needs, and we all know that things like occupational therapy and dietary and those sorts of things are incredibly important to older Australians, particularly as they slow down a bit. So just keen to understand from a supported home perspective, in terms of the cost to administer your service through the supported home program, as opposed to the cost to provide your service through a standard process of, like if I decided I needed to go to a podiatrist, where I just ring you up and say, "G'day, can I have an appointment?" What is the additional burden, cost burden on an operation, a podiatry practice, of the additional things that they need to do in order to provide a service through the supported home program, as opposed to just through the normal medical program that you would provide?
Judy, do you want me to keep going, or?
Yeah, I'm happy for you to keep going. I've got some additional bits, so maybe if you go first, Rob, and then I can
Sure.
Build on that.
Firstly, with support at home, the whole idea is that people are aging in place. Most podiatry businesses are sole practitioners, so there's one or two podiatrists in a brick and mortar building. So for that person to go out to perform a 30-minute podiatry treatment, they're actually leaving their practice for however long it takes to get there and come back as well. So you're probably talking about 3 appointments in the office that are actually missed in order to go service that one client. The other big burden in terms of cost and time is the compliance and the onboarding with the registered providers. Most podiatrists would be an associate provider or an aged care worker. So for each registered provider they work for, they have to go through a series of compliance checks, all of which are already required of them to be a registered practitioner with APRA. But then those providers don't necessarily want to onboard 100 different podiatry companies because it's also time consuming for them. So each individual client might be with a different provider. So the podiatrist has to go through that process 30, 40, 50 times. It's costly. They each have their own portal. So a lot of those portals have a cost that you have to pay per month just in order to register. So it's sort of an administrative cost more than an actual clinical cost.
Yeah. So can I take it from what you've just said that you would strongly be advocating that your APRA registration should form the basis of your registration for, well, I'm assuming for aged care, for disability care, for every point in which you access. And if there's some little nuances that need to be done in terms of the registration, then fine. Yeah. So would you have any idea in terms of the quantum, like if somebody is getting a service through my aged care as opposed to me just walking in off the street, what is the difference that you are required to charge? I mean, I know that's probably how long is a piece of string, but do you have any sort of idea about, is it 20% more? Is it 40, 50, 100? How would you gauge it as a generality?
In my experience, it's about 3 times the cost.
3 times?
3 times.
Whoa. Whoa. And do you think there could be a better way of delivering that service? I mean, understand that there will be some people that are unable to be able to access the service or would be able to, move to come to the bricks and mortar clinic. But do you have any thoughts about how that might be solved?
There are people who do this exclusively and do it very well by having a density of clients in particular areas where they can actually, form a milk run for the day that makes it far more efficient. There's software that does that. for people. It's more the admin after. So if you figure each client you see then requires 20 minutes of that podiatrist's time to go through the portals and upload all of the documents and instruments and go back and forth with the provider, that's almost a whole nother client. If we could minimize the admin burden, I actually think the clinical costs would come down significantly.
All right, thank you. Thanks very much, Chair. That was really very useful. Thank you very much.
Yeah. Look, would it be all right if I just added to that?
Ahead, Mrs.
Yeah,
Bell.
yeah. Just to say that you know, essentially, the key message is really around this is that there's enormous duplication, and that we're seeing our podiatrists delivering more administration and less care with the current process that's being taken, but also that not everybody actually delivers the support at home in a person's home as well, that people can actually travel to a clinic in some circumstances. It does vary the model of delivery that podiatrists are delivering for the program.
I'm sorry, every time I
Thank you very much.
Every time I hear this evidence, it's like my head wants to explode, that it's not obvious that this is just really bonkers. Yeah. I'm going to... I want to just dig in, I think, to a couple of your recommendations might be a good place for me to start. I'm still getting over the fact that I've just heard how crazy that is. So in terms of your first recommendation, establishing a nationally consistent onboarding and credentialing framework, I'm assuming that that is going to that piece where you're saying it's not good enough to just say, I am a registered podiatrist, therefore I should be able to offer that service in the aged care space. You're having to go through a completely separate process. Okay, so in terms of nationally consistent, what I'm hearing then is that it's just recognising the qualification that you already have, the end.
Utilise the mechanism that's already in place through the ARPA registration.
Yeah, okay, thank you. In terms of the second one around continuity of care, is that then related to the issues around registration? So is that is one of the reasons that people aren't able to have continuity of care, say for example with the podiatrist who they've already been seeing when they enter the system, is part of that barrier the credentialing, or are there other barriers as well?
It's more around the contracting.
Mm-hmm.
So a registered aged care provider would contract podiatrists to deliver the services, and of course I'm sure you know podiatrists are considered associate providers. And so they then contract a particular podiatrist to deliver their services. And if the person who has been seeing the podiatrist for many years doesn't sign up to be that associate provider, then continuity of care is broken because the registered aged care provider says, well, you can only access the funding if you go to our contracted podiatrist. And I guess one of the key issues that our community has encountered is that podiatrists have been asked to sign up to contracts, and in many cases they have been contracts that have been delivered to and on their desk as take it or leave it arrangements. So prices have been dictated to them regardless of what the cost of their service might actually look like. And so where parts of the contract really should be negotiable, they've not been negotiable. And that many of our podiatrists have looked at what's been offered in terms of remuneration and said, well, that actually doesn't cover what it costs us to deliver infection control standards, consumables, a whole range of different elements that they need to deliver their service. And so if I can give an example, one of our podiatrists talked about how she had some clients, or consumers, older people, and she had to decide to actually reject this contract that was offered to her. And when she looked at who was going to miss out on the service and continuity of care, there was a 99-year-old woman who was going to actually have to travel several suburbs to access her regular podiatry service through the scheme, because that's who the next available contracted podiatrist was with that registered aged care provider. So through compassionate reasons, she decided to take the lower fee, but said to that registered aged care provider, I will not provide services to these other clients, so you will have to find another podiatrist to do that service for them.
And I was just going to say, it goes without saying that that is significant for a 99-year-old person to be to not have the continuity of care. And I think that she had been seeing that podiatrist for many years.
A long time.
Yeah.
So there's a long-established relationship, trusted relationship. Yeah. So
I guess these are the things that we don't really think about or see when we understand that somebody gets a home care package, for example. So is it the case then that the only way that you could have, for example, the podiatrist that you want is if you had the capacity to self-manage your home care package? So we're talking about a situation where someone doesn't have the capacity to self-manage, so someone else is managing it for them, and then because they're managing it for them, they are dictating or have the capacity to dictate how all of those services are delivered, even if they're being delivered by other health and allied health practitioners who know exactly how to run their operations and provide their services.
Yeah, and so self-manage, giving the choice back to older people to remain with a trusted practitioner that they've been with for a long time. So, yeah, it would be far better.
If I can interrupt too, Senator, that even with the self-managed packages where you do have choice of who your provider is, that associate provider, that podiatrist, still needs to sign a contract with that package provider. So there's still the admin burden on the clinical team, but the client does have full choice. So obviously that's the most important thing, but there is still a reduced access if that podiatrist has 50 clients and they're with 50 different providers. They have to go through that compliance and onboarding 50 different times. So a lot of people are just not saying yes to that.
So it seems to me that in itself is a flaw in the way that the whole system is organised. And when we talk about, when people are talking about, we need this idea where we're integrating aged care with healthcare, so we have this holistic system, we actually don't really have that. It's not that people can just move between providers and services in the same way that you can any other time. The minute that you are in receipt of a package, all of a sudden, there's this whole other layer of bureaucracy and rules around who you can and can't see.
Yeah. And it's ultimately reducing the amount of, as Rob indicated, reducing the amount of clinical time that the practitioners can actually spend with their clients, which is the valuable thing that they need.
Because I guess from my perspective, I don't even understand why you should have to sign a contract with a home care provider. Like, why can't it just be that the home care provider goes, yes, they need podiatry, go see your podiatrist, and the podiatrist gets paid? That would seem to me a much more sensible way of doing things.
Yeah, it seems sensible and logical, and not only that those contracts can be so varying between, and so it's not the case that a podiatrist who's providing care in multiple different contracts can go, this is all the same, sign. No, they have to put in significant time and effort to be understanding each of those contracts as well.
Between them?
Do you know any examples?
Well, actually, Rob was talking about some variations the other day because his practice or who he works with, they've got 50 contracts. So, and look, I did talk with another provider and they had 30 contracts and they have to get them stat dec signed and all sorts of things consistently when there's changes or to get them filed. So there's all these overlays of additional pieces as well. But the variation in what the prices are that they'll pay, what's being charged, and also how it's being charged, And so one of the examples that was sent through to us talked about the podiatrist indicated that they charged the registered aged care provider, and this is just one example, $147 for a 30-minute session, and the registered aged care provider charged that individual consumer $260 for an hour session.
So it's not even the case that the allied health providers charge is what's coming off the package. There's this whole cut being taken by a provider.
Correct.
But
And that's
that's not a cut when they're charging for double the time that hasn't been delivered.
Yeah, it's almost, in some cases they've said that they're we're delivering a clinical service and the registered aged care provider is charging double that. And so what the consumers are actually seeing is that in that case, for example, the consumer would have seen it cost me $260 to receive my podiatry service for half an hour is what they saw. But in actual fact, it was substantially less than that amount of money, and there's no transparency on the billing arrangements. So, one of the recommendations we've got is about more transparency about how the expenditure is actually being consumed, and that would mean that consumers could then actually see, well, which bits are actually administration and care management charges and which were actually the delivery of clinical services.
Excuse my naivety, but it would seem to me, if I was just dropping out of the sky and deciding how I was going to organise something, it would seem to me that we'd be better off having people whose job it is to coordinate people's care, the end, that they don't provide any services at all other than helping someone access services, and then people just went and accessed podiatrists and physios and nurses and whoever else they needed without this other entity doing all this extra stuff as well. It seems to me that we have this middle thing that's just creating work for everybody.
The NDIS.
Yeah, we would agree in our utopia that people would receive service based on their clinical need, and that whatever administration was provided was actually value adding.
Yes. Yeah. And just a separate service that is about helping you administer and access services, but that's all that happens.
Yeah. There is a need for administration, and we acknowledge that, but it's got to be fair, reasonable and proportionate.
Yeah.
What level of auditing would go on? Do you have any oversight of that for the administration?
Look, we understand that the rules do have a percentage that is allowed.
So random.
And that it is over a period of time in relation to the expenditure of the package. So, but of course, how that's administered and the transparency around that is just not obvious in terms of reporting and accountability, checks and balances.
So there's the level of reporting and auditing and checks for the individual against their package, but there should also be the other way to the department on the fact that they're the ones paying it. So what sort of auditing would be done there? That's something we perhaps need to be asking the department down the track, and what oversight they have in that regard, because that example that you gave earlier it would have to be illegal to be charging something that hasn't been delivered. So we've got to figure out where that's being picked up and how in the process. But yeah, that's frightening. Sorry.
So now I understand what you mean by recommendation number 4 around improving package transparency. So that's exactly what you're talking about, right? Like cost of service as opposed to what someone is getting on their itemised bill. Just in terms of the profession-specific allied health costings, can you talk me through what the issues are at the moment around that?
Yeah. So the issues around that are related to how the data is collected and used, and a lot of it is on pricing rather than actual cost of service. And so some of the challenges that podiatry has is that podiatry has some unique costs that are different to other allied health professions. So they're required to meet infection control standards. They have a lot of equipment. You know, I'm sure everyone wants their scalpels, you know, up to scratch and clean. There's also lots of consumables. And so it's quite an expensive service, but very important to deliver. And and if you can use a comparison, as opposed to talking therapies that don't have the same amount of equipment or consumables, or maybe certain external standards that they have to adhere to. So to be able to comply with all of that is a significant cost. And some of it goes to the heart of sometimes the profession is not well understood in terms of what it delivers. And so it delivers from doing minor surgery through to treating wounds to assessing for vascular and neurological conditions and monitoring. And Rob can probably speak to that better than me as a practicing podiatrist. But, you know, there is significant cost, and when prices are set, they're not considering necessarily what the cost is that goes into the service to deliver, and therefore prices are often set at unsustainable levels that mean that podiatrists have to actually then choose as to whether they're prepared to work in particular schemes. And so what the risk is that they will exit particular schemes. And with the current workforce shortages, and particularly in rural and remote communities, and we heard from our previous witness about the challenges there, that, you know, waiting lists get longer, the potential for complications get more prevalent, and we see people entering residential aged care facilities earlier, or hospitals, or even in complicated examples, amputations. So it's really important to get the price right, I guess. And so what we found and what we've asked is for a true evidence-based costing to be undertaken of what it really does cost to deliver these services, and then to set the price in a way that it actually supports the delivery of those services so that they can be sustainable into the future.
Thank you. I don't have any more questions, so I'm just going to check whether there are any other questions from any of our other senators.
My only other one was just, it actually follows on from that answer that you just gave, and you're talking about it for the profession-specific allied health costing. When we go into the rural and regional areas, what do we need to do to increase the workforce as well out there? I mean, it's great to say, yeah, we've got to be able to do it, but what incentives need to be put in place, what's required? And from what your sort of discussions that you've had from people working in those areas?
It's complex because we're talking about supply of professionals overall, and we're seeing in some cases thin markets developing even in metropolitan areas. So, you know, and longer waiting lists. And it's really for particular schemes more that's happening because of the way they're set up. But if we're looking at the pipeline, we need to be recruiting more people into studying podiatry in the first instance, so to increase the number of podiatrists that are qualified and supported to deliver these kinds of services. The other thing is that to encourage podiatrists to actually deliver in rural and remote communities, to really consider some incentives that work and some structures that are supportive. And so some of those would be financial, some of those would be systemic. You know, HEX Help is an example of something that immediately comes to mind, that's not always available. And if I can use an example, New South Wales Health have got a HEX Help for public health podiatrists to work in rural areas. If that kind of model could be extended to private practitioners, that might be a solution to explore. So look, I think that and rural workforce agencies have got lots of ideas as well. So they'd certainly be a source of some solutions that would be good to explore.
It's certainly something that's come up previously in GP shortages and stuff
Yep.
when we've done before, and there's sort of the ideas, but I'm just wondering what works and what doesn't in your field, because obviously we've still got the balance of work life and everything with families and so on.
Yeah.
It's always hard to attract people to the country at times, but sometimes they're the most rewarding jobs.
Well, and that's, if I might just add, that is what we have heard. The members do tell us that it is very rewarding when they do go there. Yeah.
Exactly.
And there's some
I can
successful
interject.
private-public practitioner relationships that,
Which we've
and
tried in
models that actually
Tasmania.
work
That's
as well.
actually working with doctors in Tasmania, so the public-private shared arrangements, which is working quite well.
Yeah.
Sorry, Dr. Mullins.
I was just going to say, in the regional and rural areas, one of the reasons that specifically support at home is struggling as opposed to other schemes is that an anomaly of the pricing authority was that travel be included in the clinical price. There are podiatrists in some of these towns, but to go do a home visit is a 45-minute drive for them. And so if that cost has to be absorbed both directions, they're not likely to go do that home visit, even if that's someone that they used to see in their clinic. So I think that there's some, modeling that could be done on the current system where you wouldn't necessarily need an incentive, just allow the package disbursement to be reasonable
Make it more realistic.
and cover things like regional travel. Yes.
Yeah, no, that's fair enough. That's my question.
Or better community transport with trained people who are trained well in being able to transport safely people to services might be another cost-effective way of doing it. Look, thank you very much for your evidence this afternoon. It's been really interesting and enlightening. So really appreciate your time. And I note that we got a written submission, but I understand there's more to come.
Yes.
So we will look forward to receiving that. The committee will report to the Senate on the 24th of November 2024, so we've still got a bit of a ways to run with this particular inquiry. We've agreed that responses to questions on notice should be provided by close of business on Friday the 14th of August. I don't believe any questions were taken on notice for this panel. Thank you very much again to all three of you. It's been really interesting and enlightening hearing your evidence today. And that concludes today's supported home inquiry hearing. Thanks to all witnesses who appeared and to Hansard and Broadcasting for your assistance, and the committee stands adjourned. open this hearing of the Senate Community Affairs References Committee's inquiry into epilepsy in Australia. I begin by acknowledging the traditional custodians of the land on which we meet and pay my respects to their elders past and present, and I extend that respect to any Aboriginal and Torres Strait Islander people who are with us here today. The committee will be conducting today's hearing via video conference and in person. I'm Senator Penny Orman-Payne, and I have with me Senator Askew, and online we have Senators Ananda Raja, Antic, Whittaker and Ruston. These are public proceedings being video streamed live via the Parliament's website, and a Hansard transcript is being made. I remind all witnesses that in giving evidence to the committee, they are protected by parliamentary privilege. It is unlawful for anyone to threaten or disadvantage a witness on account of evidence given to a committee, and such action may be treated by the Senate as a contempt. It is also a contempt to give false or misleading evidence, and witnesses also have a right to request to be heard in camera. If a witness objects to answering a question, they should state the ground upon which the objection is made, and the committee will determine whether it will insist on an answer, having regard to the ground which is claimed. If the committee determines to insist on an answer, a witness may request that the answer be given in camera. I remind senators of their obligations under the Behaviour Code for Australian parliamentarians to treat witnesses with dignity, courtesy, fairness and respect. I remind committee members and witnesses who are appearing via video conference and who aren't speaking, if you could please mute your microphones as you are now. Now, this particular session of this afternoon's hearing is an opportunity for the committee to hear from members of the community about their lived experiences. And I remind the committee that this particular panel is a listening exercise for us, so we won't be asking questions. I would also like to remind everyone that this is a public hearing. They're formal proceedings of the Senate, and it needs to be conducted in an orderly and respectful manner. And please don't disclose any private or personal information, such as your full name or your name and date of birth or your address, during your statement, because this is being broadcast live, and once it's out there, we can't take it back. Now, I'd like to welcome all of our lived experience witnesses who have joined us at the table this afternoon and online. Now, the next part of the proceedings is going to seem very weird because I'm going to ask you to state your first name only, and I'm literally going to go along the table and you're just going to state your first name, but it's for the Hansard record. So because the bulk of you are in the room, I'm just going to start and go left to right, and then we'll come to our witness who is online.
Helen.
Susan.
Renata. Rebecca.
Bianca.
And online? I just need you to unmute.
All.
Thank you very much. Okay, now look, thank you very much for appearing before the committee today. Lived experience evidence is really important to the committee, and we also understand that there's a level of emotional labour that it takes to come and give that evidence. So I want to begin by saying we appreciate very much the fact that you have been willing to come and do this today. I'm going to invite each of you to make your statements. If you could keep it to the 10 minutes so that we can try and get in on the hour for all of you and give everyone a fair opportunity to give their evidence. So I'm going to start with Helen. Over to you.
Okay, thanks. So I thank you for the opportunity to talk about the lived experience as a mother of a child with epilepsy and the totally unexpected and devastating impact that epilepsy has had on our entire family. I speak today as an advocate for families who can't and try and end the stigma and lack of understanding associated with living with epilepsy. Our son was 12 when he had his first seizure and was diagnosed with epilepsy on his 13th birthday. And as a family, we are blessed and grateful to be well educated and relatively affluent in that we can afford private healthcare, and our son is, and our children are our number one priority, and we would do anything for them. But as two healthcare professionals, we felt capable of coping and managing any sort of diagnosis that came along for our children, you know, within the limits of modern healthcare. But we really did not expect the blow and the impact that epilepsy caused to us. We basically had to face the grief of losing the child we had. We had to watch him mourn his potential life, you know, all his dreams, the things that he wanted to do, all his interests. He was into things like water polo, rugby, surf lifesaving, and overnight it was no water polo, can't play rugby, can't do your surf lifesaving. We advise you not to go even to the beach with him, it's too dangerous. We had to stop boating. Just everything changed overnight. And there was very little hope. It wasn't like, oh, in the future, it was kind of like your hopes and dreams end now. The medications that he's been given, you know, and we're grateful for, to keep him alive, kind of stole his personality. And, you know, our family changed all of a sudden. We can pinpoint the day that it changed in 2017. I'm sure lots of people have made you aware that epilepsy is so much more than just the seizures, and it's the crushing fatigue, and it's the anxiety of when the next seizure will be, and just trying to rebuild a life. And what I want to talk about perhaps is just how difficult it has been to rebuild a life, even with, you know, the best of help involved. We've had to change our lifestyle so that our son's not been left alone, and that's had a huge impact on his sister too. You know, her lifestyle's changed massively because of her brother's diagnosis. My mental well-being has been severely affected because it's not just the stress of watching him actually have a seizure and try and keep him alive, stop him choking, or, you know, stop him or catch him when he's falling down the stairs. It's the constant worry and the sort of hypervigilance that is always there. Every noise needs to be investigated in case it's you know, he's having a seizure, and basically every ring of a phone fills me with utter dread. I think it's going to be that phone call that's come through. Basically, he was a happy and intelligent boy who was, as I said, very active. But one of the things that we, I guess, found most challenging was that he was actually a very intelligent child who's in his IQ had been measured in the top, you know, the 99th percentile. And just how much the medication affected his high-level processing and his short-term memory. So luckily, he still did well enough at school, despite the seizures and the medication, but he made his way to the University of Queensland, doing a double degree in computer science and engineering. But it's been extremely challenging for him at university. And, you know, I'd like to hope that more support comes in the education system for those with epilepsy, because, you know, you may miss an exam and they may let you repeat that exam, but it's the fact that your fatigue and mental or cognitive fog may last for so many days. He'd come out of an exam, we'd say, how was it? And he might say, can't remember. I've got another exam tomorrow. Yeah. So basically, he's failing at university, and that's a real shame for someone who's so intelligent, and also mentally very difficult for him to, you know, to see, you know, what's his future holds. It's very depressing, basically. You know, you can't do this, you can't do that. While he's at university, he can't get a part-time job because basically, as people have said outright, we don't want an epileptic working near a kitchen. We don't want, someone who's at risk. So, no. And that's, very hard for him to deal with. The other thing that I wanted just to highlight in his story is that it's been very hard to get him help with his mental health. It's got to the stage where I've been offering psychiatrists, I'll say, I'll pay you double if you can give me an appointment, please. He really needs this. And the waiting list, they just said, we can't even get on the waiting list. So obviously I know there are limited funding, but I just wanted to, say that help is required. Yeah.
Thanks very much, Helen.
No problem.
Susan.
Yes, so my name is Susan and I'm here to share my family's experience with epilepsy. It is a story that spans 3 generations. It is a story of resilience, hope, heartbreak, and ultimately loss. Most importantly, it is the story of my beautiful daughter, Lauren. So my journey started when I was a child. My mother had epilepsy, and from a very young age, I knew what to do when she had a seizure. I knew where her medication was and how to help. Although she only had a handful of seizures during my childhood, I clearly remember her asking me never to tell anybody because she was terrified of losing her licence. So we lived in a rural community where a car wasn't a luxury, it was a necessity. The nearest town was an hour away, and specialist care simply wasn't available. Mum relied almost entirely on her local GP because seeing a neurologist just wasn't realistic. Years later, I found myself reliving that experience, but this time as a mother. When my eldest daughter was 11, she had her first tonic-clonic seizure. There was no warning, no trigger. She had simply been baking with her grandmother. We were told that there was nothing we could really do until she had more seizures. And as a parent, those words are incredibly difficult to hear. You live in a constant state of waiting, wondering if today will be the day that it happens again. Eventually, she was diagnosed with epilepsy, started medication, and thankfully became seizure-free. And today, she continues to live a healthy, seizure-free life. We thought that chapter in our lives was behind us. But then in 2020, the day after her 17th birthday, our youngest daughter, Lauren, had her first tonic-clonic seizure, again with no warning. She had simply been sitting in the lounge room watching a movie. After further seizures and numerous tests, Lauren was diagnosed with epilepsy. She was started on medication, but unfortunately suffered an allergic reaction and had to begin the difficult process of trying different medications. Living in regional Queensland, we had access to only 2 neurologists, neither specialised in epilepsy or paediatric care. Although specialist epilepsy services existed elsewhere, that option was never discussed with us. And as parents, we couldn't believe that we were facing this journey again. But this time was different because Lauren was just beginning adulthood. She was finishing school, learning to drive, planning further study, dreaming about travelling, finding work and building the future every young person deserves. Watching those dreams suddenly become uncertain was heartbreaking. Lauren was everything that you could hope for in a daughter. She was bubbly, kind, fiercely determined, incredibly funny, and had the most wonderfully sarcastic sense of humour. She was a country girl through and through. She loved life on the farm, showing cattle, playing football, and taking on every challenge that came her way. Over the next 4 years, Lauren tried medication after medication in hope of finding seizure control. But each one brought new side effects: anxiety, depression, weight gain, constant fatigue, headaches, nausea, sleep problems. and through it all, her seizures remain completely unpredictable. She had no warning signs, no triggers, no way of knowing when the next seizure would happen. Despite everything, Lauren refused to let epilepsy define her. She earned her driver's licence knowing that every seizure meant losing it again, and sometimes for 6 months, sometimes for a year. And for a young person, losing that independence over and over again is devastating. But Lauren kept going. She spoke openly about her epilepsy. She wanted people to understand that living with epilepsy was really like. And as a family, we were determined that epilepsy would not stop her from chasing her dreams. When Lauren started her first job, it was a 40-minute drive from our home. Because there was no public transport where we live, family members spent around 3 hours a day driving her to and from work. We did this because that's what families do. We were fortunate that Lauren had supportive employers. But despite her determination, working full-time simply wasn't possible. Between medication side effects, the anxiety of wondering whether another seizure might happen, the recovery afterwards, there were days she could physically just not get out of bed. And what broke my heart most was hearing her apologise. She would tell me how sorry she was that she couldn't work more, sorry that she couldn't be like everyone else. No young person should feel that they have to apologise for living with a medical condition. One of the biggest lessons our family has learned is that epilepsy doesn't just affect the person diagnosed, it affects everyone who loves them. It is watching someone you love have a seizure and feeling completely helpless. It is waiting for them to regain consciousness, seeing the confusion in their eyes, hearing them apologise because they know how frightened you are, and then watching them realise that they've lost their licence again, or another job opportunity, or another piece of independence. And as a parent, there is nothing harder than watching your child suffer when you would give absolutely everything to take that pain away. Then in 2024, everything seemed to be changing. Lauren had been seizure-free for 15 months. She got a licence back. She was applying for her dream jobs of Jillaroo or a governess. And for the first time in years, we could genuinely believe that we were turning a corner. We believed her epilepsy was finally under control. Then on the 4th of April, everything changed. Lauren went to bed that night and she never woke up. We had lost our beautiful daughter, our best friend, the light of our family. Lauren died from a sudden unexplained death in epilepsy. SUDEP. She was only 20 years old, just 2 months shy of her 21st birthday. What has made our grief even harder is discovering afterwards that Lauren was considered to be a high risk of SUDEP, yet no doctor or specialist had ever spoken to us about it. The first time many families hear the word SUDEP is when they read it on a post-mortem report, and that should never happen. I cannot say that knowing about SUDEP would have saved Lauren, but I also cannot say that it wouldn't have. Families deserve the opportunity to have those conversations. They deserved informed choices and they deserve honesty. And that is why I'm here today. I am Lauren's voice. I promised after losing her that if I ever had the opportunity to stand before decision makers and tell her story, and if it meant another family might be spared this heartbreak, I would do it. Today, I am keeping my promise. Together with close family friends, we have created a 35-metre road train wrapped in purple, carrying Lauren's smiling face alongside information about epilepsy and SUDEP. What began as a tribute has become something much bigger. Every kilometre it travels, it starts conversations. It raises awareness, It reminds Australians that epilepsy is far more than seizures. Through Loz's legacy, we have now raised almost $89,000, with the majority dedicated to SUDAP research. Lauren's legacy continues to save lives by starting conversations that many families never get to have. My greatest hope is simple: that Lauren is remembered, that more Australians understand the realities of epilepsy, that every person diagnosed receives the best possible care, including honest conversations about SUDAP, and that no parent ever has to discover this condition only after losing their child. Because epilepsy affects far more than the person living with it. It affects families, it affects futures, it affects every dream that should have been. And if Lauren's story can lead to greater awareness, better education, improved specialist care, and more research, then her legacy will continue to make a difference. Thank you.
Thanks, Susan. Renata.
Madam Chair, Senators, thank you for giving me the opportunity to speak today. I sit here not as a clinician, researcher or advocate by profession, but simply as a mother, as someone who has spent 16 years living beside a disease that never sleeps. My son Max is 26 years old. He has drug-resistant epilepsy. Despite taking 10 anti-seizure medications every day, epilepsy dictates his life. But it doesn't just affect the person having the seizure, it consumes entire families. It forces us to live with a question that never disappears. Will the next seizure be the one that they don't survive? That question has lived in our home for 16 years. To understand why this inquiry matters, I want to take you back to where our journey began. Max was 10 years old when he woke me in the middle of the night crying. He was drenched in sweat, shaking uncontrollably, and had wet the bed. His heart was racing. He couldn't stand. He was confused, dribbling, mumbling, and terrified. He kept saying, "Mum, I think I'm going to die." We had no idea that he had just suffered his first tonic-clonic seizure. Neither did he. The next day, he could barely function. His shoulder had dislocated during the seizure. He had a crushing headache, overwhelming exhaustion, and no memory of what had happened. That night changed everything. From that moment on, epilepsy quietly took hold of his life. At school, Max experienced frequent staring episodes. Teachers believed he was daydreaming and criticised him for not paying attention. None of us realised that those daydreams were actually seizures. Instead of receiving treatment, he carried the burden of being misunderstood. Looking back, one of our greatest heartbreaks is knowing that the symptoms of epilepsy were mistaken for poor behaviour. This misunderstanding cost him 7 years of diagnosis and treatment. We were told by our GP that he had Alice in Wonderland syndrome. At 16, Max got his learner's licence. Like every teenager, driving represented such a sense of freedom, independence and adulthood. Unknowingly, he completed 60 hours behind the wheel whilst living with undiagnosed epilepsy. When I think about that now, it horrifies me. Then everything changed one cold morning in the Queensland bush when Max was 17. Sitting beside a scout campfire before dawn, he collapsed into a tonic-clonic seizure. By chance, another scout was training as a paramedic and she recognised the seizure immediately and called 000. Max's epilepsy was not diagnosed because the system worked. It was diagnosed because chance intervened. Only then did we begin our journey with a neurologist. We believed at the time that the hardest part was over, but it wasn't. It was just the beginning. At his first appointment, Max was prescribed Keppra. Like many people with epilepsy, seizure control came at a devastating cost. The medication triggered severe mood changes, explosive rage, and we watched our son disappear beneath side effects that he simply could not control. What followed was an endless cycle of medication changes, dosage adjustments and failed combinations. The seizures continued, the side effects accumulated, our family life changed completely. Every decision was shaped by risk. Holidays disappeared, relationships were strained, financial pressure mounted as we paid for specialist travel, treatments, therapies. On it goes. We never ever had any certainty. Some of the most terrifying moments happened far from home. Whilst travelling in Thailand, Max experienced 2 tonic-clonic seizures and we watched helplessly as our son convulsed and lost consciousness in a foreign country. Yet, despite everything, Max has refused to let epilepsy define him. He moved to Brisbane to build an independent life, find work and access public transport. Like many young Australians, he wanted the opportunity to contribute and build a future, but epilepsy has followed him. He has lost employment after seizures and post-ictal confusion caused mistakes at work. Seriously, epilepsy is an invisible disability. People do not see the memory loss, the cognitive fatigue, the anxiety that accompanies every aura, the words that disappear mid-sentence, or the exhausting effort required simply to appear normal. This is the reality of epilepsy. The risks are constant. The consequences are lifelong. There was the night that Max had a seizure in a taxi on the way home, the driver not understanding what was happening threw him out of the cab on the Pacific motorway at 2 a.m. More recently, while travelling alone in Melbourne, Max had a seizure and found himself on St Kilda Beach with no idea how he got there. He managed to navigate his way back to the city only to find his bag and phone lying between tram tracks. Instead of compassion, he was reprimanded for his negligence and the risk that he had apparently created. I would like you to spend one ordinary day living inside my son's mind. I wake up certain of only two things. I survived the night and I'm still alive. That's a good start. Before anything else, I take my 5 drugs. Routine isn't a choice, it's survival. I pack my lunches last night because money is tight. I cook my breakfast, I get ready for work. I'm trying to live independently like every other 26-year-old, then I have a seizure. It's only a focal seizure, but there's no such thing as only a seizure. I'm not okay. I pick up my gym bag. I walk outside in my undies. I'm going to work, aren't I? Then I realise I'm locked out. Shit, the confusion crashes over me. Did anyone see me? Damn, my breakfast is burning on the stove. Now I'm late for work again. 15, maybe 20 minutes of my life have disappeared, post-ictal brain fog. Nothing makes sense. Another piece of my memory is gone, and I can't prove any of it. I can't explain it. I can't justify it, because saying I had a seizure doesn't carry much weight in the real world. My work suffers. My reputation suffers. People think I'm making excuses. Some think I'm lying. Little by little, my confidence disappears. But I look healthy. I look strong. You can't see what's happening inside my brain, so I keep going and I try harder. I smile, I become a people pleaser, because if I work harder, maybe no one will notice. What they don't know is that I've already had 3 or 4 auras today. That feeling that another seizure might be coming. Do I hide in the bathroom? Do I tell someone? What do I even say? I forget to tell Mum and Dad I've had 2 seizures and I'm at work. I can't just call them. Then I realise, oh, I've left my lunch at home. I'm such an idiot. That's what I tell myself. Do I have enough money to buy lunch? No, I will go without. Work finishes, I lock up, it's dark. The only work I can find is casual, $26 an hour, no sick leave, no holiday pay, no superannuation. I work at great risk, but I want to work. I love work. I want to contribute. I don't want epilepsy to decide my future. So I keep showing up. I walk to the bus stop alone, then I have another seizure. My phone falls, I miss my bus, I get on the wrong one, stressed, anxious, embarrassed. Only then do I realise I've had another seizure. I wet myself. Where's my phone? I get off the bus, I catch another one back. My watch tells me where I stopped moving. My phone is lying in the gutter. I pick it up, I get on another bus, thank God they're only 50 cents. I sit in the disabled seat and someone stares at me. You're not disabled, look at you. I don't argue, I don't explain. How do you explain something that no one can see? Another aura, and now I'm frightened. I'm wondering whether another seizure is about to happen and whether anyone around me will know what's happening. How do I tell a stranger I'm about to have a seizure? I have epilepsy, because there is no warning. Then I remember I forgot to pick up my meds. Again, I get angry with myself. Leave it till tomorrow. My meds are costing $170 a month because I'm not eligible for a healthcare card. Eventually, I make it home and I'm exhausted. I take my medication. Again, I call Mum. She reminds me of everything I've forgotten today. Tomorrow, she'll probably have to remind me it again. Finally, I go to bed restless. I hope tomorrow will be different, but with epilepsy, you never know. That isn't one bad day. That is my life, every day. The hidden victims, families. Parents learn to sleep lightly because silence can be terrifying. We know what a seizure sounds like. We also know what no sound at all can mean. Siblings live with unanswered phone calls, unread messages, and the fear that every ambulance siren could be for someone they love. Every swimming pool, every beach, every staircase, every train platform, every road, every outing is assessed for risk. Every day ends with the same thought: will today be the day that something goes wrong? Once you know that hundreds of Australians die each year from epilepsy-related causes, including SUDEP, you can never unknow it. The closest we came to losing Max wasn't in a hospital, it was in the ocean. In 2020, on a quiet beach in New Zealand, Max had a tonic-clonic seizure while standing in the surf. He collapsed face first into the waves, his lungs filled with seawater. He was drowning. The person who recognised he was dying wasn't a lifeguard, it wasn't a doctor, it was his 10-year-old sister. She recognised the distinctive blue colour of his face and raised the alarm and saved his life. This is why this inquiry matters. When Max was 10, there was no roadmap. When Max was 17, there was no coordinated pathway. When Max was 20, we finally found the right team. Not because the system worked, because we eventually found our way through it. Only when we were told the truth, Max has drug-resistant epilepsy. 3 simple words, 10 years too late. Senators, you cannot give my son back the years that epilepsy has taken. You cannot give him back the memories that he has lost, or the jobs, or the opportunities, or the independence. You cannot cure every form of epilepsy, but you can change how Australia responds to it. Today you have the opportunity to change what epilepsy takes from the next family. 16 years ago, we walked into this journey frightened and completely alone. No diagnosis, no roadmap, no one to tell us what came next. It took 13 years to find the right system. No Australian family should have to wait that long. My hope is simple, that the next child who has their first seizure is recognised sooner, that the next parent is handed more than a prescription, that they are handed hope, knowledge, support and a pathway, and that no Australian living with epilepsy has to wonder whether they can afford the medication that keeps them alive. My son works because he wants to contribute, yet because he earns just above the low-income threshold, every prescription costs him full price instead of $7.70. He is penalised for choosing work. Medication is not a choice, it is survival. I hope that the next employer understands invisible disability, that the next teacher recognises a seizure, that the taxi driver knows the difference between someone who is intoxicated and someone whose brain is under attack. Because people with epilepsy deserve more than survival. They deserve safety, dignity and opportunity, and they deserve to believe that their country understands what they are living with. It is our families' 16 years, if our family's 16 years of fear, of determination, of hope helps even one family avoid the journey we have travelled, then every step will have meant something. Thank you.
Rebecca. Hi. Okay, I'm Mia's mum. Mia's 18, so much like Renata, Mia has drug refractory epilepsy, and that was terrifying to find out. So Mia had her first seizure on the 4th of February 2024, and about an hour later she had another one and was resuscitated in front of me. And then she was put into ICU all night and then eventually came out and transferred hospitals. And then she went into, I think she had like 13 or 14 that week. And we've done the journey. It is very, very hard for Mia. It's been financially difficult for everybody, but, you know, we blindly do not give up. I guess, you know, Mia is so brave. She actually makes jokes about, you know, coming back to life, like, Mum, what's your problem? I'm like, Mia, it's not funny. Another time we were driving, so one of Mia's seizures was long drives. And another time she had a seizure on the side of the road, and we thought we'd lost her that time. Her sister was running around frantically trying to find someone. We didn't know where we were. Ambulances couldn't find us. She was completely grey. And she has midazolam to stop her, but there's a time frame as well. And the midazolam wasn't working that day. So Mia, we have tried. Like, I don't think any one of us here today has a child to let epilepsy define their quality of life. But it can be really lonely when you're fighting to get your child back. Like, you're in a system where you've got neurologists and they're wonderful, but it needs to be looked at where there's, like, you know, subspecialists like epileptologists. Like, epilepsy is not like, it's not the same. Every one of our kids are different. Every one of us. Like, you take our kids to school and you get, you know, the school health nurse and they're like, We've seen a seizure, we've got it. Like, we can lock the midazolam in the school office. No, you can't. Like, this person can't breathe. You don't have 2 minutes and you don't even know what you're looking at, you know? And then in cases like, you know, Mia's, and I think Helen said the same, it affects our kids, our other kids. You know, Mia's sister is an amazing student. She's at home with her today looking after her. You know, she's gone down to 30% attendance and then she struggles to catch back up again. There is a system out there that, like, kids, and I'm sure there's adults too, that are doing absolutely nothing wrong, are not able to meet basic human rights as a person. You know, Mia refers to herself now as an 18-year-old of, I need to be babysat. It affects her relationship with everybody, but most of all, it affects her with herself, because I think one of the things that a lot of people is, like, we all try and avoid is, these kids think, what point is there to life? Like, this is really what we're looking at. You know, Mia's like made so many jokes and we're like, that's not funny, but realistically you have to take it on board and you go, well, I have to get better. You know, I have to learn more. I have to learn how to open airways. I have to learn CPR. I have to, you know, like, I remember once on the side of the road with an ambulance, and the ambulance said, well, we called the emergency department, you know, she's better off with you. And I'm like, guys, I'm out of my dad's, so if you want to give her a lift, I'll meet you at home with her. So, like, when we're buddying up, and I think one of the most important things that you can see in this is people live in terror. Like, they live absolutely terrified. And, like, I remember calling NDIS twice. And I'm like, guys, we need help. I'm a single mum. I've been let go from 2 jobs. No one will give me a job on a house on a carer's pension. Like, everything's going downhill. I'm struggling to, like, buy medication. I'm struggling to buy food. I'm in over my head. And at the same time, Mia was at a hospital that was seriously letting her down. She's like, Mum, they're testing on me. Mum, they're learning from me. And she was quite, she didn't say it politely, okay? But she's a kid and she's terrified. And I had to write a letter to the hospital and say, guys, we've had to call Ryan's rule on you twice. You told me that we weren't even going to need it. And then you came back and said, I'm so sorry, I'm getting everyone out of bed. Like, she didn't even recognise me. And then it wasn't just, I just was like, I have to find someone to help this kid. Like, and that's me as a single mum. Like, this hospital is killing her. Like, I need help. And she was saying it as well. So we searched and searched and searched. And then I was talking to someone one day, and he said, I think I know someone that can help. And that's how I learnt the power of an epileptologist. And in 3 hours, he said, Mia's got drug-resistant epilepsy. So prior to that, we had neurologists at school test Keppra on her, up, down, up, down. I had stuff thrown at me. I saw a beautiful, quiet-natured, loving girl become so aggressive and so angry. The police one day were like, this is domestic violence. And I'm like, this is Keppra. And much like everyone else, we all stay awake at night. I'm pretty sure when we say that, you're waiting for bumps, you read everything. Like, you read up about SUDEP, you read up about diet, you read up about Keppra. You know, one of the biggest things that I found when I came across the private neurologist that we found was, he said, the first thing we're going to do is get her off Keppra, because they made Briviac, and Briviac was actually designed as a second without all this stuff. And I thought, why is everyone out there, why are all these kids out there, like, being given Keppra and the same thing, when someone's just told me, like, within the industry, it's gone. You know, like, there's suicide in little children because of Keppra. Like, and it's terrifying. And I'm not going to go on about it, because if there's one thing we've learned is we can't change this. So we just need to stay positive, get better, keep going. But it's really sad. And I think, like, when I came into this today, if there's 2 or 3 things that I would urge, you know, it's that NDIS thing. I mean, it's just my opinion that if someone needs an emergency medication to keep them alive, then they're entitled to some kind of support. I mean, I had to map out how to get from Noosa to the Marta in a lane if she had a seizure, to get her out without being on traffic, without being in a tunnel, without, like, and I'm just like, no wonder, like, you know, and then I'm obviously not fun to be around, like, because I'm like, Mia, don't do this, don't fall asleep, blah, blah. Like, it's just like, it's really, really sad, because from, you know, the school system going, oh, we're not going to, you know, administer midazolam. I'm like, guys, it looks like the fish you get with your sushi. Snap, put it in, save her life. Sorry, we're going to have to fill out 4 or 5 forms and get 4 weeks of stuff. Like, I'm just like, this epilepsy thing is just not what everyone thinks it is, you know. And it's worse than your child, losing your child in front of you physically, like I did that day, but then you also see you losing your child every day, your life, their siblings' lives. Like, it breaks my heart. It's one of the things that I think really, really needs to be looked at. And I actually asked Mia today, what would you say if you said, like, if you could bring up anything? And she said, I would not be letting medical students diagnose anyone. And I'm like, that's fair. So Mia had glandular fever, Scoo missed it, she got temperatures, she had her next seizure, she was taken to Nambour. Someone else said that she had anxiety, she could have had COVID, she was locked in a room. I thank God a nurse came and said, what are you doing in here? She'd done a COVID test yesterday, because it was not long after that she had a seizure and needed to be resuscitated. So there's got to be more education and awareness, but also there has to be a we can do this, like blindly, like a mum trying to keep a kid alive. Like, I did not bring this kid into the world to waste away in a house with epilepsy. Like, you can do this, you can do that. Like, and find what those things are. Find psychologists, social workers that specialise in epilepsy, and if they don't, teach them. Like, find coaches that go, okay, here's a young person, we can put you in jobs in childcares or whatever, you know, schools, environments, medical places where people are ready to go to help someone with a seizure, rather than have someone thinking, I don't fit in, I don't deserve to be live, or even worse, I'm sorry we're homeless, Mum, because we got epilepsy. I'm sorry we don't have a job. No kid should have to say sorry for that. That's not their responsibility, that's ours. So, I don't know. I just reckon keep at it. But I'm very, very strong on neurologists and epileptologists and NDIS being like looking back into it, because they said that you need to have 9 to however many seizures a week. And the one week, like when Mia had over like 13 or 14, we had to reteach her things like 2-minute noodles take 5 minutes, what people eat for breakfast. She had complete memory loss. You know, she got in the car like every day for months and went with a drink, and I'm like, the drink holder's there. Like, people don't realise, and it's really got to be addressed, because it's looking the other way why Australians are in real danger.
Thanks very much, Rebecca.
That's okay.
Bianca.
Good afternoon. Thank you for the opportunity to speak today. I really appreciate it. I'm here to share my lived experience of having and losing a child to epilepsy. I speak to you today in memory of my son Nikias and all the other children that I've learnt about who have passed from sudden unexplained death in epilepsy, otherwise known as SUDEP. SUDEP is the #1 cause of death of people who have epilepsy. My son died suddenly, unexpectedly and tragically in April 2021. He was 17 in Year 12, had a part-time job at Coles, had a great group of friends. He was hard-working, kind, thoughtful and had a great sense of humour. He was the most wonderful child or son that I could ever have wished for. He was diagnosed as having epilepsy at age 3 after 18 months of febrile convulsions and multiple hospitalisations. We were told there may be a good chance he would outgrow the condition. He was seizure-free between 10 and 12, and we were hopeful that this had happened. Unfortunately, when he started high school and started maturing, he started to have involuntary jerking movements of a morning. This would result in his arms flailing involuntarily. His paediatrician assured us it would not be epilepsy. However, I was insistent that something was not right. Following an ECG and another test, we met with an otologist and his paediatrician. At the meeting, we were informed that Nikias did indeed have epilepsy. He had now juvenile myoclonic epilepsy. We were told it was important to keep the myoclonic epilepsy under control with medication, as it could develop into grand mal or tonic-clonic seizures, but we weren't told why this was important to do. The tests also revealed that Nick had epilepsy in part of his brain, that it was always there and always would be. At this meeting, we were told that we would need to be careful of the following: not allow him to do skydiving or scuba diving, to be careful around water and make sure he was supervised, to ensure he got enough sleep, that he took his medications and that he didn't spend too much time on screens. Nikias, as we were, was very diligent in ensuring he followed the advice of his doctors. Understandably, we were all somewhat disappointed to learn that he would have epilepsy for the rest of his life. As a family, we treated epilepsy as a condition that would require some modifications to Nick's life, but we wouldn't allow him to use it as an excuse, and he wouldn't allow it to interfere with his life and what he wanted to do. Nick was happy. He lived a full and happy life. We didn't know that it could kill him. On Sunday, April 11, 2021, our day began like most Sundays. My husband, Nick, and I watched a Liverpool Football Club replay as a family. We spent time hanging out together in the lounge and then went about our day. Later in the afternoon, my husband went outside to mow the lawns. I was mopping floors. Nick was shooting basketball hoops. Once he'd finished shooting hoops, he went into the shed to work out in our home gym. Half an hour later, my husband came running into the house screaming at me to get help. He'd found Nick collapsed in the gym and thought he was dead. 3 days later in ICU, Nick was declared brain dead. On April 16, we said goodbye. Nick's passing left us with one question: what happened? Initially in the hospital, a doctor told us he may have collapsed due to a lack of or an excess of fluid intake, that maybe he had suffered a cardiac arrest. Then we were told he had tumours in his heart. Following an autopsy, we were told there were no tumours, so there was more confusion. What had happened to our Nick? With no answers, I started questioning doctors about what had caused him to have cardiac arrest. Could something have happened to his heart? Why does a healthy boy just collapse and die? No one could tell me what had happened to Nick. I then started looking at what may cause a perfectly healthy 17-year-old to suddenly die. I will point out that I have no training in medical history, no health background. My training is in education and dealing with behaviour. So this was all new to me and something that I felt way out of my depth with. I looked into heart conditions, genetic conditions, and any possible reason to explain his sudden death. After his passing, my husband, 13-year-old daughter, and I were told to see cardiologists, and they recommended that we undergo a series of heart tests. The cardiologist requested all of Nick's medical records from the ambulance, the ICU, and his doctors. When we met with the cardiologist, he told us that there was nothing wrong with Nick's heart. His heart had not stopped first, his breathing had. A lack of oxygen had then led to his cardiac arrest. So now I had a new question. What makes a 17-year-old healthy boy stop breathing? This is when I started looking into what people with epilepsy die from. This is when I first learnt about SUDEP. From what I initially learned, it appeared that SUDEP was something that people with epilepsy passed from in their sleep. SUDEP as his cause of death still didn't make sense. Nick was running on the treadmill when he collapsed. I had a new question. Do people with epilepsy just suddenly die from SUDEP? At this stage, I was in a few SUDEP Facebook groups I had found. I decided to post on these groups and ask if anyone else had lost a loved one in a similar way that we had lost Nick. Sadly, the answer was yes. One lady told me her husband was carrying a breakfast tray outside and he collapsed and died. Another young boy in his teens was playing online with his friends. He got up to get a snack from the fridge. His mother came home and found that he'd collapsed and died in the fridge, in front of the fridge. Another example is a woman whose son was sitting at the table reading and he just died. With this information, we went back and saw Nick's neurologist. We told him what we knew. He told us that there is an entity called SUDEP, and this appeared to have been what Nick had passed from. This was the first time a medical professional had ever mentioned SUDEP. We had been dealing with this epilepsy since Nick was 18 months. This was the first time these words had ever been mentioned. At all the hospitalisations throughout Nick's life, SUDEP was never mentioned. At no appointment with a GP, a paediatrician, a neurologist or an hepatologist was SUDEP ever mentioned. Not once had any medical professional over those many, many years led us to believe that epilepsy could kill Nick. Understandably, Nick's death has left me devastated. I question myself as a parent. I blame myself for not knowing about SUDEP. I question the decisions I have made regarding his care, the medications he took, the doctors he saw. I am still filled with guilt that I have not done everything I could to protect him. I felt alone and angry, and I feel that I have let him down. Following Nick's death, I established a Facebook group for Australia titled SUDEP Support Australia. It is a closed group that provides support for parents and those who have lost a loved one to SUDEP. Losing my son and the stories parents have shared with me about the loss of their children has led me to believe that key changes must occur in the treatment of people with epilepsy to ensure that we reduce the numbers of deaths from SUDEP and work towards finding a cure. The changes needed are: the people with epilepsy and their carers need to be informed of what SUDEP is. It may be uncomfortable for people to hear, and it might be something doctors feel they don't need to disclose. But I can assure you that conversations about the sudden death of your child and funeral arrangements are much worse. People with epilepsy deserve to be informed of the risks of their disease in the same way people with heart disease and cancer are made aware. Over and over again, I am told by members of the Facebook group that they had not heard of SUDEP until their child had passed from it. Learning about SUDEP after your child has passed is too late. That those who are at high risk of SUDEP are informed of this by their treating physician so they can ensure they do whatever they can to prevent SUDEP. Following my son's death, I learnt, according to a checklist by SUDEP Action UK, that he was what was considered at high risk of SUDEP. Had we known this, we may have made different decisions regarding his care and medications. Unfortunately, this choice was taken out of our hands due to a lack of information from his treating physicians. I also believe the people with epilepsy should be informed of the preventative measures they can implement that may reduce their likelihood of SUDEP. SUDEP Action UK completed research where they informed those with epilepsy in a particular area in the UK about SUDEP and the preventative measures that they could use. The study found that the number of deaths from SUDEP in that area decreased as a result of this strategy. We need to inform people how to reduce their risk of death from SUDEP when such a strategy has already been proven effective. In Australia, we are continually informed of how to prevent skin cancer, how to prevent diabetes, heart disease and sudden infant death in children. Why not SUDEP? Our son's death certificate states epilepsy as a cause of death. It does not state SUDEP. We need to ensure that pathologists and coroners are upskilled so that they can identify a death caused by SUDEP so that we can have an accurate numbers on the number of people who die from SUDEP in Australia. Currently, we do not. Australia needs a federal organisation that is responsible for a national SUDEP approach. This currently we have an ad hoc approach with different organisations doing different small bits and pieces. But because SUDEP's not attractive, it's not sexy, people don't want to talk about it, it's hidden on pages, you can't easily access the information. We need a national body that puts it at the forefront and pushes it as an advocate. This organisation would be responsible for research into SUDEP and preventative strategies, maintaining a national data bank on the number of people who have passed from SUDEP, the dissemination of information about SUDEP and preventative strategies to all medical professionals, the upskilling of GPs, neurologists and medical professionals about SUDEP, the upskilling of coroners and pathologists, providing information to the public about epilepsy and the fact that it is a serious disease and that it can kill. We need to raise the profile of SUDEP within Australia so it becomes known and discussed in the same way that cancer, MND and MS are. Support, we need support for parents and loved ones who have lost someone to SUDEP. My hope in speaking today is that the Senate Committee will agree with and recommend the recommendations that I put forth as they can save lives. It's been 5 years since Nick passed. We live each day missing him, wondering what he would be doing, thinking of what his life would be like. His death has left an indescribable chasm in our lives that will never be filled. Our loss and pain are beyond comprehension. It's unimaginable. I thank you for allowing me to speak today. My hope is that with this committee's help, less families will have to experience what we have. Thank you.
Thanks, Bianca. I'm going to go to Paul online.
Thank you very much. My name is Paul. I've already shared the story of our daughter Natalie, who has lived with Dravet syndrome her whole life through the submission with Epilepsy Queensland. Natalie is now entering adulthood and lives at home with myself and my wife. Probably rather than just tell the story of Natalie, I'd like to highlight 3 areas that I believe people living with epilepsy need greater support: education, the transition from paediatric to adult services, and employment opportunities. These issues emerge strongly through our association, through Natalie's lived experience with Dravet syndrome, and demonstrate how gaps in systems can have lifelong consequences. Firstly, in relation to greater education and training in schools. Education plays a critical role in shaping outcomes for young people with epilepsy. In Natalie's experience, though, it showed that support within schools was often inconsistent. While some teachers were knowledgeable and proactive, others lacked the confidence and understanding needed to appropriately support a student with epilepsy. As a result, support often focused only on cognitive impairment, with limited recognition of the impact the seizures, medication side effects, fatigue, and safety concerns can have on learning and participation. Every teacher should have access to basic epilepsy awareness. Schools need clear protocols so that staff understand how to respond during a seizure, how epilepsy can affect learning, and how to support students to participate fully and safely in school life. Improved education would not only enhance safety, but also reduce stigma and create a more inclusive learning environment. When school staff understand epilepsy, students are more likely to feel supported, confident, and be able to reach their full potential. The transition from paediatric to adult healthcare is one of the most challenging periods for people living with lifelong conditions. In Natalie's case, support systems became significantly less structured once she reached adulthood. The transition lacked clear guidance, and responsibility for navigating services largely fell back onto the family, which put a lot of emotional strain on us to solve those gaps and come up with solutions. Finding appropriate specialists, understanding available supports, and coordinating care became increasingly complex. This experience highlights the need for structural transition planning that begins well before a young person leaves paediatric care. Families should be supported by dedicated coordinators who can provide information, connect people to services, and ensure continuity of care. Epilepsy does not end at the age of 18. It is a lifelong condition. The support available to individuals should reflect that reality. A smoother and more coordinated transition would reduce stress on families and help young adults maintain stable healthcare, independence and quality of life. In our case, the only constant during Natalie's lifetime has been Epilepsy Queensland, who have provided significant assistance and support, which has ultimately helped immensely in our epilepsy journey. Stronger employment pathways and workplace support. Employment is a key contributor to independence, and we've heard from some of the other witnesses today. It builds self-esteem, social inclusion as well. However, for people living with lifelong epilepsy, employment opportunities can be significantly limited by both practical barriers and community misconceptions. Natalie's experience demonstrates how concerns relating to seizures, driving restrictions, cognitive impacts, and reduced independence can affect long-term future planning and confidence. People with epilepsy often have the skills, the motivation and desire to contribute to the workforce, yet they may require additional support to access and maintain employment. This can include specialised career guidance, workplace education programs, flexible working arrangements, transport assistance and employer awareness training. Greater understanding of workplaces can reduce stigma, increase confidence for both employers and employees, and create opportunities for individuals to participate meaningfully in employment despite the challenges of their condition. Supporting employment should not be seen as a welfare issue. It should be seen as an investment in inclusion, independence, and the potential of people living with epilepsy. With the right supports in place, many individuals can build successful and fulfilling careers. In closing, Natalie's story reminds us that the greatest challenges are often not caused by epilepsy itself, but by the gaps in the systems designed to support people living with it and the families associated. Better education and awareness in schools, structured support during the transition to adulthood, and stronger pathways into employment would make a profound difference to the lives of thousands of Australians living with epilepsy. By addressing these areas, we can help ensure that people with lifelong conditions are not simply managing their diagnosis, but are able to participate fully in education, work, and community life. Thank you very much.
Thanks very much, Paul. Can I say thank you very much to Helen, to Susan, to Renata, to Rebecca, Bianca, and Paul for coming and giving evidence today. It really is reinforcing for us as a committee the real challenges faced by people and their families living with epilepsy. I said at the last hearing that we left our first hearing in no doubt that epilepsy is more than seizures. And I want you to know that we take our responsibility as a committee to take on board the evidence that you have given and to incorporate that into our recommendations really seriously. So thank you very much for taking the time. I'm embarrassed that I'm crying because I'm not living this like you are, but I really appreciate it, and I want you to know that the committee really values your time and your evidence, so thank you very much. Yeah, we might suspend just for 5 minutes while we swap over witnesses. Resume. And I now welcome representatives from Epilepsy Queensland. Thank you very much for appearing before the committee today. I understand that information on parliamentary privilege and the protection and obligation of witnesses giving evidence to Senate committee has been provided to you. For the purposes of the Hansard record, if you could each state your full name and the capacity in which you're appearing today, and I'll start on my left.
Leonie Hogarth, Head of Service Delivery for Epilepsy Queensland.
Sandra Rodiger, CEO of Epilepsy Queensland.
Thank you. I'm going to invite you to make a short opening statement and then we'll go to questions.
Thank you. Thank you, Chair, for the opportunity to appear before the committee today. Epilepsy Queensland's submission centred on the voices of our community, but there were many experiences it could not fully capture, like the regional Queenslander who lost their job after being told they could not be rostered on until they could predict when their next seizure would occur. Or the father whose family saw the toll epilepsy took on his well-being and the children he loved. He later took his own life. Or the teenage boy whose classmates repeatedly tried to provoke a seizure by hitting him on the head. Or the many families who've lost loved ones to epilepsy, telling us they wonder if greater awareness of the risks might have made a difference. These stories all point to the same truth. Epilepsy is more than just seizures, and it requires care beyond the clinic door. Epilepsy shapes whether people can work, learn, connect, and live safely. It's a whole-of-life condition that requires a whole-of-government response through a funded National Epilepsy Action Plan coordinated through Epilepsy Australia as the peak body. Clinical care will always be the foundation of epilepsy care. An optimal care pathway must establish nationally consistent pathways from first seizure through diagnosis, treatment, escalation, and post-clinical support. Around 50,000 Queenslanders live with epilepsy, yet in 2024, Queensland only had 128 neurologists and only a small portion of whom specialise in epilepsy. A national plan must respond to the workforce shortages that contribute to misdiagnosis, delayed diagnosis, regional inequity, and ultimately ongoing seizures. But if we stop at the clinic, we leave families to navigate the rest alone. And Leonie will now outline what this means in practice.
Our consultation has identified 4 broad priority areas. Firstly, support beyond a clinical diagnosis. Facilitated referrals to epilepsy organisations such as ours must be built into the care pathway so families are not left to navigate epilepsy alone. We provide the education, navigation and ongoing connection that clinical pathways alone cannot. Yet this post-clinical support remains undervalued and underfunded. After accessing our support, more than half report they are less likely to call an ambulance after a seizure as they felt more confident in managing the epilepsy safely. And our national peer support program, delivered by people with lived experience, provides connection and builds confidence, yet its current funding ends in December. Secondly, epilepsy care must address uncertainty, fear, safety risks and isolation. People with epilepsy are up to 5 times more likely to take their own life, and approximately 50% have anxiety and/or depression. Yet mental health care is often out of reach, especially for those with employment barriers. Funded counselling is needed to help families navigate a life-changing diagnosis. Thirdly, epilepsy must be recognised for increased practical support. When people lose their licence, they can lose their job, their independence, access to healthcare, education and community participation. Transport subsidy eligibility needs to be broadened. Ongoing seizures also affect functioning across all 6 NDIS domains, and drug-resistant epilepsy must be appropriately recognised so people are not left without support. Lastly, epilepsy understanding must be embedded across the systems that people rely on, including schools and childcare, where epilepsy education should be standard, as well as in primary healthcare, frontline services, employment, transport and community settings. We see the difference this makes when employers and community-facing organisations undertake our training, building inclusion and also preparedness for the 1 in 10 people who will experience a seizure. We see it when we provide training as standard onboarding for childcare centres and disability organisations who know that understanding goes beyond seizure first aid. In summary, seizures can be frightening, unpredictable and sometimes life-threatening, creating fear, uncertainty and constant vigilance. But the real impact continues after the seizure ends, and that is why a national plan must go beyond clinical care to address its whole-of-life impacts. Thank you.
Thank you. I'm going to go to Senator Askew, who's going to kick us off for questions.
Thank you, and thank you very much for your time, for your excellent submission, and also for the presentation, but thank you for coordinating this afternoon for us as well. It's been a pretty amazing afternoon of evidence, and as we've heard, there's lots of areas that we need to be focused on in regard to improvement in the area of epilepsy. So first of all, I'll return to the National Epilepsy Action Plan, which we have discussed it at our previous hearings with Epilepsy Australia, but I just want to understand from your perspective how you would see that would be delivering for people with epilepsy in Queensland, but also what would, what specific areas, I know we've just gone through the support beyond clinical diagnosis, transport subsidies and so on. What policies would we need to be looking at nationally, do you think, in regard to the treatment of and care for people with epilepsy? So what recommendations that we would be able to put into our report?
Sure. I think fundamentally it starts with the optimal care pathway. I think that there has to be standardised care pathways that includes the timeframes to treatment, from first seizure through treatment. Importantly, also the escalation pathways for drug-resistant epilepsy. But I also think that the post-clinical care has to be built into the optimal care pathway, and that includes, as we say, the referrals to support beyond that clinical diagnosis. What we hear all the time is that people get given a diagnosis, a script for medication, and basically the phrase of "we'll see you in 12 months." And that's the part that has to be embedded in the optimal care pathway around what happens beyond that diagnosis piece. But as we say, I think that epilepsy goes far beyond that clinical door, and I think there's opportunities and policy changes around education. I think that schools, childcare centres fundamentally should have epilepsy education built in as standard. But it's not just how to respond to a seizure event, because typically it's viewed as a convulsive seizure. And what we hear time and time again in our work is that people are misunderstood. The educators, they want to know more. They want to know how to support kids in school, and they want the best for their students, but they're not given that information and education to do it. But I think we're also missing an opportunity for early diagnosis. I think if we can provide greater training to the areas where people are under 5 is actually one of the highest diagnosis groups for epilepsy, and so if we've got educators who are trained to recognise signs, then there's opportunities for getting that clinical care earlier. I think fundamentally around transport as well, we hear all the time from people that either they can't do what they need to do because they don't have the transport that they need, but also that the transport is not a safe place. It's not understanding, and I think that again that's a missed opportunity where if education is provided, if there are things that are done to tell people that seizures don't necessarily look like what you see in the movies, some education and awareness around those different presentations, I think there's fundamental opportunities there. And I think similarly in workplaces. I think employment, we hear a lot about discrimination in employment. And again, it boils down to a fundamental lack of understanding. Asking somebody to predict a seizure so that you can be rostered on just points to the fact that there just isn't the understanding there. So certainly in education, employment, transport, and obviously healthcare, and then of course when it comes to disability care, drug-resistant epilepsy has significant functional impacts, significant across all 6 domains. And to think that because it's classed as a health condition, it's leaving people at risk and it's leaving people without support. And I think that that's an opportunity for change as well.
So areas of we've heard over the different lots of evidence that we've heard, the NDIS has come up a bit, but in what respect, where are the key challenges with gaining access to the NDIS that you've seen?
I think the access for the NDIS is particularly difficult with epilepsy for a few different reasons. So one, we hear from our members, they're often told epilepsy is medical. We don't fund medical. So they get a very black and white. Or we've heard situations where people have told us that the NDIS have responded in that you need to come back if you have more than 10 seizures, when trying to quantify it from that perspective in isolation and not looking at those functional impacts. So that's what we really want to try and help educate around and build that capacity of our community as well to, when they're navigating the NDIS, to learn how to speak that language. It shouldn't be another burden that they need to take on. It should be something that is better understood in terms of that functional impact. The cost of the functional impact assessments is often very prohibitive, and that's a key part of evidence that people need for their application. So that's another key issue. And certainly for the drug-resistant epilepsy community, really needing their own specific pathway, and whether that looks like a particular team or particular qualifications or skills, but really having a specific focus area for that as well.
Is there a challenge within the medical community even to get that understanding of what needs to be provided for the NDIS?
Absolutely. We've seen some of the evidence and some of the letters, and it is very medical, and it speaks very medical, and it's very short, and it doesn't speak to the functional impact. So that then creates additional burden and time and effort and costs of appointments and reports when perhaps they're not being created effectively.
So I think that's part of the policy direction I think we probably need to have a bit of a look into as well.
I think the NDIA planners, delegates, access team, they don't have a fundamental understanding of epilepsy. Can present so many different ways, so they see a diagnosis and it's just that doesn't qualify. So again, it comes down to that understanding and awareness, and we certainly help with access support letters for our community, and we can work with clinicians to do it. But it's still a challenge even when the letters are written in a way that talks to functional impacts. It still often just comes down to we don't fund medical.
Thanks for that. Just wanted to go back to something that you said, Ms Hogarth, regarding you can run training. So what sort of training do you provide? Is that something you provide just at Queensland, Epilepsy Queensland, or is it something that's a national program?
So we provide a few different options around training. So for families and individuals living with epilepsy, it's an opportunity to understand epilepsy a bit beyond that diagnosis, clinical, you have this, with your medication, we'll see you in 12 months. So really unpacking what does that look like in practice. So understanding seizures, understanding seizure first aid, thinking about that iceberg analogy where seizures are, potentially what we see, but everything else that fits underneath. What does that look like? Mental health, the employment, the impacts on education, the impacts on family, SUDEP. So an opportunity to talk through a lot of those opportunities. We run those face-to-face, online and webinar as well. So we have a whole range of ways that people can access the training. But importantly, we also deliver training to care organisations. So whether that's schools, whether that's disability organisations, workplaces. Unfortunately, I think one of the things that fundamentally would be great to look at how do we change this is that is often very reactionary. So often organisations will prioritise it if and when something is quite critical, rather than understanding the different presentations of seizures and epilepsy. So we touched earlier, Sandy touched earlier on the importance around education. School is such a fundamental, foundational, space for learning and growth. And so many times we've heard opportunities where people, or experiences where people have talked about that their child had absent seizures and they weren't hearing that information, they were labelled as lazy, not paying attention, but also a very different pathway or trajectory around behaviour. This is a child that never pays attention. This is a child that never follows my instructions. So a very different pathway for them as opposed to the medical diagnosis, exploring what else could be going on. Epilepsy, maybe, something else, maybe. It's just that opportunity to look at and identify that we need to look into this a little bit more.
And you can see the benefits, as you said earlier, of teachers and teachers' aides understanding that there are other options out there, that it could be not just being inattention or not listening, it could be a seizure. Absolutely. And picking it up earlier, so that does make sense. Just wanted to touch, first of all, before I go into that, paramedics, I noticed in your submission you were talking about even paramedics are struggling and actually recognising the situation. So is there some experience from that, or is it something that you just would prefer to be focusing on, actually upskilling their knowledge?
Oh no, it's certainly an area that we hear from our members around their experiences with first responders. Paramedics being one, police as well, in terms of how seizures can present with changes in cognition, behaviour, all of those other things that aren't necessarily always appreciated or understood to be seizure activity, and therefore, the implications around the justice system or whatnot. Similarly, with first responders, we've heard families say that they've had to tell the ambulance officers how to administer the emergency medication. So there is absolutely still some more work that needs to be done with first responders in understanding the different presentations of epilepsy and seizures, and then thinking about what those referral pathways may be. It's not always to emergency. We hear that time and again. For some, it can actually be a lot more harmful to have to go to emergency every time. And the cost of that on, health services and whatnot. So it's certainly an area that needs to be addressed.
And so are you actually taking action within Queensland to deal with, to talk to the state government about that at all, or just out of interest more than anything?
Yeah, it is something we are exploring.
Yeah,
it is something that we hear all the time from our community, as Leonie said. And again, I think it's an opportunity for us to make a difference. I think if it comes down to that awareness. If those seizures are understood as seizures, you've got that earlier possible opportunity to actually do something around treatment. But then on the other side of it as well, is I think that there's also a missed opportunity around referral pathways when people are interacting with emergency services. We often hear people might experience a seizure and go to ED, but then that seizure event's over and they go home and that's the end of it. Yeah. So I think there's opportunities both ways to enhance the care and support that people get.
So it's not only a Queensland problem, but I just thought I'd ask that question from a Queensland perspective. I'm from Tassie and I've got both police and paramedics in my family, so I'll ask that question as well when I get home.
Sure.
The other question I just want to touch on before I hand on is in regard to research. So what is there enough research being done into the experiences and ways that we can improve the services and the treatment for people living with epilepsy?
Our experience and what we're seeing on the ground is that there is research, but it's not necessarily being translated into everyday care. So, we hear of research projects all the time. The other thing that we're seeing a little bit of is that we're losing clinicians and researchers to overseas. And I'm not sure the reasons behind that. That's probably more of a question for the researchers. But I don't think that there is, considering the prevalence of epilepsy in the population, I think that more research is absolutely a good thing. More treatment options is a good thing. I wouldn't suggest that there is sufficient research in that space.
Yeah, I agree, and I think the research that comes our way and that we make sure that our members know about is quite ad hoc, and we don't always then get the practical implications of, okay, this is the research, this is the outcomes, but what does it actually look like and mean? How does this change someone's quality of life, safety, that sort of thing. So I think arguably more research needs to be done, to be honest.
Okay, that's good. We'll take that on. I'll just hand back to the chair because I'm conscious of time. Maybe you go.
I'll go to Senator Nandaraja, and if you've got more, I'm happy to cede my time if you do. Senator Nandaraja.
Well, thank you, Chair. Look, thank you so much for your testimony. I have so many questions, and we're not going to have time to go through all of them, but keen to just touch on a few areas. The first is around transport subsidies and transport. This is a time where I really wish this country had self-driving cars. I really wish we had it, particularly for communities in remote regional Australia. And perhaps, Chair, we could speak to the relevant department about what we're doing on that front in terms of regulation. But could you just talk us through the transport hurdles and what is currently available for patients as well as families?
Would you like me to? Yeah. conversing. Look, I think one of the first things to kind of name is transport is not a convenience issue. It's an enabler of work, of family life, of studying, of accessing appointments and community access, etc. So it's something that is foundational in the way that we are able to live our life and get out of our home. You know, that's a kind of a little bit of a side point, but we do know that a lot of our members are quite socially isolated, living behind closed doors. In terms of transport, it's certainly something that can turn individuals' and families' lives upside down. So whether it is someone's had a new diagnosis or a change in diagnosis, that can often mean we need to take your licence. So that immediate, depending on what the situation is, up to 12 months, that's life-changing. You know, how do families and parents get kids to 2 different schools and then there are after hours activities? How do I get to work? For regional and remote families and communities, that's amplified with the lack of transport options available, which often then has that flow-on effect around employment, education, mental health. You know, and not discounting the impact that the lack of transport has on people's mental health. Currently, the taxi subsidy scheme is very limited in terms of the criteria, so not many of our community are able to access the taxi subsidy scheme. And then we think about, okay, well, what else is there out there? So yes, there are public transport or community transport organisations, but again, for safety reasons, and many people will have provided stories of, you know, being robbed or attacked or, you know, being unsafe or their seizure presentation being handled really badly, that they're not able to catch public transport independently. Again, amplified by regional and remote, that those options just aren't there for a lot of people as well. So it is a significant issue for our community. I think one of the things that needs to happen is some greater subsidies around transport and looking at that criteria. So it's not just people aligned to NDIS access, but the broader epilepsy community as well that this impacts.
Yeah, thank you. With regards to workforce, can you just talk us through some of the workforce constraints? Now, it's not just a case of needing neurologists. We need neurologists with epilepsy expertise, often deep expertise, and bearing in mind that this is a spectrum, right? The presentations are different in pediatrics versus adult onset, you know, and it's got this bimodal presentation. So keen to understand, you know, your thinking there, and also we need scientists in neurodiagnostics, we need care navigators, we need nurse specialists. Where are the constraints? We need a workforce plan, frankly.
Yeah, absolutely. And I think part of the optimal care pathway planning needs to address the capacity and the capability side of the specialist workforce. We hear quite often from families that although they're seeing a neurologist, the neurologist doesn't specialise in epilepsy. So it really and truly it can sometimes lead to years of delayed effective treatment plans. And if we think of the health economics of that, you know, that has a long-term implication for Australia. There is definitely a shortage of epileptologists. There's not many epileptologists. My understanding is there isn't a standardised pathway for epileptologists either, but there is a general lack of epilepsy specialists in neurology. And then that also feeds through into clinical nurses as well. We hear quite often that the hospital systems are quite stretched when it comes to epilepsy nurse specialists and care navigators. And then that just keeps filtering through. I think it also has to include the primary healthcare though. It's another area that we hear of misdiagnosis quite a lot because often epilepsy is understood to be convulsive seizures. We hear especially from women whose symptoms are dismissed as anxiety quite often because it doesn't present as the typical convulsive seizure. So I think it's from every level of healthcare, right from primary healthcare all the way up to epileptologists. There's definitely a shortage and I guess more opportunity to understand epilepsy specifically.
On the topic of research that you touched upon earlier, I understand there's one Centre for Research Excellence funded by the NHMRC in Melbourne, and we did hear testimony from them from the Murdoch Children's, but it's focused on the DEEs. So again, very confined. Are you aware of any other CREs looking at epilepsy, or is this the only one? Because that's all I could find.
I'm not aware.
Okay, so there's obviously scope then for much greater, I guess, health workforce capability building through a CRE call at the minimum.
Yeah, definitely. And I think research is not my space, but from what I've understood is that often the research or medications are often focused on stopping the seizures rather than understanding the underlying cause of the seizures. That's what I've heard from talking to researchers and clinicians. So I think that that's probably another area to focus on.
My last question, just in regards to something practical, do people living with epilepsy wear a bracelet or some sort of alert? Is that or do they feel stigmatized by doing that? Or what's your recommendation?
Yeah, look, that certainly comes up in a lot of conversations with us and amongst peers as well, like through the peer support activities and workshops and whatnot. It's a very individual choice. Some people say, I would not leave home without it, and they have multiple layers of visual. We've got people that have tattooed, so it's permanent, you know. Others talk about apps and smartphones and whatnot. Others are like, no way, I don't want anything that's identifiable in terms of how they are potentially treated and the impacts of that on their well-being and their safety. So yeah, we've heard very polar opposite views on that, but yeah, there are options out there. But again, it's one of those things around assistive tech. People don't know what they don't know as well. So more information around what is out there and how to support individuals. And I think that's a key part of where our organisation comes in to help bridge the gap between the clinical care and the everyday life. What does it look like in practice? And where are those challenges that people are facing? You know, we're seeing a lot more complexity in the calls that we receive as well. You know, the interface with whether it's domestic violence, whether it's the cost of living, cost of medications. I need to weigh up, am I going to have my medications this month? Am I going to be able to put food on the table? So there's certainly many impacts. Sorry, I went on a bit of a tangent there. Sorry about that.
Perfect. Perfect. People with drug-resistant epilepsy obviously have very limited therapeutic options. How I mean, in this scenario, we often will try and enroll people into clinical trials, right? Just to see if there's anything that can be offered. Is that something that you see with your client base who have DRE? Are they being actively recruited or offered clinical trials, or is it just so hard to navigate and find?
It's something we talk to our members about, and it's quite interesting that some families are well aware of it, yep, we're already participating, others not so much. And then when we ask as well, when we hear in terms of presentations, have they had genetic testing? Because we know particular genes could then influence targeted medications or treatment options, and that hasn't always been discussed with individuals either. So I think there's more perhaps education with GPs as well as neurologists in terms of knowing what the treatment pathways are, including the flow-on effect to organisations such as ours. However, also looking at that medical clinical pathway as well.
And my final question, could you just talk us through what seizure first aid is?
Yeah, so seizure first aid is much more than you get in your senior first aid, and that is a problem we often hear in that people will say, oh well, I've got my senior first aid. Seizure first aid is, and epilepsy and seizures are often just a footnote almost in the entirety of that program, and sometimes still quite outdated terminology and language. Seizure first aid is more about building the confidence and capability of people to be able to recognise and respond to seizures. So it's not just about the convulsive seizures and really breaking down those assumptions, because we know many in the community still believe that epilepsy is convulsive seizures, epilepsy is flashing lights, and that's about it. So, you know, we certainly have a long way to go in terms of our awareness campaigns, but beyond that, education and understanding. I think that's critical. But I think seizure first aid, for me, is all about building that confidence and that capability for recognising and then responding to different types of seizures and in different environments, whether it's in water, whether that's at home, whether that's at daycare or disability day programs, etc.
And I keep saying this, my last question is really, again, relating to employment services. Have you engaged with the unions on how they can have a role in advocating for, you know, these young people who are desperately keen to participate and to lead as normal a life as possible and contribute, and are clearly coming up against terrible discrimination, employment discrimination and other barriers? I mean, there is a role for unions here. They're very, very good at advocating for marginalised groups of people. What are your thoughts?
I think unions are definitely one stakeholder, but I wonder if it's much earlier in the process, particularly around building individual confidence and capability about when to disclose, how to disclose. So that's one part of it. Another part is those employment organisations themselves who do have some funding and resources around training, reasonable adjustments, working with employers, funding incentives. So it's that partnership approach, I think, because as you mentioned and as we've heard before, that there are many people living with epilepsy who want to work. And the flow-on effects of not being able to work, again, financial stress, family stress, mental health. So it's certainly something that people in our community generally want to do. We've seen, some really terrible experiences of people having a seizure and being told that despite their medical clearance, they can't return to work. Another staff member who wanted to return to work, but was told it'd be too traumatic for others. But then if we look at it from the flip side, we've also seen some really good things that do work. We have a gentleman that we support who was driving the trucks in the mines. He is no longer able to do that with his diagnosis, but his workplace has been fantastic and found another role within the organisation. So pivoting, to a different job and roles and responsibilities, and he's very happy with that. Similarly, another lady we work with, that her workplace has shown great collaboration in wanting to understand how does this impact you. So then they have put in a whole heap of reasonable adjustments. So looking at how she uses her time and energy, what apps or technology could help her do her job. Let's look at work from home flexibility. Let's look at workplace understanding. Do we need some education here for leadership, colleagues, peers? So there are some really great things happening in the employment space, and we need to find those gems and learn from them and look at how do we replicate those models, because unfortunately we also hear a lot of discrimination and a lot of issue when it comes to working.
Yeah, okay. We'll leave it there. Thank you, Chair. Thank you so much.
Thanks very much, Senator Nandaraja. I'm conscious of time, but I noted when it was either your opening remarks or in your answers to a question, you talked about a program whose funding was going to run out soon. Can you just remind me of what that program was and what it does and what that funding running out will mean?
Yeah, of course. So that's our national peer support program. So peer support is fundamental for people being able to connect with each other. We've often heard people say, I found my tribe, I found people who get it. But it's those ongoing connection, that information sharing, that navigating, did you know about Ryan's Rule? Did you know that this is, how you might be able to? So all of that information and confidence and capacity building that comes with meeting and sharing those experiences. So that funding does finish in December this year.
And what was the source of the funding in the first place? Was it a particular grant program?
Yeah, that particular one is the NDIA peer support and capacity building program. So at the moment, our program reaches around 500 people. We've got 20 odd lived experience facilitators, and we've got people participating across all states and territories. So the way we can do that through online, through chat, through some face-to-face, depending on demand. So we'll have a significant impact on our community.
And how long was the funding for, and how much was it?
It was for 2 years.
2 years, yeah.
Who was the recipient of the funding? Is it
Epilepsy Queensland
so it was your,
to deliver the national
yeah.
with a number of state-based partners.
Yeah.
Collaboration, yeah.
Could you take on notice how much that was for and just get back to us?
Yeah, there's also another more informal peer support program that we run where the funding is also finishing in December. This is a regionally based program where we've got a staff member based in North Queensland in Townsville, and it's focused on youth mental health. And we are really seeing, I mean, we know that being on the ground makes a difference. We know that being face-to-face and giving people the opportunity to connect is important, especially for regional Queenslanders, because only being able to connect online doesn't work. But it's focused on youth mental health, and whilst it's not a formal peer support program, it is around building peer support connections for for youth with mental health in Townsville, and that program's funding is also coming to an end.
And what was the source of the funding? For that
Queensland
program?
Mental Health Commission.
Okay. And how long was it for?
18 months.
Okay. And is there a reapplication process, or it's just they had it and now it's finishing?
Yeah, not for that particular one.
And with the National Peer Support Program, is that a case of there's the opportunity to apply for funding again, or it's just they ran it for 2 years and that's
originally the application process was 2 years with the possibility of a 1-year extension. We haven't heard anything about that 1-year extension, and the department released a grant round which closed on the 2nd of July, I think, for funding, but that would leave a 6-month gap. So even if we were successful in that grant application, there's 6 months where there's no funding, which means that that program will come to a standstill.
And was that applied for by Epilepsy Queensland to then roll out nationally, or was it a joint application process with other state?
It's applied by Epilepsy Queensland, but we work in partnership to deliver it with other states. So we've got staff based in Epilepsy Queensland who work on it, but we've also got staff, other state-based organisations have staff who also work on that program. So it's very much a collaborative model, but we're the grant holders.
Right. And one more financial technical type question, and excuse me for my naivety because I should know the answer to this question, but what is the source of funding for Epilepsy Queensland?
A variety of sources. So we get a small amount of recurrent state funding, which funds some of our core education programs. As we've mentioned, we've got these 2 time-limited grants, and the rest of it is our own source funding. So we do fee-for-service, the training that Leonie mentioned in childcare centres, schools, etc., disability organisations, and then we spend a large amount of time fundraising.
Yeah.
So unfortunately, resources do get chewed up by constantly needing to fundraise, and what we find is that particularly with the time-limited grants, we lose good staff.
Yeah.
And epilepsy is a complex condition, and so to train people and to make sure that we've got the team, because we run a multidisciplinary type approach to our service delivery, we don't have a nurse-led model. But that takes time to build up that expertise, and so when these funding grants come to an end, we lose good staff, and then if we're successful in another grant round, then we've got to find more staff and train them.
I know there was a view, and I only know this through my experience with MND Queensland, who gets no state government recurrent funding at all, but they were told that, you know, it's going to be taken care of by the neuro clinics that the government is setting up that are supposed to deal with everyone, whether they've got multiple sclerosis, MND, notwithstanding that everyone's needs are very different. Has that impacted Epilepsy Queensland at all, or have you sort of been left out of that and you're still getting separate?
So Epilepsy Queensland is a member of the Neurological Alliance of Queensland, which has formed probably about 18 months ago as a result of the state government commitment to neurohealth. That is, there's no funding attached to that, so the tenders have been released for the neuro hubs. We are, at this point, we're not going to tender for those hubs. for a whole bunch of reasons around what their commitment was originally aligned to and versus our service model and our internal capacity. But we are a member of the Neurological Alliance, so we work collaboratively with the other neurological organisations, and as the hubs roll out, we will more than likely have a role and a presence where we can, you know, run face-to-face sessions and things like that. So it's not that it's not going to be something that we'll participate in, but from a funding model, we're not going to get involved in it. I think it's also important to realise, though, that those hubs were not to fund service delivery. Those hubs are very much to be a place where service delivery can operate from.
Okay.
And so organisations would need to, such as ours, we'd have to have our own funded service delivery anyway to operate from those hubs.
Thank you, that's really helpful. I'm conscious of time, so we're already 10 minutes over. So if nobody else has any... No, you're good? Okay. Look, can I say thank you very much for coming and giving evidence today. I'm really glad that we were able to get you in front of the committee. Just to let people know that we are travelling around the country. We've got hearings next in Melbourne and Launceston where we'll be hearing from people, and we're investigating. We're also going to Adelaide and Alice Springs and potentially over to the west. So this isn't the last hearing that we will have, and we're looking to have lived experience evidence everywhere we go. And so we will have a broad base of evidence before we come time to write our report. So thank you very much, both to Epilepsy Queensland and everyone else who's been here today to give evidence. And there's words I'm supposed to say, so I better say those. So thank you for your evidence today. The committee will report to the Senate on the 10th of September 2026. We've agreed that responses to questions on notice should be provided by close of business on Monday the 10th of August. So just that funding question, if you could get that to us by then, that would be great. That concludes today's hearing. Thank you to all the witnesses who appeared and to Hansard and Broadcasting for their assistance, and as always, thank you to the Secretariat. I have to say this again, the committee will report to the Senate on the 10th of September 2026 and has agreed that responses to questions on notice should be provided by close of business on Monday 10th of August, and the committee stands adjourned. Thanks very much.